very warm good morning to all. We, IAP Vadagara, wholeheartedly welcome all to the PED GASTROCON Kerala 2024, fixing the annual conference of Pediatric Gastroenterology Chapter, IAP Kerala. We will be moving on to our first session, which is a case scenario-based session. How do I approach? The first speaker is Dr. Maya Pidambaran, Senior Consultant, Pediatric Gastroenterologist and Hepatologist of VPS Lakeshore Hospital, Kochi, chaired by Dr. Prashant Pavitran, Vice President, IAP Kerala.
Good morning to all. Shall I share my slides?
Good morning. Good morning to all. We are having the first talk of the day of PED GASTROCON Vadagara, the Pediatric Gastroenterology Chapter Conference of IAP Kerala here. And our first speaker is Dr. Maya Pithambaran. He's a session, is a case scenario-based session. The first session of 3 talks, and the first session is a case scenario-based session and how to approach. And the topic is a 7-year-old child with chronic abdominal pain and school absenteeism. Abdominal pain is a common symptom that can result from a wide range of conditions. It can vary in intensity, location, and nature, from mild and temporary to severe and chronic abdominal pain. The topic is a 7-year-old girl with chronic abdominal pain and school absenteeism. Dr. Maya Pithambaran, Senior Pediatric Gastroenterology Consultant of Lakeshore Hospital, Kochi, is the speaker. Over to Dr. Maya.
I've shared my slides. I hope they're visible.
Yes.
Are my slides? Sure. So shall I start off?
Yes.
For permission.
Yes.
Good morning to all. At this outset, I thank my chairperson. I thank IAP Vadagara for giving us this opportunity. And it's very unfortunate we couldn't come there and make it in person, but I'm sure we'll all make the best use of the present situation. And I'm glad to be the opening batsman of this academic fiesta. In these challenging times, I would also like to send my prayers and thoughts for the people of Wayanad. May they find strength and resilience during this challenging times ahead. Now, moving back to my topic, chronic abdominal pain in a 7-year-old child who has school absenteeism. I'm sure this is the problem all of us have come across as a challenge.
BJP സംസ്ഥാന പ്രസിഡന്റ് ഇത് സംബന്ധിച്ച് കേന്ദ്ര ആരോഗ്യ മന്ത്രാലയം JP നന്ദനോട് നേരിട്ട് അഭ്യർത്ഥിക്കുകയും നിവേദനം നൽകുകയും ചെയ്തിരുന്നു. കേരളത്തിൽ പരീക്ഷാ സെന്റർ അനുവദിക്കുമെന്ന് ഉറപ്പ് നൽകിയ അദ്ദേഹം ഓഗസ്റ്റ് 5-ന് പ്രഖ്യാപിക്കാമെന്ന് അറിയിച്ചിരുന്നതായി.
Maya, you are muted.
You can continue, madam. Dr. Maya.
You are muted, Maya.
Yeah.
You can continue. Your slide, you can just change.
So this is a very, very common challenge, which all of us face in our day-to-day practice.
Okay.
So I would start with the definition of chronic abdominal pain. What is a chronic abdominal pain? Intermittent or a constant pain when it lasts for a minimum of 2 months, we call it chronic abdominal pain. 75% of this is functional, but we also have a 20% which is organic and a 5% which is psychogenic. Around up to 10 to 15% of children in this age group experience this pain at some point or the other, which explains or it gives us the gravity of the situation which we are going to deal with. So these are some of the common scenarios we come across in our day-to-day life. One, this is a 7-year-old girl. She complains of pain. This pain is epigastric pain. The pain worsens after food intake. The pain lasts for around 15 to 20 minutes. She also has vomiting, and off late she also noticed some blood streaks. Now, in examination, she's otherwise sleeping well. Clinically, she's well. So, is this a functional pain? Is this an organic pain? This is something we need to decipher and decide on how further we need to evaluate. Now, look at this child. This is another 7-year-old child. He sleeps well, he eats well, but 7 a.m. he says he has got pain. He doesn't want to go to his class. He's okay dealing with mobiles. He is eating well in the evenings. He's happy. But he passes stools once in alternate days. His mother says that's fine. He's always been like that. Now, is this functional pain? On looking at this, on clinical examination, he's absolutely normal. Look at this child. This is another 7-year-old child. He sleeps well, wakes up at 7 o'clock. He passes stools. His stools are a little soft, semi-solid. Sometimes mucus is there. Again, 8:30 when the bus comes, he doesn't want to go to school. There is a family history of IBD in his family, and also his mother has IBS. So the parents are worried, is this functional pain? Is this organic pain? How much should we evaluate these children? Now, if you take the Rome criteria, what is functional pain? Functional or non-organic chronic abdominal pain when there's a pain in the absence of an identifiable anatomical, biochemical, metabolic, inflammatory, immunological disorder. Now, functional pain as per the Rome 4 criteria, it's not just the absence of this. If you see, pain where after appropriate medical evaluation, the word is very important because at this point, as per the Rome 4, the onus on us clinicians to decide on this appropriate medical evaluation. It's not like we need to exclude all the conditions under the sun before we say, okay, this is functional pain. So that is where we as clinicians need to draw the line. So this is the general classification of the Rome 4 criteria for the functional abdominal pain. On one end, we have functional dyspepsia, we have abdominal migraine, we have irritable bowel syndrome, and we have the garden variety of functional abdominal pain, which is not otherwise specified. Now, how do you approach a functional abdominal pain? A detailed history and physical examination, as we all know, is the most important thing and the crux to differentiate between organic and functional pain. Remember that limited investigations only need to be done if you suspect functional pain, and more time and patience is needed when we deal with these children. Now, in the history, what are the things we specifically look for? Ask for the history from the parents, the child, the history related to the pain, history of associated symptoms, like that child had dyspepsia, about constipation or his bowel habits, his diet habits, his lifestyle, his school, his teachers, his friends, his extracurricular activities. It would take some time. Sometimes we may want to take help, especially if you're a busy pediatrician. Examination, yes, looking at the height, weight, his growth, general examination, abdominal examinations. Note the body language, note the family dynamics, which may sometimes give you a clue. So differentiating an organic pain from a functional pain is not easy because we don't have definite criteria or a single investigation which is going to tell us that, okay, this is functional, this is organic. So that's when we take the help of some of these red flag signs or some of the characteristics of the pain, which would help us to help us to differentiate between a functional and an organic pain. And one of these which I have found very, very useful in my clinical practice is the night awakening symptoms. If the child wakes up from the sleep and says, okay, I am having pain, that's something to be worried about. If the child says there's a pain radiating to the back, shoulder, McBurney's point, okay, those are things which will give us a clue, okay, this is not a functional pain, but the child is leaning forward, hunching, that is to relieve the pain. Again, that is less likely to be a functional pain. The pain lasting longer than 2 hours, deep pain, all these are telling us this is likely to be an organic pain. What about functional pain? They are paroxysmal pain, periumbilical, epigastric, or lower abdomen, more or less they are in the midline. If there's on the sides, it is more likely to be an organic pain. If it is a shorter pain, the pain does not wake the child in the night. The child may sit late and say at 12 o'clock, I have pain, but that's not functional pain. That's not organic pain. Now, there are these red flag signs which will alert us. Now, if a very, very young child who says, I have pain, we need to be worried. If there is weight loss, there is fever, joint pain, rash, there is a growth delay, there is delayed puberty, there is genitourinary symptom, bleeding, dysphagia, clinical examination, there's pallor, icterus, there's a localized tenderness, there's a mass, there's an organomegaly, there's arthritis. Perianal disease is something many times we tend to overlook, and we should always specifically ask for these perianal symptoms because they may give you a clue to Crohn's disease. Stool or gallbladder, if you on evaluation you find that inflammatory markers are elevated or hypoalbuminemia, those are the red flag signs which should alert us and think, okay, this is not just a functional pain, this is an organic pain. Again, the analysis of the pain, if you see, you can see if the pain is in the epigastrium or in the periumbilical. As per the Epley's law, we know that if it is around the umbilicus, it's more likely to be a functional, but still, if it's on the sides, it is less likely to be a functional pain. So if you take the symptom analysis of epigastric pain, yes, it is very high likely to be a functional pain, but it does not mean it's always functional. It could be GERD, it could be a peptic ulcer disease. If you have a periumbilical pain, it's high chance that it is more than 85% chance it is functional, but it could still be a small bowel involvement. It could be an intestinal tuberculosis, IBD, lymphoma, etc. Again, lower abdominal pain, it is possible 75% of these, especially in the midline, they are functional, but it could still be any of these organic pathologies. So it is after the end of these clinical examination, the history, at the end of this, we should be able to decide, okay, is this functional and is this organic? Now, once you have decided, that's when you can go ahead with the investigations. And if you think that this is just a functional pain, maybe a level in 1 investigation would be good enough. So a blood picture, a CRP is something which I've always found good, useful in my clinical practice. A urine or a stool routine may help. And ultrasound abdomen, many times we do, but it's not for anything else but for reassuring the parents. And if you don't find any of these red flag signs, the chance that you're going to get a positive ultrasound is less than 1%. However, you may get an ultrasound report with a mesenteric lymph nodes or gallstones, and then again, you need to explain to them. And I'm not going into those details because we have a panel on this. Now, level 2 is when you are actually suspecting an organic pathology. Like, for example, you have an epigastric pain, you may want to do an upper GI endoscopy. If you have a left lower quadrant pain and you're suspecting IBD, you might want to do a fecal calprotectin or colonoscopy. Small bowel pathology or hepatobiliary, you may want to do a CT or an MRI. And level 3 is only very, very rarely we do like EEG or an MRI angiogram or a CT or a urine porphyrin. So how do we go about when a child comes to you? So you have a child or an adolescent who has presented with an abdominal pain with a history and a physical examination. There are no alarm signs. We're not worried. So, or if there, then you can think it's possibly a functional pain. Now, if there are alarm signs or something which is worrying, then you need to think there's an organic and you may want to do an endoscopy or an ultrasound or any of those according to your findings. If it's a functional pain, the patient has an epigastric pain, postprandial fullness, early satiety, it's possible that this child has having a functional dyspepsia. This pain is associated with change in bowel movements as constipation. It may be either a functional constipation or it may be an irritable bowel syndrome. You have paroxysmal episodes which may be associated with headache, photophobia, nausea, vomiting, like this typical abdominal migraine symptoms, then it could be abdominal migraine. If it does not fit into any of this, then or enough insufficient criteria for any of this, then you can put them as a garden variety of FAP, NOS, where you have a functional abdomen pain, not otherwise specified. Now, so look at our child. Now, each one of these scenarios, look at this first scenario. This child, she has epigastric pain. This child has nausea and vomiting. This child also noted to have streaks of blood in the vomiting. So here I'm worried because there was blood. It could be a peptic ulcer disease or it could be a GERD. So along with the level 1 investigation, I would want to do an endoscopy. In this second child, this child has no alarm signs. This child is a bit constipated, but if you see, this is more or less typically a functional pain. You have periumbilical pain plus minus constipation, so it may be a FAP, NOS, or a functional constipation. For him, I would only do a level 1 investigation. This child, there is a 7-year-old child where you have a lower abdominal pain, but this child also has some semi-solid stools, some mucus in the stools, families of IBD. So here I'm not very sure. Is it functional? Is it organic? So at this point, I may do a level 1 investigation, but on follow, because things are not very black and white. It's just gray sometimes. So sometimes you may have to take that call later. Maybe in a few clinical visits, I might want, if he's not improving, I might want to do a colonoscopy. So this is how once we have differentiated, okay, this is organic pain, you go for an appropriate treatment. This is functional pain. Now what are we going to do? How are we going to do this huge chunk of functional abdominal pain? How are we going to manage? Now, before we go into management, just two slides on the pathophysiology of functional abdominal pain. The basic concept is, it's not just there is an enteric nervous system, which we call as a little brain or the gut brain. And there is always continuous bidirectional connection between the central nervous system and the enteral nervous system. And a dysregulation or a disruption of this brain-gut communication plays an important role in the pathogenesis of functional abdominal pain. So look at the small physiological stimuli, meal, gut distension, all of them in patients who have a disrupted brain-gut axis, there will be associated visceral hyperalgesia, abnormal gut mobility. So there is actually an increased perception or an amplified response to all this, and the pain gates are left open, and small stimuluses are actually amplified and perceived as pain by the child. Now, this is a new concept where we talked about the brain-gut axis. Now, there is a new concept where it's called the microbiota and the gut-brain axis. So that means the microbiota inside our gut is also playing an important role, either directly when there is a breach in the disruption of the integrity of this is structural integrity. There is the products by the bacteria, the microbiota, is a short chain fatty acids and GABA, 5-HT, all that may have a direct effect on the enteric nervous system or the central nervous system, and it would lead on, and the dysregulation of this is also significantly involved in the pathogenesis of functional abdominal pain. So this is what I said, small events anytime in the life of the child, dysbiosis, early use of antibiotics, family stress, parenting problems, all of them will cause a vulnerability of the microbiota gut axis. There is a central sensitization, there's visceral hypersensitivity and dysmotility, and the child would develop functional abdominal pain. So what did we learn from here? Here, the pain is genuine. Never accuse the child of malingering. And functional abdominal pain is a positive diagnosis. It's not a diagnosis of exclusion. And this is not a psychiatric problem. Now, so the goals of our therapy are to break the cycle of stress and pain. It is not about to completely relieve the pain. Our aim or the goal is to get the child back to his normal lifestyle, and counseling the parents and child are the cornerstone of this therapy. The reassurance we give, the advices we provide is what will help the child return back to his normal life. So the first thing to start with is counseling the parents. What we need to tell them is we need to understand them, that we need to get the confidence, we need to tell them that we are here to support them, and we need to explain to them the concept of brain-gut axis. And in a simple way, what we say is it is like a headache within the abdomen when you are stressed. And we need to give them that reassurance or unequivocal statement that this is not an organic problem, and we should be remembering to avoid repeated investigations and ambiguity. So the advice to the parent would be to return the child to the school as early as possible. That will be avoid or engage him in extracurricular activities. No rewards for his pain is allowed. Distraction techniques or no attention during the pain, and timeout procedures, like especially if he throws a tantrum, that would be helpful. Now, there are other therapies beyond the counseling. So this is most of in your clinical practice, I'm sure all of you would have experienced that. You give them that reassurance, you give them that confidence, the word from you that, okay, this is definitely not an organic problem, is good enough to many times solve the situations. There are other pharmacological therapies which we may want to resort to in patients who are not responding to these the counseling and reassurance. There are many drugs in the market. We're starting with antispasmodics like peppermint, rotavirine, mepevirine. You would have seen all that in your market. Tricyclic antidepressants may be helpful in anxiety situations, but all of them have, especially antispasmodic, insufficient information for recommendation. Then also other drugs like antibiotics, ciproheptadine,
Yes.
results. Then sometimes they're also like if you have a particular symptom, you can deal with that symptom. Like you have an epigastric pain, you can give a trial of PPA. The child has constipation, you can give a trial of laxatives. Patients who have migraine, like especially those who have abdominal migraine, you can try flunarizine. Now, what is the role of diet and abdominal pain in functional abdominal pain? If you have, first thing is there a role of milk? There are multiple studies which have shown that no evidence for the role of milk exclusion in these children. Gluten, there is no gluten avoidance cannot be recommended. The only thing is FODMAPs. FODMAPs have come up recently in a big way, where you have fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. There's one study in children which have shown that in 19% of the children, there was at least a 75% reduction of their symptoms if you keep the FODMAP levels less than 3 grams per day. And then about fiber. If the child has a constipation, fiber supplementation has been shown to be helpful. What about probiotics? There are a humpty number of probiotics in the market, but at this point of time, from around 15 studies, around more than 1,000 children, we have found that at present there is no probiotic which presently probiotics cannot be said as an only answer for functional abdominal pain in children. Now, there is also, apart from the counseling, the pharmacological, there are also some other methods like the cognitive behavioral therapy and hypnotherapy. Cognitive behavioral therapy, where you stop the negative thoughts, replacing them with positive ones, distracting oneself when the pain arises, imagination to encourage the child about pleasant things, and so on. It has been shown to have benefits in the short and long-term benefits. Hypnotherapy, which I have not tried any point of time, but it has also shown some short and long-term therapy in children who have this functional abdominal pain. Now, if you ask me what has happened to all these children, or have you ever thought about what happens to all these children over the years whom we have labeled as functional abdominal pain? If there is a long-term study where there have been around more than 100 children who had functional abdominal pain, who've been followed up for a period of 15 years. And what did they find? They found that around up to 30 to 50% of children resolve in 2 to 6 weeks, and up to 70% of children resolve by 5 years. But however, around 30% of children, they didn't respond well. And as they grow into adulthood, they continue to have, at least among the 30%, around 30% of them actually had multiple issues, chronic migraine, back pain, and chronic problems in 30% of those patients. In the 30% of those who didn't have response, out of that, around 30% didn't do well even in their adulthood. They tend to have more chronic problems. So to conclude, chronic abdominal pain is a common problem in pediatrics, and functional abdominal pain is an important subset of chronic abdominal pain. Symptom-based analysis is a cornerstone in these or the approach in these patients. It is very important to pick out or differentiate between the functional versus the organic pain, and so that we can decide, or we can draw a line on the investigations we proceed to do. And limited investigations only need to be done in children whom we suspect to have functional abdominal pain. And it's also important for management to understand the pathophysiology of this brain, of this functional abdominal pain syndromes, where you have the brain, gut, and the microbiota axis. And counseling and reassuring has always played a major role in management of these children with chronic abdominal pain. Thank you.
Thank you, madam. Nice presentation. Dr. Maya's Dr. Maya talked about the functional abdominal pain and organic pain, the differentials, and also the Crohn's disease that we shouldn't miss, and also the importance of also H. pylori, also she's mentioned, and also the case scenarios, and also psychological causes, which is like important. And most of the time, we'll end up doing investigations, and she's told restrict investigations, and also the psychology is extracurricular activities is very important in these times of thank you, madam. Thank you very much.
Thank you,
for the
Dr.
nice
Maya.
presentation. I have one more questions, one or two questions can be taken.
Hello, it was a wonderful presentation. One question regarding the abdominal ultrasound. Everybody asks this question, I know. Still, that problem of mesenteric adenitis. The patient will come to you and tell you that my child is having some mesenteric adenitis as suggested by the radiologist and all. So how to answer to that question and how to manage?
I'll give a very quick answer to this because we have a whole panel discussion on mesenteric adenitis and gallstones, which I instantly picked up. So what I use this is I look into the detailed description of the lymph nodes. The diagnosis will be mesenteric lymph nodes, but you go back and see, okay, what have they described? In general, there is a long, because these nodes are oval, there will be a long axis and a short axis. What is recommended is to take the short axis measurement. So it would be like 10 by 5 mm, something like that. So the 5 mm is a short axis. And that is what, if the short axis is bigger, more than 1 centimeter, or you have a clumped nodes, or you have a conglomerate nodes, that's when you think that is significant. Now, this mesenteric nodes alone also we should not take into consideration. We should also look at the general condition of the patient, the inflammatory markers, the counts, all that. Putting it together it could be is this like a tubercular underlying pathology. It could be a Crohn's or something which we need to further evaluate. Otherwise, many times a firm reassurance from you is good enough. And I always say, look at the nodes in your neck. If you have nodes in your neck, you would also have these children and a lymphoid proliferative phase. You would also have nodes in your abdomen, and just don't worry about it, is what we tell them. It's all how we reassure them.
Okay, madam. Thank you, madam.
May I request
We
Dr.
close
Vijayakumar,
the
sir?
session, and
May I request Dr. Vijayakumar, sir, Head of Department Pediatrics, Calicut Medical College, to hand over the memento to Dr. Prashant Pavitran, sir, Vice President, IAP Kerala. Thank you, Dr. Vijayakumar. Thank you, Dr. Prashant. Now we will move on to our next session. And the next case is an 8-year-old boy with jaundice and prolonged prothrombin time. I invite the speaker, Dr. Jagdish Menon, consultant pediatric gastroenterologist and hepatologist, Dr. Reliance Institute Medical Center, Chennai. I invite Dr. Hamid, sir, senior pediatrician, Vadagara, to chair the session. Thank you. Thank you, Dr. Hamid. Thank you, Dr. Jagdish.
Good morning. Jaundice and prothrombin, prolongation of prothrombin. This is our subject to discuss today. For jaundice is a common problem we are meeting in our day-to-day practice, and importance of prothrombin time is, it is a most prothrombin time is a most important parameter to assess the severity of the injury of the liver. To discuss about this, we have Dr. Jagadish Menon, consultant pediatric gastroenterologist, hepatologist, physician at Relay Institute and Medical Center, Chennai. He did his MBBS at Government Medical College, Calicut, 2004. MD Pediatrics, JIPMER. DM in Pediatric Gastroenterology and Hepatology at JIPMER. And he is the first pediatric hepatologist and liver transplant trained at International Liver Transplantation Society, and he published various papers nationally and internationally. Over to Dr. Jagadish.
Thank you, sir. Good morning, respected seniors and colleagues. First of all, my sincere thanks to IAP Vadagara for giving me this opportunity. So let's kickstart with this 8-year-old child who has deranged prothrombin time and jaundice. So first of all, when we talk about jaundice, I think jaundice could be either a hemolytic jaundice or it could be a jaundice which originates from the liver, which could be either a cholestatic or a hepatic jaundice. And when you have an increased PT, I think then we have around 3 possibilities. One, it could be a genetic defect in synthesis of factors, coagulation factor, which increase to this thing. For example, hemophilia. Then it could be secondary to vitamin K defect. Child is on warfarin, or sometimes when you have frank sepsis, you may have DIC, which leads to an increased PT. And the last scenario, which probably we would be discussing in this session, the organ synthesis issue. And we know that these factors are exclusively synthesized in the liver. So this point out to an organ which is involved, that is liver, in fact. So we'll be talking about different scenarios. So let's go to our first MBBS session. I think probably in Guyton, Ganong, wherever it is, the coagulation pathway is clearly given. The PT actually speaks of the extrinsic pathway. It is a bypass to the factor 10, which actually tipples down the coagulation cascade. So whenever you have a vitamin K defect, I think that point I would like to emphasize, because when you have a vitamin K defect, then these factors, in fact, of both intrinsic and extrinsic pathway can be defective, and that can actually show a false positive PT or INR, deranged INR, which is actually a ratio of PT by a standard PT, prothrombin time. So why we are emphasizing about prothrombin time here? Because we know that factor 7 has the shortest half-life, so that actually helps in detecting it early and managing the patient early. 2 aspects why we are using this thing. So commonest cause of an increased prothrombin time is actually a vitamin K defect and liver disease. It is not hemophilia. And obviously we need to ask the patient whether the patient is taking a warfarin. So the case scenario will depend on the duration of the jaundice, any associated symptoms, or the patient is sick or unsick, which includes the ABC, neurology, etc. So this is a scenario 1 of 2 kids. One is an 8-year-old boy, 8-day short duration jaundice, no other symptoms, liver is palpable, spleen is not palpable, sensorium is fine, and the bilirubin is 9, and the enzymes are in 1500 and 1700. There is another girl who is approximately 8 years, previously well again, short duration jaundice, a bit irritable, liver is palpable, bili is slightly higher than the previous one, but the enzymes are actually in 10,000 and 7,000. So what is this clinical condition, and which patient are you worried about? In fact, when we see the mathematical figures there, we will obviously be worried about the child who is coming the second. But when we look into the coagulation parameters, when we look at the PT and INR, it is high for the patient who is A rather than B. So obviously we are worried about the patient who is on A rather than B, in fact. So for the second child, the INR is perfectly fine. So I'll explain why this is important. What is the next step? We give a vitamin K because we need to see whether it's this liver problem or it is secondary to a vitamin K defect. Many patients would have been taken some antibiotics from outside also when they have non-specific prodromal symptoms like fever and other things. So whenever we give antibiotics, the gut flora is totally gone and the gut is sterile, the vitamin K synthesis is less, so vitamin K deficiency can happen. And when we define a liver-based coagulopathy, it is always after correction of vitamin K, ideally after 6 hours, as early as 2 hours. So that is how you define it. So that is why. So that is why the pediatric acute liver failure group has defined acute liver failure based on the prothrombin time of more than 20 seconds and INR more than 2 with or without the child having a clinical HE. There is biochemical evidence of acute liver injury and no evidence of chronic liver disease. We know that hepatic encephalopathy in children is an extremely non-specific sign. Why I say this? Because a child would have been cannulated multiple times outside, the child would be irritable, but the INR will be perfectly fine. And then we cannot call that the child is having a liver-based encephalopathy actually. So it could be a late sign or a symptom, and it is very difficult to diagnose in young children and infants. Probably it may not apply to this scenario, but it is like that. So this is an interesting model that I would like to mention here. So for example, if you see these red things are the liver cells and the green is the liver tissue. When we see that when the liver injury happens due to a viral insult or drug, etc., only when the injury hits and only 90% of the hepatocytes are functioning actually. So in that case, the bili can slightly increase. 50% of the hepatocytes are gone. Still, we can see that the liver's synthetic function is actually normal there. It has not gone up. 40% is gone. Then the INR starts becoming abnormal. But this is the parameter when the hepatocytes are only 1/4 of the cells that is left there, where the INR becomes more than 4. This is a downhill course because this is a criteria where we start listing for liver transplant, because native liver survival in certain specific scenarios when the INR is more than 4 is extremely less. So this is so PTNR as a function also gives a clue when to list a transplant in ALF for a liver transplant actually. So this is a question that is always debatable. So you have a patient with an INR of 6, acute liver failure, do you correct it or not actually? Answer is no, because we know that the liver produces factors which helps in bleeding and which helps in stopping. So this means when the liver is actually damaged, both factors are balanced, so they hardly bleed in fact. But whenever you are doing some invasive things like central vein catheter insertion and etc., then obviously we give FFP and all those things to do that. Otherwise, for an INR of just a value there, we needn't actually correct that deranged coagulopathy. So this is a new modality which actually checks, the machine will check whether it is balanced or whether the clotting is more or the bleeding tendency is more. You can sometimes use it. We use it mainly in the post-transplant time period rather than a child who is naive and who has come with an acute liver failure. So there are certain specific treatment for ALF. We still know that this is the PALF updated database. Still, even with advent of genetics, advanced biopsy techniques, 40% of etiology of ALF is still a mystery. So rest a few like modalities I think are available for paracetamol. You have NAC, herpes, you have acyclovir, Wilson disease, you can do plasmapheresis, etc., etc. But still it is 40%, we don't have a clue what is happening. Again, an 8-year-old girl, history very short, somewhat similar to the other child, jaundice, but this child actually had a rapid worsening of jaundice. You can in fact see the yellowness that is worsening. There is abdominal distension for 2 days, family history of similar illness, and spleen is actually palpable. So how this patient is different from the previous scenario? The duration is the same. A couple of things that is different. There is a rapidly worsening jaundice. There is some abdominal distension, should be gaseous. It could be even ascites. There is a family history in the past, and the spleen is palpable. So these are red flag signs in this child, which may say that this is probably not an acute hepatitic-like event, something else is there. So the onset is like acute liver failure, if you see, but later there are a few signs. So how this child is different? In parameters, when we see, the other kids had bilirubin from 8 to 10, but these kids have bilirubin. I think this child has progressive increase in bilirubin from somewhere around 28 to 40. There is a good unconjugated fraction that is lying there. The PTNR is sky high even after vitamin K and even FFP correction actually, because the child had a central line insertion. The low albumin was there. The baseline albumin was 1.9. These values are after transfusion. Near normal enzymes. This is very striking with respect to the previous patient who had enzymes in thousands. In fact, very low alkaline phosphatase. We hardly see practice which is 9. In fact, for a kid, it is usually up to 360. We take as normal because of the bone growth, and platelet counts are low. So this is not actually ALF. So let me take this thing, very high bilirubin. Think of a couple of things in acute liver failure. One could be hemolysis, acute kidney injury, sepsis, superadded, Wilson in acute liver failure, and acute on chronic liver failure. So these are the 5 conditions where you get a very high bilirubin in acute liver failure. This child, for further evaluation, KF ring is positive, ceruloplasmin is 7, urine copper is in 1400s, and the two parameters which I would take more important is there is no other liver disease where you get an extremely low alkaline phosphatase apart from Wilson disease. So this, because ceruloplasmin can be low when the liver is totally extinct because of many other things, hepatocyte necrosis, it can be going down. Some of the cholestatic liver disease may have a high copper. In fact, you have a score to score for the diagnosis of Wilson, but these parameters are very important and would give a clue towards Wilson disease. And when we did the CT abdomen, it was showing actually a stigmata of chronic liver disease. So this is an acute presentation of an underlying chronic Wilson disease or an acute on chronic liver failure. So Wilson in ALF or ACLF, always we have to remember only mild elevation of enzymes, very low alkaline phosphatase, copper can cause acute kidney injury, hemolytic anemia may be there, which is actually a DCT negative obviously. Sometimes they have leukocytosis, sometimes you get a false positive autoimmune markers, very high mortality, never treat with chelation, and plasma exchange can have a role before transplant. The PTANR, apart from diagnosing liver failure, has an importance in this Wilson score, which actually gives the criteria when to list for a transplant. This is a transplant listing criteria. This is not the indication. It's not like when the figure is crossing 11, you have to go for a transplant, but this is a listing criteria for liver transplant. So what are the chronic liver disease which presents in a fulminant fashion? So one is Wilson disease, other is autoimmune hepatitis. You can have chronic hepatitis B and sometimes Budd-Chiari syndrome presenting like this. So we have a child whose duration is like 3 months here. Child has jaundice followed by ascites. The gap is approximately 30 days. The child had a variceal bleed, and later the child had skin patches which were on and off, and the child came to the OP in fact. So relatively unsick with respect to the scenario 2 that I described actually, because the child has come to the OP in fact. So when we did the hemogram, the platelet count was strikingly low. It was 40,000. The PTANR, the baseline value was very high. Post vitamin K, it slightly came down, but it is not normal. And when we see the bilirubin, it is not very high, but it is high. 4 enzymes are slightly increased, and the albumin is strikingly low here. Alkaline phosphatase is normal. Ultrasound abdomen again shows that the child has evidence of chronic liver disease. And when we did the upper GI endoscopy, you can see a very large varix there. So this is a decompensated cirrhosis, unlike ALF or ACLF, which is like a bolt from the blue, sudden onset, sick, faster deterioration. This is a typical presentation of a chronic liver disease in decompensation, and this Wilson disease or autoimmune hepatitis or even HVOTO, which are the common things that we see. So when we did the investigation, the conventional autoimmune markers were positive, the complement levels were low, viral markers were all negative, and it is always better to check with the radiologist when they have disproportionate ascites to look for the hepatic veins, because outflow tract obstruction like Budd-Chiari can lead to a tense ascites like this. Any role of liver biopsy here? We should not do it now because of 2 reasons. One is the child has a deranged coagulogram. Second is tense ascites. There is no tamponade effect. The child can have a bleeding into the abdominal cavity. But the cornerstone for diagnosing autoimmune hepatitis is actually a liver biopsy. But in this scenario, you have to go by the clinical sense. So how to treat this child? Salt restriction, diuretic. Ascitic tap is usually done only when they have respiratory distress, a large volume paracentesis. Beta blocker for the varices so that it doesn't bleed again. And we need to treat for SBP also with a once daily antibiotic and endoscopy so that the varices are eradicated. Specific treatment for autoimmune hepatitis is with steroids and azathioprine. Simultaneously work up for transplant because the child has advanced liver disease. Wait for approximately 3 to 6 months. If the child is not improving with the medication, fresh decompensation or worsening on therapy, the child has to undergo a liver transplant. In fact, the same applies to children with Wilson disease. Start them on chelation. If they are not responding approximately after 90 days, it is better go for a transplant. But remember that the PTANR may still take some time, but symptomatically the child may become better. Probably the last scenario, I think this is an 8-year-old boy with an intractable itching, mild jaundice, having hepatosplenomegaly. Probably you will be knowing what is the diagnosis here, but let's look into this. So this child has a normal platelet count. The PTANR, the baseline was 30 and 3. After vitamin K, it actually rapidly normalized. And the LFTs are like the transaminase elevation are slightly high, but you can see the gamma GT is on the lower side. So many a times when they have cholestasis, the gamma GT should be logically on the higher side, but you have a low gamma GT. Bile acids are very high. Ultrasound shows some altered echo texture. So this is an early chronic liver disease. What is the importance of cholestasis and deranged INR? Majority cases of cholestasis causing a deranged INR or PT is due to a vitamin K defect, because saponification is needed for fat-soluble vitamin to absorb into the portal circulation. So that is why this is very important whenever a cholestatic baby comes into our OP. So this is a progressive familial intrahepatic cholestasis, genetically diagnosed type 2. So there are some liver disorders which presents with itching and a deranged vitamin K deficiency causing an deranged INR amine. So there can be other subtypes of PFICs, primary sclerosing cholangitis, Alagille syndrome, etc. When INR become 1, I think this patient has been managed with medical treatment. If the INR doesn't improve, then we have to think that PFIC has landed up in a liver failure. I mean, a chronic liver disease causing a liver failure. So usually, I think we manage PFICs like this. Drug therapy can manage pruritus many a times, improving quality of life. If the liver is working well, then a diversion can also be done, which diverts the bile acids out of the body. Or if the liver is not working well, then you have to obviously go for a transplant. So in general scenario, 1/3, 1/3, 1/3 fits here. 1/3 may be managed here. The rest may go into this scenario. 1/3 may stop here. The later 1/3 may go into that scenario. So this is the gross figures that is available. Why vitamin K is important? For the physician, I think we see whether it is reversible with that, but it is equally important for the physician and the patient to see whether this vitamin K deficiency does not lead to an intracranial bleed. So whenever a patient comes with cholestasis, it is better always to give, and it may apply more to an infant, but still, we have to give a vitamin K as a both diagnostic thing and a therapeutic thing. Diagnostic to check if the liver is working well, it is not secondary to vitamin K deficiency, the deranged PTINR I mean, and this deranged PTINR due to vitamin K doesn't cause an IC bleed. So that is the implication of giving vitamin K when you see a patient with a deranged PT. So basically, this is the algorithm. It is quite simple. So initially, when the patient comes with a deranged INR or PT, we give injection vitamin K, check the PTINR after 6 hours. And when you see that it is getting improved, then it is due to vitamin K deficiency. If it is continuing to be high, I think the child has synthetic failure and it will work as per what is happening in fact. So PTINR has to be taken as a liver function actually. It is not something that is related to, it is obviously related to coagulation, but the commonest cause of deranged PTINR is obviously a liver disease and vitamin K deficiency. It is vitamin K deficiency is actually common in kids with liver disease. Always rule it out first before labeling that the liver is failed and that is the reason for deranged PTINR. And the single most important parameter, PT and INR are the single most important parameter which helps in listing a patient for a liver transplantation. Thank you.
Thank you, Dr. Jagdish, for your nice presentation. All are self-explanatory. One thing we have to take a message is we have to think about the vitamin K deficiency before labeling it as a liver disease. Thank you. I think a question session will be after 3 sessions.
Thank you, Dr. Jagdish, for the wonderful talk. Now I invite Dr. Hamid to hand over the memento to Dr. Jagdish. May I request Dr. K. Muralidharan to hand over the memento to Dr. Hamid. We like to inform you that we will take questions after the next session. Thank you. Thank you, Dr. Jagdish. Thank you, Dr. Hamid, and thank you, Dr. K. Muralidharan. Now we move on to our next case scenario, a 9-year-old boy with abdominal pain, weight loss, anemia, and blood in stools. I invite Dr. Geeta M., Senior Consultant, Pediatric Gastroenterologist, Aster MIMS, Calicut, as the speaker. And I invite Dr. Salahuddin, Consultant Pediatrician, ICRA Hospital, Totalpalam, to chair the session. Thank you.
Morning. I hope I'm audible.
Yeah. Good morning, all. Our next case is a 9-year-old boy with abdominal pain, weight loss, anemia, and blood in stools. Abdominal pain is a common symptom, but even if it is associated with weight loss, anemia, and blood in stools, we should be more careful. We have to evaluate. So for this case discussion, we have Dr. Geeta ma'am. She is Senior Consultant Pediatric Gastroenterologist at Aster Medicity, Cochin. Over to you, ma'am.
Am I audible?
Yeah.
Thank you, Chairperson, for the kind introduction. So today's role for me is to discuss a 9-year-old boy with symptoms of abdominal pain, weight loss, anemia, and blood in stools. So this is generally meant for the practicing pediatrician and for the postgraduate. So let's start with elaboration of the symptoms. Now, like it was already mentioned by Dr. Maya about abdominal pain, when a child comes with this history, you have to categorize the type of abdominal pain, starting by looking at the location of the pain. So like Dr. Maya said earlier, organic pains are usually away from the umbilicus and pains in and around the umbilicus are usually functional, but this is an exception to that rule. So when the location of the pain is periumbilical, you have to also think of small bowel causes of pain. So if the location of pain is in the epigastrium or in the right or left hypochondrium, then you can think of other causes. But if it's in the periumbilical or in the midline, think of small bowel type of pain. Now also categorize the type of the pain, the severity of pain, whether it's causing a nocturnal awakening, as Maya said, the duration and character, and aggravating and relieving factors. Nocturnal pain is an important characterization for organic cause. So if there's a midline pain, but it is severe enough to cause nocturnal awakening of pain, child going to the hospital for the pain, give some credence to the pain. Now, weight loss is one thing that you need to document very well. Supposing there is about 2 kg or more weight loss, then it has to be taken some credence. Patients sometimes say the child is appearing thin or looking thin, but there's no actual weight loss. So that needs to be taken with a pinch of salt. The other thing in today's scenario is to find out whether it was an intentional weight loss or a non-intentional. This being a preteen child, it's unlikely that it will be an intentional weight loss, but in adolescence, we do see children who are trying to lose weight and therefore come with these kind of symptoms. Associated symptoms like loss of appetite, loss of weight, fever, etc. should also be taken into account. Now, this patient has got 2 alarm signs in the history. One is anemia, and the other is blood in stools. Weight loss, if it is documented to be more than 2 kg, is also alarm symptom. So the type of anemia should be characterized as an iron deficiency anemia. Is there evidence of chronic illness, or is there any evidence of other vitamin deficiencies or other deficiencies like albumin? So a patient with anemia and low albumin will automatically go into a category of organic causes which needs to be investigated. Now, the other symptom that this patient has got is blood in stools. So before we go into further investigations, you have to get from the history how much blood is there in stools, and has somebody witnessed the blood in stools? Is it fresh? Is it altered blood? Is it melena? Is it associated with hard stools or soft stools? Is it mixed or falls separately from the stools? These are necessary for us to identify whether it's a local cause. For example, if the child has got a fissure or has got a rectal ulcer, sometimes this history will help us to identify these causes in the clinic itself. Blood and mucus in stools, or blood and mucus alone without stools, is an alarm highly indicative of inflammation of the bowel. So that needs to be also thought of. And is the stools, is the bleeding painful? This gives an important clue as to whether the child has got a fissure. So these are the history that should be taken in the clinic before you launch on to any investigations. The next thing would be to do a head to foot examination. Look at the growth of the child. Is the child growing well? There is definitely some amount of weight loss that you're talking about, but has that affected the height of the child? So plotting a growth chart or looking at the previous growth and recent growth will identify any growth stagnations. Now, this is an important parameter which can help us to identify whether the child has got a chronic illness, not just inflammatory bowel disease, but any chronic illness. If there is stunting of growth or stagnation of growth, as per the growth chart, not just superficial feeling that the child is not gaining weight, but as per the growth chart, then you can think of a chronic condition. Now, if the child is not gaining weight, is there muscle wasting? Is there fat loss on clinical examination? Also be careful to look out for these few conditions. Anemia associated with the clubbing, which is an important parameter for inflammatory bowel disease. And sometimes you will find pedal edema due to anasarca or hypoalbuminemia. So this should also be an important thing that should be done in the clinical examination. Now, inflammatory bowel disease or conditions of the bowel are notorious for not having any general physical findings except this loss of weight or slight lean appearance of the child. In the abdomen also, you are not going to find much of any findings unless it's an extreme case where there is ascites. Sometimes, if you're lucky, you'll find a mass in the abdomen. Sometimes you'll find some area of tenderness over the mass also. But in general, when the patient presents with these symptoms, even if the symptoms have been present for 2-3 months or 6 months, the general examination of the abdominal examination is going to be unremarkable. They may have some vague tenderness or diffuse tenderness, which may appear to be a non-specific or non-organic cause. Examine the perineal area, especially if there is blood in stools. You can actually find out if there's a fissure, and you have to also look out for fleshy skin tags. Sometimes they may have, especially the pre-adolescent or adolescent children, may not even come up with the history. They may be having abscesses of fistula-like formation there, which they are reluctant to come out with. So do examine after taking advocate permission. Do examine. A gentle examination is only required. You don't have to do a per rectal examination. A perineal examination is good enough. Also, be mindful that there are extraintestinal manifestations of this inflammatory bowel disease, such as skin lesions, erythema nodosum. So what is erythema nodosum? It's a commonly seen extraintestinal manifestation of inflammatory bowel disease, and they appear only as red nodules. In a fair-skinned child, you can see these red nodules, but in other children or in our children, what you can ask the history for is whether there are any painful nodules which they attribute as some insect bite. And they remain there for 3 to 4 days and they disappear only to return sometime later. These lesions can precede the abdominal pain, can be present during the abdominal pain, or may present later also. So they may be totally unrelated. The parent may not relate these nodules to the present condition of the child, but you can ask for such a history. It is commonly seen in our children. So extraintestinal manifestation and perineal area examination is an important extra thing that you should look for in these children who present with abdominal pain and bleeding PR. Laboratory tests are the next baseline investigations to be done, especially since the child has anemia and bleeding. So a peripheral smear will help us to identify the type of anemia. And of course, along with these blood tests, you can look for other signs of inflammation, which are raised CRP and raised ESR. Now, platelet count is also an indirect method by which you can look out for chronic inflammation. And so this combination of a raised CRP, a raised ESR, and platelets above 3 or 4 lakh indicates there is some chronic inflammation somewhere in the body. It may not be inflammatory bowel disease itself, but there is some inflammation going on. This, coupled with anemia, will give you a clue that we are going towards the diagnosis of a probable bowel disease. Now, liver function tests, sometimes the albumin may be only borderline low, like 3.5, or they may be really low, like Dr. Jagdish's case, maybe even 1.9, especially if there's extensive involvement of the small bowel due to malabsorption. Amylase and RFT, which we are doing because of the presence of pain, is usually normal in these cases. Now let's take an example for this case, wherein the hemoglobin is 8.9, the total count is borderline increased. Neutrophils are on the higher side, but not significantly so. Now the platelet count is 6.7 lakh. Now this is typical of inflammation somewhere in the body. The ESR is on the higher side, CRP is also quite high. If you had this child with only CRP raised, normal ESR, normal platelet count, it could even indicate a normal infection or a localized infection at that point of time. But a persistently elevated ESR, a persistently elevated CRP on two or more occasions indicates a chronic inflammation. As you can see, the liver function tests are fairly normal except for the albumin, which is borderline low. Now, fecal calprotectin is one test that can identify if the inflammation is in the bowel. In this case, it was more than 500. But in this case, already the child is having history of bleeding PR. So when there is bleeding PR, there is already an indication for us to go ahead and do a colonoscopy. So in this case, fecal calprotectin may not be so important, but if the child did not have bleeding PR and child had only abdominal pain, anemia, a fecal calprotectin would help make us give us the idea that the problem could be in the bowel and may help us make the decision of going ahead for colonoscopy. Ultrasound abdomen in some cases can show thickening of the bowel, but it need not be so. It can be totally normal. In some cases, you can find out masses, conglomerated lymph nodes also. But in general, the ultrasound abdomen can be normal. So the only investigation here that can help us in point toward diagnosis of inflammatory bowel disease is the raised inflammatory markers, the raised platelet, a fecal calprotectin of more than 500, and the thickening of the bowel in the ultrasound. So what would be the next investigation? Do you have to go for a CT scan or you have to go directly for endoscopy? In this patient, in this particular case, because the child already has a pointer towards the bowel in the form of a bleeding PR, you have to directly go for colonoscopy, as that would give you the maximum yield for making a diagnosis. So when you do an endoscopy for this patient,
PED GASTROCON.
Can I continue?
Yeah, continue.
Yeah. When you do an endoscopy or a colonoscopy in this case, this is the normal appearance of the bowel. You can see the glistening mucosa, the vascular pattern being very clearly. But
ഒന്ന് മ്യൂട്ട് ചെയ്യോ? Can you?
Yeah. But in the when you do a colonoscopy, you can find that. Can I continue?
Yeah, continue, ma'am.
Yeah. So in this case, when you do a colonoscopy, you can find that this normal appearing folds, etc., have been lost, and you will find the red. This is from where the bleeding has occurred. So the superficial mucosa undergoes ulceration, bleeding points appear, and as the inflammation spreads, they can become even larger ulcers and result in severe colitis. So this is an inflamed bowel, which is suggestive of an ulcerative colitis. The other condition in inflammatory bowel disease is the Crohn's disease, which usually does not present much with bleeding PR. They usually present with pain and anemia and patchy normal mucosa. And in extreme cases, you can have pseudopolyp formation and complete destruction of the mucosa in certain areas of the bowel. Now, the importance of doing the colonoscopy here is you can actually take biopsies from this mucosa and you can come to a confirmatory diagnosis. So the idea of doing a colonoscopy first in this patient would be because he's got bleeding PR, he's got all the signs of some inflammation, and you have to make a quick diagnosis. So this will actually give us the diagnosis, gives us the biopsy and histopathological finding also. So this is the histopathology of a normal colonic mucosa. And in the case of ulcerative colitis, you'll find that the superficial mucosa has got a lot of ulceration with crypt abscesses. You can find architecture being lost, but the deeper parts of the mucosa are relatively spared of inflammation. That is the difference histologically between ulcerative colitis and superficial lesion, superficial illness, whereas Crohn's disease is something which has got even deeper involvement of the mucosa of the bowel wall, and you can find non-necrotizing granulomas inside the bowel. So our diagnosis is confirmed by doing the biopsies, and therefore we can directly go for treatment. Now, is a CT necessary for patients with inflammatory bowel disease? A CT helps identify the extent of disease. It does not give us the diagnosis. So ideally, for a patient with bleeding PR, we would go first by doing an endoscopy and a colonoscopy. Sometimes an endoscopy is also done to find out when the involvement of the upper GI tract, but a colonoscopy for sure. And the biopsy will give us a diagnosis. A CT is done for us to identify the extent of the illness and any complications that are there. So the CT that in the olden days used to do barium meal follow through, that is no longer done anymore. And what is the difference between a normal CT and a CT angiography? A CT angiography is a method of identifying the strictures in the small bowel. So here, instead of normal contrast, what we give is mannitol, which helps the bowel to distend very well. Therefore, any false artifacts or any false peristaltic movements will not be picked up as strictures. So in the first picture that you can see here, you will see that the bowels are all very well distended and there's no bowel wall thickening. Whereas in this picture, you can see that there is thickening of the bowel wall and an area of the bowel which shows no hostrations. So this helps us to identify the involvement of the bowel. In this larger picture, you can say that the proximal and distal part of the bowel will be distended, whereas the inflamed area can be shown as thickening and narrowing. So this shows there are multiple strictures of the small bowel called as multiple skip lesions, which helps us to identify Crohn's disease. So Crohn's disease is a condition which involves any part of the mucosa from the mouth to anus. Therefore, involvement of the small bowel plus large bowel is usually a diagnosis of Crohn's disease, whereas ulcerative colitis, the disease is usually limited to the colon and does not have small bowel involvement. So most likely when the patient has got a diagnosis or a biopsy or finding of Crohn's disease, we tend to take a CT angiography. It is usually not required in the case of ulcerative colitis. Now, when do we do a capsular endoscopy? Supposing the patient has had a bleeding PR and we do a colonoscopy and we find that the colonoscopy is normal and the biopsy also has not shown anything, but the child continues to have symptoms, that is when we have to do a capsule endoscopy. So capsule endoscopy is not a very commonly done test. It involves using a capsule which can be actually ingested by the child, and this capsule has a camera which keeps recording all the images inside the bowel and helps us to identify the point of bleed for this patient. So the advantage for the capsule is it can help us to look at the entire small bowel. The upper GI scopy and the colonoscopy can see only part of the bowel. This entire small bowel cannot be visualized, but in the capsule you can see the entire small bowel. The disadvantage of the capsule is, one, it cannot take a biopsy, so it can only visualize and find out where the lesions are. Two, it can sometimes in the case of strictures, it can get stuck in the bowel. So a contraindication for capsule is when you think that the child has got a stricture, you should not do. So even in Crohn's disease, if you think that the child has got a stricture, you do not put a capsule. But if you think that there's an obscure bleed, a bleed for no reason, you don't know where the bleed is coming from, then you can go ahead and do a capsule. And these are some of the capsule images. They can actually pick up large ulcers in the bowel and can help identify whether the lesion, how to target this lesion when you do a laparoscopy or a push endoscopy. So once you know where this ulcer is lying, approximately by the duration of the time that has elapsed since the capsule has been ingested, or from the time that the capsule transmits images, you can identify these narrowings or these areas of ulceration. And later on, you can do some other method like laparoscopic or push endoscopy and try and target these biopsies. The reason being, without a proper biopsy, it's difficult to start treatment in inflammatory bowel disease. You cannot do empirical treatment just because you have seen an ulcer does not mean this could be Crohn's or this could be ulcerative colitis. You definitely need a histopathological diagnosis. Sometimes tuberculosis can also present like this. So it's also mandatory that in these patients, tests are done for ruling out tuberculosis. Now, once you have made this diagnosis of inflammatory bowel disease, which is not uncommon in our children, in preteens and teenage, you find a lot of these patients do have inflammatory bowel disease or Crohn's, which has gone missed for many, many years sometimes, affecting the growth of this child. So it's mandatory or it is imperative that these children are started on treatment very early. You cannot wait for some time for spontaneous relief because it definitely affects the growth of the child. So the treatment is definitely has to be in the hands of a pediatric gastroenterologist because it's a long or a lifelong treatment. The treatment is very complex and has to be modified at different stages of the child. And now the goal of this patient is not just relief of symptoms, but also to get the growth back on track and help them to lead a normal life in future. So the initial goal in about 2-3 decades ago was just relief of symptoms. And for that, we used to start the patient on corticosteroids and 5-ASA. But now the goal is also complete mucosal healing, for which we need, especially in pediatric age group, we need to put these children on immunosuppressants. Now, adult gastroenterologists usually treat these patients with only corticosteroids and taper them and start them on 5-ASA, and they think it's enough. But that does not bring back the growth of the child. So they definitely need to be on immunosuppressants and need to be carefully monitored for the future. So mucosal healing, which seems to avoid later complications, even malignancy, and also brings back the growth trajectory of the child is imperative in this patient. So individualized treatment based on the severity, tolerance, any reactions to the treatment and response to treatment is necessary, and biologicals do help us to improve the quality of life for this patient. So the new paradigm for these patients, both in ulcerative colitis and in Crohn's disease, is identify the complications, map up the disease, and a treat to target strategy, wherein the goals of mucosal healing as far as possible should be adhered to. And these children, just because they are on treatment does not mean they don't need any monitoring. Any monitoring for opportunistic infections, tight control of the illness, etc. will help them achieve their normal growth, normal life parameters, and therefore can avoid complications in the future. Biologicals are also a way in which we can try and get them into control, but these should be done only on a proper evaluation and with proper follow-up with the pediatric gastroenterologist. So in summary, ladies and gentlemen, inflammatory bowel disease is up to the pediatricians to help identify or screen these patients and refer them properly for further evaluation. Because these children, by the time the anemia and the inflammation has gone on for very long times, can lead to loss of the small bowel or lead to strictures which require surgery. So any child with failure to thrive, chronic pains, delayed puberty, or any of these alarm signs like fever, bleeding PR, loss of appetite, loss of weight with raised inflammatory markers needs to be evaluated for inflammatory bowel disease. In case of bleeding, colonoscopy and biopsy is necessary for the diagnosis, but usually we do an upper and lower GI scopy and biopsy, and this helps us to clinch the diagnosis. Earlier we detect a patient and give adequate treatment, it is life-saving and also bowel-saving and helps them to get a very nice outcome. We also need to destigmatize the disease because most of these patients, when they hear that the treatment is lifelong, tend to go for alternative therapy or tend to be non-compliant with the medication. That will actually make the disease worse and lead to further complications. So as a society or as a group of doctors, both the pediatrician and the gastroenterologist must work together to destigmatize the disease and help our children to achieve better outcomes. Thank you.
Thank you, ma'am. Any child with abdominal pain, you should see for red flag signs. So if red flag signs like weight loss or bleeding PR is there, you have to evaluate. That's what ma'am told. And about IBD, she told it may require lifelong treatment. And now the treatment is focusing mainly on this one growth and development of the child also. So any questions? From audience?
Now, may I invite Dr. Haris Abubakar, sir?
You can ask questions in the chat box also.
Any questions from the audience? Audience can put doubt in chat box also. We will read it later or discuss later. Okay, one question.
One question to Dr. Jagadish. Sir, you told about vitamin K therapy. What's the dose and what's the mode of therapy?
Thank you for that question. So vitamin K, I think in kids who are more than 1 year, I think the dose range is between 5 to 10. In infants, the dose that we give is actually between 1 to 2.5. So any child who is more than 1 year, the dose range is actually between 5 to 10 in fact. For example, a child who is, I don't think we follow this mg for a kg kind of thing in vitamin K. For example, a child is less than 5 year and more than 1 year, we tend to give them 5 mg. Child who is more than 5 year, then we usually give a 10 mg dose. It is available, but the route of administration is always IV, because if the child is already cholestatic, then we cannot give it as an oral preparation. So,
I am Dr. Purushottam. May I make a comment?
Okay, sir.
I enjoyed the sessions, all the three clinical scenarios and the discussions. In 70s and 80s, where we were studying, many cases of intestinal tuberculosis were diagnosed and treated. At that time, there was not much of facility for pediatric scopy, the biopsy, the imaging were not there. And nowadays, more and more of the chronic disease are being diagnosed, but rarely we diagnose or treat tuberculosis. And in this session also, Maya didn't mention about that possibility of intestinal tuberculosis, and Gita just passing mention of tuberculosis. What's your experience of tuberculosis of intestine in the pediatric gastroenterologists? There are Bandasar and Riyasar in the previous generation and newer generation of gastroenterologists. What's the experience of the newer generation of gastroenterologists about the intestinal tuberculosis is one question. Second thing, are we not utilizing the macroscopic examination of stools, which is so useful as a clinical specimen? For a nephrologist, urine is called as a liquid biopsy. But nowadays, even the youngsters are going to toilet independently. They flush and lose the samples. So should we not utilize the macroscopic stools examination in the coming years somehow to make a diagnosis? Two questions. Thank you.
So can I go first?
Yes, ma'am.
Sure. So, Dr. Purushothaman's question was one regarding tuberculosis. Are we seeing it? Is the incidence coming down, or why are we not seeing much of tuberculosis today? So, the general theory about tuberculosis is when other diseases, other infections were very high, these chronic illnesses were not a major problem probably because our microbiome was different, and therefore they used to control this chronic illnesses. The moment we had the advent of antibiotics and hygiene, etc., and a lot of our infections now out of the picture, chronic illnesses, the world over it is seen that chronic illnesses starts rearing the head. Now, if you look at India as a whole, you'll find that Kerala is distinct because we have the highest number of inflammatory bowel disease, Crohn's especially, not UC but Crohn's, both in pediatric and adults in the whole country. So our population or our disease pattern is much more akin to European pattern. And people believe it's because of the high rates of hygiene, because we have kind of eliminated a lot of these infections much earlier. Even tuberculosis in the rest of India, when tuberculosis was very high, they used to laugh at us when we said inflammatory bowel disease and Crohn's disease. Now that the hygiene level in other states are also improving, they are now having inflammatory bowel disease and their level of tuberculosis is coming down. Still, we do not deny that tuberculosis is an important differential diagnosis. Only it is not as big a diagnosis as it was before. We still do the tuberculosis panel. We do a biopsy, a gram stain, we do the culture, etc., and then rule out tuberculosis and go ahead because it is an infinitely treatable condition. In the advent of multi-drug resistant tuberculosis, we don't know. We may see much more worse conditions. We are seeing a rise in pulmonary tuberculosis. But intestinal tuberculosis, in my experience, we are not seeing that much. We do see the occasional cases, but definitely not as much as inflammatory bowel disease. Second thing, when tuberculosis is that rampant or it goes on for such a long time, they usually have other manifestations. And therefore, the patient comes to the facility earlier or comes to the doctor earlier, and the diagnosis is probably done with extra-intestinal manifestations of tuberculosis is identified. Purely intestinal manifestation or purely bowel manifestation of tuberculosis is not such a very common condition. It's usually seen in multi-drug resistant or patients who are already treated with tuberculosis and then develop a symptom. So that is what I'm thinking. Second question of yours regarding a stool, I definitely agree. We are losing our touch with clinical medicine, and therefore we need to use the stool as an indicator of an internal problems much more often. This would become much better in the future if we knew our microbiome. So even the microbiome evaluation of a particular patient can give an indication of chronic illnesses also. So maybe it is the future. Dr. Riaz and Dr. Banu, if you would like to comment.
Yeah, I totally agree with you, Dr. Gita. I mean, we see intestinal TB very rarely. We see once in a while, but majority, as you said, it is the Crohn's disease that we definitely see. And as you said, definitely we get the MTB panel for the, not only for gene expert and the direct smear, and also for the culture. From the biopsy, we do take it. But, you know, almost all the time it is negative. Occasionally we get one positive, but it is very uncommon. You're absolutely right.
Well, I also agree absolutely with Dr. Banu and Dr. Gita.
It is not like we're not looking for it. We're actually looking for tuberculosis. When we do the sampling, we actually send for gene expert. But we end up getting a negative report. We always, whenever we make a first diagnosis of Crohn's in a child, we actually keep a differential. Even in your diagnosis, we sometimes write to exclude tuberculosis. But when the results come out, they tend to have small granulomas. We don't find TB bacilli. Our gene exports are negative. MAN2 is done. When we make a first diagnosis, we always try to exclude tuberculosis before we start the child on a treatment for Crohn's disease.
Important thing also to remember is not to mistake it as tuberculosis and not think of Crohn's also. So the fear here is that we think it's tuberculosis and treat for tuberculosis and try different methods, but always think that there could be Crohn's, so keep the differential diagnosis in mind.
Hello, madam. I am Dr. Jose. Madam Gita, madam. What is now the incidence of, previously we think the inflammatory bowel disease are in the, because pre-adolescent, adolescent age group. Whether the shift of age group is decreased to the infancy or the early childhood period having an incidence of IBD in your practice? So, youngest age group you come across.
So there is no denying the fact that with the advent of more and more investigation, the the ability for us to do endoscopies in small and younger children, even newborn babies, has opened up the differential diagnosis cadre, in the sense that you are able to identify ulcerations inside the bowel in small infants also. But those cases, less than 5 years of age, the really small inflammatory bowel disease, we would always take with a pinch of salt, because there are multiple conditions in this age group which can present as ulcers in the bowel. So just because the colonoscopy or the CT has shown that there is a stricture or there is an ulcer in the bowel in an infant or in a child less than 5 years, we must take every effort to rule out other conditions. Immunodeficiencies are a very common cause of bowel problems, ulcers in the bowel, and so many genetic causes also have been identified. IL-10 deficiency also can have found to associate with perianal fistulas in newborn babies. So just because it is ulcer in the bowel does not mean it's inflammatory bowel disease. And ulcer in the bowel in less than 5 years of age should always go through the immunologist. Also always go to the pediatrician to rule out any of the immunodeficiencies, opportunistic infections, and then only think of inflammatory bowel disease. We do not directly make a diagnosis of inflammatory bowel disease in this young age group. In older, yes, but we do not, because they have survived the first 5 years without infection. These children are too young for us to make a diagnosis directly for inflammatory bowel disease or Crohn's disease. They have to go through the evaluation of any genetic causes, immunodeficiency causes, and only later, when this is excluded, can we say that it's inflammatory bowel disease.
Thank you, ma'am.
Hope we have come to an end of the discussion. May I invite Dr. Haris Abubakar to hand over the memento to Dr. Salahuddin, the chairperson. Dr. Haris Abubakar, sir, is Senior Consultant Pediatrician, CM Hospital, Vadagara. We wholeheartedly thank all the 3 speakers and chairpersons of the first session. Since we are running short of time, we will straight away move to our next section, Updates in Pediatric Gastroenterology. With great pleasure and honor, we invite Professor Dr. Riaz A., former HOD, IMCH Calicut, on the next talk, Misdiagnosis and Missing a Diagnosis in Pediatric Gastroenterology, an odyssey of 4 decades. The session is chaired by Dr. M.V. Haridas, Senior Consultant Pediatrician, Cooperative Hospital, Vadagara.
Prashant, can you see my slides?
Yes, sir. Very much. Please.
Who's chairing?
Myself, Dr. M.V. Haridas.
MVH, okay.
It is a great honor and pleasure getting chance to introduce Professor Riaz. Professor Riaz is one of the pioneer pediatric gastroenterologists of South India. He is the 17th batch student of Calicut Medical College. He took MBBS, MD, DCH, DNB, and later DM gastroenterology. He has got 38 years of PG teaching experience and 43 years of undergraduate teaching experience. And he has written a textbook, nice textbook on pediatric gastroenterology and hepatology. And with these words, I am introducing Professor Riaz, and the topic I don't want to comment. It is missing the diagnosis and misdiagnosed in gastroenterology. Over to you, sir.
Thank you. Good morning, everybody. Hope I'm audible.
Yes, sir. Please.
Good morning, everybody. And I would like to thank Team IAP Vadagara and my PED Gastro colleagues, especially Dr. Prashant, for this privilege. Well, many a time, pediatricians like us wonder whether our diagnosis is correct or whether it was wrong. And if it was wrong, what went wrong? So, but remember that arriving at a clinical diagnosis in a very sick child is always similar to solving a tough jigsaw puzzle like this. So we shall discuss why we may miss a diagnosis through a few case scenarios. But before that, I would like to take a Mungur Jamia, or what's called an anticipatory bail, because I'm sure that many of you in the audience are my old students. And so there may be some repetition of my slides from previous talks. Some of you may feel bored, especially my PED gastro colleagues who have listened to my talks previously also. I'm really sorry about it. Now, what are the causes of diagnostic errors? Diagnostic errors are actually due to two factors. Number one is very poor history. The second cause is a very bad or a very hasty clinical examination. Suppose you've got 100% to be seen in, say, 3 or 4 hours, it will be very difficult to do justice to our history as well as clinical examination. Now, this is a quiz for postgraduate students. Name the only branch of medicine apart from pediatrics that gets history from bystanders and not from patients. Anything in the chat box? Most students, including postgraduates, say, so psychiatry. Okay. But remember that psychiatric patients will be usually giving beautiful histories which may not be correct. I'm sure you'll recall this scene. Which is this scene? Film. This is a hilarious scene from Ulladaka. And Jagadi was acting as a patient with abdominal pain, and he was so beautifully describing what went on, that there was a horse in his mouth and so on. So psychiatric patients do give. So the correct answer is veterinary medicine, unless you are Dr. Doolittle. Now let's see a case scenario. This is an old case which happened way back in 2002, that's almost 20 years back. A 1-year-old girl born to consanguineous parents was brought to me with severe water diarrhea for more than 6 months duration, which started after stopping breast milk and replacing it house milk. So this child was treated elsewhere with multiple antimicrobials without any relief. The history was significant because 2 of her siblings had died in the past of severe dehydration. This child had malnutrition, periorificial and acre lesions. She had mild hypochromic microcytic anemia. Otherwise, the investigations were within normal limits, except for a 0.5% sugar, which can be regarded as normal in this age group. So, I made a diagnosis of acrodermatitis enteropathica after discussing with my wife, who is a dermatologist, and we put her on zinc and ORS. There was a dramatic response. Within 5 days, within 1 week, the child's diarrhea completely stopped and the skin lesions also subsided. But the father had a complaint. He told me, Doctor, നിങ്ങളുടെ മരുന്നിന് ആപ്പാട് 50 രൂപ ആയിട്ടുള്ളൂ, പക്ഷേ മരുന്ന് കിട്ടാൻ ഭയങ്കര ബുദ്ധിമുട്ടായിരുന്നു. He had to spend 150 rupees for auto rickshaw hunting for the medicine because at that time, zinc was not that freely available. This child was later lost for follow-up. Then comes 2022, that's after 20 years. Now, the parents were worried because his marriage has been fixed, as is usually in the Malabar area. When a child is on Eltroxin or diphencylamine, before the marriage, there's a tendency to stop these drugs. So zinc was stopped. Following that, about 1 week after stopping zinc, she started developing profuse watery diarrhea again. She also developed extensive lesions in the oral cavity and genitalia. So this patient was given multiple antimicrobials and steroid creams without any relief. Then she was seen by a dermatologist who did a skin biopsy, which was reported as pemphigus vulgaris. Now, pemphigus vulgaris is a very nasty disease, and she was advised lifelong treatment with prednisolone and azathioprine. The parents were also advised to avoid marriage and pregnancy because azathioprine is definitely a teratogenic drug. This was the state of affairs when this patient came back to my wife, who is a dermatologist. I was also called in because she was my old patient also. She was a very depressed girl. She had Cushing-out facies, extensive acne. She had extensive lesions of genitalia and growing, and also the oral cavity. These lesions were actually typical of acrodermatitis enteropathica, but adults with acrodermatitis enteropathica, that's actually very rare. This is supposed to be very rare in adults. Her serum zinc was very low, so we tapered and stopped prednisolone, and azathioprine was also discontinued. Put her on just ceftriaxone and zinc along with the local treatment. And there was an astonishing response after just 5 days, because almost the entire lesions almost subsided and the diarrhea also subsided. The marriage took place in time also. So acrodermatitis enteropathica is an autosomal recessive disease. This is actually a relatively benign disease, provided you diagnose it in time and give lifelong zinc therapy. And unfortunately, the skin lesions may resemble psoriasis, eczema. Sometimes it may be vesicular bullous lesions, which may resemble pemphigus vulgaris. So this underscores the importance of taking a proper history, including past history as well as a drug history. So why was the diagnosis missed in this child? Number one, the history was not properly taken because the history of consanguinity is missed. The history of deaths of 2 siblings due to severe dehydration was missed. History of skin lesions in her infancy was missed. So treatment history was not taken. The fact that the child was on long-term zinc therapy. The skin biopsy was reported as pemphigus vulgaris. Actually, that should have been reviewed or counted. The next case, we had a 6-year-old boy with a febrile illness who had an AST, and as a part of the evaluation for febrile illness, LFT was done. It was found that our AST was 450, his AST was 450 and the ALT was 22. So the pediatrician became worried and he repeated from 3 different labs. In all the results, that was AST and ALT elevated in the same ratio. So since they were from Kasaragod, they went to Mangalore for a detailed evaluation. He had a grade 3 protein malnutrition, mild hepatomegaly, the ultrasound showed fatty liver, his albumin and ceruloplasmin were low. Liver biopsy was done and he was put on dipensilamine with a diagnosis of Wilson's disease. Well, this child was referred to us after 1 year because even after 1 year of treatment, his transaminases continued to be very high. Now, he did not have jaundice or any signs of chronic liver disease. Now, how will you proceed in this case? This is back to basics. Always take a history. And I like this particular slide very much because I'm writing 3 times history, not because we have to write history taken 3 times in the examination paper. I'm only trying to underscore the importance of taking a proper history. If you do not take a proper history, you will miss the diagnosis. Then you examine and do a relevant investigation. So all doctors should be like Sherlock Holmes. There is no doubt about it. So see the patient again. You can see that his calf muscles do appear a bit bulky. And the history was that he had mild motor delay. And in fact, he was even evaluated by a pediatric neurologist in infancy. He was also undergoing physiotherapy for his developmental delay. Now, we are just, what is this sign? This is the Gauss sign, which is positive. It shows that he has got proximal muscle weakness. His CPK came as more than 18,000. So diagnosis is now very obvious. It is Duchenne muscular dystrophy. So it's actually a quiz for the postgraduate student. Which sign is being demonstrated here? Anyone in the chat box? Heidi? Hello? Hello? Am I audible?
Yes, sir, you are audible.
Yes. What is this sign? This is actually a very nice sign. This is called Valley sign in Duchenne muscular dystrophy. This was in fact described by an Indian neurologist from SGPJ. His name is Pradhan. Full name is Sunil Pradhan. We are all fond of a sign described by foreigners like a Gauss sign. But this is a sign described by an Indian neurologist from Lucknow. So why was the diagnosis missed in this case? Because this child had actually Duchenne muscular dystrophy. He had motor delay. His AST was persistently more than the ALT. He had hepatomegaly and fatty liver. This was because he had severe protein energy malnutrition. So hepatomegaly and fatty liver may be a part of his severe PEM. His low albumin, low ceruloplasmin were also part of his PEM. So what are the sources of ALT or SGPT? See, the most important source is cytosol of hepatocytes. A small quantity may be present in the heart and the skeletal muscle also. So whenever the SGPT is found to be elevated, it is suggestive of liver disease because the SGPT is liver specific. What about SGOT? SGOT is present not only in the liver and the heart, but in several other tissues or organs like the skeletal muscle, kidney, brain, pancreas, RBC, WC, etc. So whenever these organs are damaged, whenever there is a disease affecting these organs, SGOT can be elevated. So what are the causes of unexpected elevation of transaminases? Obesity, NASH, as in this child, diabetes, asymptomatic chronic hepatitis B, C, Wilson's disease, alpha-1 antitrypsin deficiency, and of course, muscle diseases like muscular dystrophies, as we have just discussed. Who is this? Well, this is indeed Arnold Schwarzenegger. Transaminase will want to be high because he is a very muscular person. If you measure transaminase at the end of a marathon race, naturally the transaminase may be found to be elevated. Now let's see another case. we had a 10-year-old unimmunized boy who had chronic constipation, severe dyschezia of more than 2 years duration. He had hematochezia, he had encopresis, that is soiling. He was extensively evaluated and treated with no relief. This happened long back without any relief. So his basic investigations were with the normal limits, calcium, potassium, TFT were normal. Then somebody did a barium minimum, which was found to be normal. But rectal examination showed a soiling and a loaded rectum. So what happened to him? We took a history again and found that he was treated for whooping cough 2 years back. Okay, and he was given a prescribed, this helped to clean the diagnosis because he was given Corex cough syrup. It's a very sweet medicine. And now Corex is a cough suppressant, it contains codeine. So this boy became addicted to codeine, to Corex, and daily was taking quarter bottle of Corex. That was responsible for its constipation. പണ്ട് നമ്മളെപ്പോഴും പറയുന്ന ഡോക്ടർ പുരുഷോത്തമനൊക്കെ അറിയായിരുന്നു പണ്ടൊക്കെ കാലിക്കറ്റില് പനിക്ക് പെരാക്സിൻ കുരയ്ക്ക് കോറക്സ് എന്ന് പറയാം. പെരാക്സിൻ ഈസ് ക്ലോറംഫെനിക്കോൾ. അപ്പോൾ ഒരു കുട്ടിക്ക് ഇപ്പം നമ്മൾ പൈമോക്സിൻ കൊടുക്കുന്ന മാതിരി ഒരു LRA വന്നിട്ട് ഫസ്റ്റ് ആന്റിബയോട്ടിക് ടു ബി ഗിവൺ ഇസ് പെരാക്സിൻ, ദറ്റ് ഈസ് ക്ലോറംഫെനിക്കോൾ. അതിന് കൂടെ എപ്പോഴും കോറക്സും കൊടുക്കുക. ദാറ്റ് വാസ് ആക്ച്വലി റെസ്പോൺസിബിൾ ഫോർ ദ ക്രോണിക് കോൺസ്റ്റിപ്പേഷൻ ഓഫ് ദിസ് ചൈൽഡ്. So how does codeine cause constipation? Because codeine can inhibit intestinal peristalsis, it increases the absorption of fluid, and can reduce fluid secretion. These are responsible for the chronic constipation caused by codeine. Another case, a 14-year-old boy with high fever, chills, rigor, and jaundice of 5 days duration. Here, mild hepatomegaly. Look at the blood leukocytosis, neutrophilia, very high acute phase reactants. Transaminase are only mildly elevated. ALP is normal. But the creatinine was 2.2 milligram%. His HbA1c was positive. His IgM anticore antibody was negative. IgM anti-HIV2 was negative. What's the diagnosis in this? You may be tempted to make a diagnosis of virus B hepatitis, acute virus B hepatitis. But look at you can see that the IgM anticore antibody is negative. So this is not acute virus B hepatitis. This is actually, look at the blood leukocytosis, neutrophilia, high ESR, CRP, and deranged RFT. So this is actually Weil's disease in an HBsAg carrier. He happened to be an HBsAg carrier and developed Weil's disease. You can see the subconjunctival hemorrhage, which is not seen in viral hepatitis, which is not commonly seen in viral hepatitis. So dark field microscopy shows the organism. The next investigation would be a CP or CK, which is very high. So this was consistent with the diagnosis of Weil's disease. So you don't have to wait for the serological test to make a diagnosis of leptospirosis because that may take quite a few days. Now, another case, a 6-year-old boy living in slum. He was evaluated for recurrent severe abdominal pain. He had severe pallor. He had hypertension. The clue, I will give a clue. Who is this? When I show this clue, most 90% of my pages will not say anything. 10% will usually say, so this is Marilyn Monroe. Marilyn Monroe is actually the differential diagnosis. Diagnosis is Elizabeth Taylor. Okay. So what has Elizabeth Taylor got to do with recurrent abdominal pain and pallor and hypertension in a poor slum dwelling boy from Kerala? That then you should remember what was Elizabeth Taylor's favorite hobby. That was getting married. She was actually married 8 times. And this was her ex-6th or 7th husband, I'm really not sure. If you can name him, you can diagnose his condition. Anybody, what's his name? Ex-6th or 7th husband of Elizabeth Taylor, a very famous actor, is Richard Burton. What has Richard Burton got to do with our case? Now look at this line. You can see there's a line here. So this is the blue line or lead line or Burton's line. So that's the relevance of Richard Burton. Now let's see the peripheral smear. Hypochromic microcytic RBCs. You can see the basophilic stippling, cigar cells and pencil cells. What's the diagnosis? So this is consistent with the diagnosis of plumism or lead poisoning. Now, why did he develop lead poisoning? This child had severe pica and his father was a painter also. The lead content of paint is enormous. It ranges from 90 parts per million to up to 1 lakh parts per million. So because of the pica, maybe he was taking a pain which is responsible for him developing lead poisoning. Another case, a 13-year-old boy with abdominal pain of more than 1 year duration. His father died from Gulf 1 year back following a massive upper GI bleed. We do not know what was responsible for the massive GI bleed. He used to have dyspeptic symptoms. So everyone thought that this child was having a functional pain because his father died. But he was having very severe pain, sometimes relieved by food. He used to get up in the middle of the night with severe pain, and he had lost 8 kg in 1 year. So he had lots of red flags. And basic workup was negative. Stool local blood was positive. And you can see that he had a large peptic ulcer, duodenal ulcer. So he had a peptic ulcer disease, just like his father. Another case, a 5-year-old boy with a recurrent abdominal pain of more than 3 months duration. The father is about to return to Gulf. Then he thought that he'll take a consultation with me. This was a rather dull aching, continuous pain. He had severe mileage, severe PM. He had a pallor, he had a lump in the abdomen. And his final diagnosis was a retroperitoneal sarcoma. So this was not a functional pain. He had lots of red flag signs. This is another patient we came across very recently, a 6-year-old boy with puzzling vomiting. He had of more than 2 months duration. He had nocturnal vomiting, severe malaise, significant loss of weight. In 2 months, he lost 5 kg, but not able to go to school for more than 2 months. Since he was also from a Kasaragod area, they went to Mangalore for evaluation. His RFT, LFT was normal, sodium was slightly low, potassium was 5.5, but he had persistent low blood sugar of maybe around 60 to 65 milligram per cent. So he used to be on glucose drips for the hypoglycemia. The TFT was deranged. You can see that his TSH was 10.5. Ultrasound, there is no calcification of adrenals. The MRI was normal. They did a serum insulin because they thought this may be an insulin. Then they thought this may be a psychiatric illness and was referred for psychiatric evaluation, which turned out to be normal. So he was put on antiemetics and supportive measures. IV fluids and thyroxine was continued at 25 microns per day. Then he was referred to a pediatric surgeon who did a very meal follow-through, and that was also normal, and hence he was referred to us for further evaluation. So in fact, he was carried to a room by his father because he was so sick. He looked emaciated. What the striking finding is the pigmentation, the striking pigmentation of the buccal mucosa, the gums, the palm arteries, the digits. He had sparse brownish hair, mild pallor, no jaundice. His weight was less than 3rd centile, height was normal. His BP was only 80 by 60. He was dehydrated. So what will you do? Is the hemoglobin was 9.5 gram per cent. He had hyponatremia and he also had hyperkalemia. What does the X-ray show? Chest X-ray shows microcardia. Okay. Now we thought of the possibility. This possibility: the cortisol was low, ACTH was very high, TSH, in spite of thyroxine, was elevated. Is the anti-TP was positive? Is the MRI abdomen was normal? So a 6-year-old boy with vomiting of 2 months duration, severe lethargy, hyperpigmentation, hypertension, microcardia. So we thought of the possibility of Addison's disease along with hypothyroidism. These are consistent with the diagnosis of polyglandular syndrome type 2. So this child was put on, after resuscitation, he was put on hydrocortisone and fluorocort, thyroxine, and supportive measures were continued. You can see the difference. At diagnosis, he was looking like this. At 2 months, he's very, quite healthy, active, and very pale. In fact, the mother says that he is hyperactive now. So the importance is that the stomach is a huge sympathizer of all other organs. He becomes upset when his cousins are diseased and starts throwing up. So remember that when a child has got vomiting, there are several non-GA causes also for recurrent vomiting. For example, a patient with increased intracranial tension, a slow-growing brain tumor, chronic kidney disease, various inborn errors of metabolism, cyclic vomiting syndrome, and a lot of endocrine causes including Addison's disease. And this child had Addison's disease. Another case, a 4-year-old girl with a jaundice of 6 months duration, born to non-consanguineous parents, PM, soft hepatomegaly. The total bilirubin was just 1.1 milligram per cent, actually upper limit of normal, but it is normal. Conjugate was only 0.2. The transaminases, the alkaline phosphate, everything was normal. Albumin was 3 gram per cent. Viral markers were negative. So what will you consider in this patient? There's no jaundice, but it's referred with a diagnosis of jaundice. How will you proceed? again back to basics. We took a detailed history and we found that the mother was a WhatsApp addict. And once she got a message in the WhatsApp that carrots prevent all diseases. So the mother became very happy. She started giving the child kanji with carrot, milk with carrot, dosha with carrot, and carrot juice. So the diagnosis is carotenemia. Serum carotene was very high, more than 30 milligram%. So how will you differentiate carotenemia from jaundice? The eyes will not be stained in carotenemia. You can see that after stopping carrot, his palm has become normal. So what is the most important clue to diagnosis? It's actually suspicion. Just like this Hitchcock thriller, Suspicion, starring Cary Grant and John Fenton. You should think of other conditions. So always keep the possibility of other conditions also whenever you get any patient for whom we cannot make a diagnosis. So a very careful history taking is very important. 80% of diagnosis from history. A thorough physical examination, that's actually called an eyeball scan. This is actually much more valuable than any imaging modality. 15% can be diagnosed. Investigations only 5%. There's a famous quote by the famous physician Woodward. He said that when you hear hoofbeats, think only of horses, not zebras. കൊളമ്പടി ശബ്ദം കേട്ട് കഴിഞ്ഞാൽ അത് കുതിരയാവാനാണ് സാധ്യത, വേറെ ഒന്നിനെ പറ്റി ആലോചിക്കേണ്ട. This is a very valuable medical principle. Why? Because common is common and rare is rare. So always try to diagnose common conditions first. That's what Woodward said. But in pediatrics, I would like to change it, because in pediatrics, if you don't think of rare conditions, I'm sure that is zebras also. I'm sure that you may miss some severe diseases for which there may be an effective treatment. So as Hippocrates said, cure sometimes, treat often, comfort always. This should be the motto of pediatricians. And this is Alexander Pope, the famous English poet, whose famous words were, I'm sure they are in Karya, to err is human, but to forgive is divine. So doctors are also, we're all doctors like us, we're also human beings. We're all bound to make mistakes. So whenever you got any problem in gastroenterology or hepatology, you can always refer to one of the pediatric gastroenterologists. Nowadays, we have got so many very brilliant young pediatric gastroenterologists in Calicut, all over Kerala, in Cochin, like so many people like Cochin, even Calicut, we have got a very good young pediatric gastroenterologist. If you have got any doubt, you can refer to any of us or any of them. Thank you so much for listening to me.
It was a highly interesting presentation, sir. He was stressing the importance of history taking and physical examination. A few questions, if any, can be entertained.
We will like to inform that we will have the discussion and take questions at the end of all three talks of this session. Thank you, Professor Riaz, sir, for the excellent talk and presentation as always. May I invite Dr. Prashant Pavitran to hand over the memento to Dr. M.V. Haridas. May I invite Dr. Prashant K.S. for the next talk, Acute Pancreatitis in Children. Are we missing? To chair the session, I invite Dr. P.M. Salim, Senior Consultant Pediatrician, CM Hospital, Vadagara. Thank you.
Good morning, my beloved teachers and my dear friends. A warm welcome to our IAP State President, Dr. Shimi Paulos, and past President, Dr. Vijay Kumar to Vadagara. At the outset, let me take a few seconds off to recognize the presence of a great teacher and who is considered as the teacher of teachers by many who know him, Dr. Professor Riaz Arakkal. He was my teacher in Calicut Medical College. He taught me pediatrics there, but also he exemplified the great characteristics and morals of a great teacher, as well as a good human being. Thank you, sir. And as you have seen, he had presented a very interesting topic, and hats off to him. Now coming to today's discussion, we will be discussing acute pancreatitis in children. Are we missing the cases? As you know, pancreas is an important organ in our body. It does the dual role of exocrine as well as an endocrine organ. And in children, acute pancreatitis can be considered as the differential diagnosis of all acute abdominal pain in children. Most of the characters of acute pancreatitis in children can be similar to that of in adults. But there are certain differences also, because in the etiology, alcohol consumption and gallstones are more common in adults, but not so in children. And in children, the more common causes are drugs, trauma, infection, and maybe anatomic abnormalities too. So it is very important to identify these cases early and also treat them early to prevent the life-threatening complications and to prevent mortality. So we will be discussing this topic, and the topic will be taken by a renowned pediatric gastroenterologist from Trivandrum, Dr. Prashant K.S. He is associate professor. He's in the division of pediatric gastroenterology. He is working at present in the Department of the Pediatrics of SAT Hospital, Government Medical College, Trivandrum. He has many publications to his name. He has more than 10 publications in national and international journals. And he has also published 15 chapters in various textbooks of pediatrics and pediatric gastroenterology and hepatology. His achievements are, he was a part of the team who established the first pediatric gastroenterology unit under the government sector in Kerala at SAT Hospital. His areas of special interest are liver diseases in infants and young children. He is also interested in pediatric inflammatory bowel diseases, and he does therapeutic gastrointestinal endoscopy in children. So he will be discussing the various aspects of acute pancreatitis today. Over to you, Dr. Prashant.
Thank you, Chairperson, for the kind words. Am I audible?
Yes.
Yes. Before I go to my talk proper, I feel humble after listening to the lecture by a legendary teacher, our beloved Riyaz sir. And the chairperson has set the tone for discussing the topic, giving a very apt introduction about the topic. So today I am here to discuss the topic, acute pancreatitis in children. So I will be covering the topic, giving a broad overview of the topic, and this is mainly intended for the pediatricians and the pediatric gastroenterologists. During the course of the lecture, I would like to try to discuss how it differs from the adult and what are the key management issues that we have to address while managing a child who has been diagnosed with acute pancreatitis. So for any condition and anything, we'll start with the definition. Acute pancreatitis is histologically defined as the presence of inflammation within the parenchyma of pancreas due to any reason. It could be an infection, it could be a toxin, it could be a genetic reason, it could be a metabolic reason, and even trauma at times. Acute pancreatitis by definition is a reversible process characterized by the presence of interstitial edema, infiltration by acute inflammatory cells, and varying degrees of necrosis, apoptosis, and hemorrhage. Each word is very, very important. Having said about the definition, what are the implications? There are some short-term and short-term implications, long-term morbidity in terms of debility associated with the illness, hospitalization, etc. And having set the tone for acute pancreatitis, I would like to point out that a small subset of cases may in fact develop recurrences because we don't know whether it was the first episode of a recurring pancreatitis, or a small subset could even progress to chronicity. And the long-term fallouts will include exocrine and endocrine insufficiency, because we all know what are the functions subserved by this fiery organ in the gut if offended by an noxious stimulus. Next slide, please. So why do we discuss the topic? Of late, whether it has been a rising incidence or it is a real incidence or is it a high pickup rate, we are not sure, but very elegant publications, I mean sequential publications from same centers over a period of 5 years, 6 years, repeating the etiological spectrum, they do prove that of late there has been an increase in the incidence of pancreatitis in children, so much so that the incidence may be pegged at 10 to 15 cases per 1 lakh children. So what are the professed reasons for this rising incidence? One could be the increased awareness among the clinician about this entity, then the wide availability of appropriate biochemical testing. With regard to this acute pancreatitis, the availability of tests like amylase, lipase, then the wider availability and accessibility to imaging modalities like ultrasound, the rising burden as well as diagnosis of multi-system disorders like lupus erythematosus, HSP, Kawasaki disease, etc. And the ongoing epidemic of obesity in children must also viewed as a pointer in relation to the rising incidence of pancreatitis in children. Next slide. So when we discuss the classical etiology of pancreatitis in adults, the chairperson was alluding to alcoholism, etc. as a very common etiology. Apart from that, biliary disorders are very common. But when we come to the pediatric perspective, we can stratify it into a few set of broad headings. The original classification propounded by Whitcomb et al., they have classified it in using an acronym called TIGARO, wherein T stands for toxin, I means idiopathic, G genetic, A means alcohol or autoimmune pathology, R stands for recurrent, and O stands for obstructive pathology, which includes the biliary pathology as well. In children, the biliary disorders constitute roughly 30% of the cases, which would include gallstones, GB sludge, microliths, etc. The systemic conditions could include lupus erythematosus, Kawasaki disease, then Henoch-Schönlein purpura, then the whole lot of viral infections ranging from mumps, varicella, Coxsackie virus infection, EB virus infection, and at times even the hepatitis A infections can also present with a viral infection. Then trauma, we think that it is a very important cause for pancreatitis in children. Trauma in any form, be it is a bicycle handle injury, sports injury, a contact sport injury, and in this era of rampant child abuse and all, that could also be one of the traumatic causes of pancreatitis in children. And medication form a very substantial chunk, especially in the children who are undergoing chemotherapy. The usual drugs implicated are L-asparginase and a whole lot of anti-epileptic drugs like valproate, carbamazepine. These are a few drugs to mention. Then coming to the structural abnormalities. Structural abnormalities per se may not be the reason that we will encounter as the cause of acute pancreatitis, but if they do recur, we will venture to evaluate. A few of the structural abnormalities include pancreas divisum, anomalous union of the biliopancreatic duct, annular pancreas, etc. Then metabolic diseases. Metabolic diseases also form an important cause of pancreatitis in children. Some of the important causes include hypercalcemia, hypertriglyceridemia, and some of the organic acidemias like propionic acidemia, etc. Then genetic mutations. Again, this all comes in the recurrent pancreatitis, and autoimmune disorders per se are quite rare in the pediatric population. And even after extensive evaluation in a small subset of say 20% or so, the etiology will be a mystery. Next slide. Then these are the broad spectrum of pancreatitis in children. You could see that it ranges from, as from the previous slide itself, it can be varied like biliary, idiopathic, inborn errors of metabolism, medications, metabolic disorders, systemic disorders, trauma, viral, or even unidentified causes. But if we explore the etiological spectrum, one thing, there are a few inferences that we can make. One thing is like inborn errors of metabolism and trauma-like incidents are the inciting risk factors for acute pancreatitis in infants and young children, especially toddlers. Whereas even though biliary risk factors are there across all age groups, they tend to predominate in older children. And roughly 1/5 of the patient, that is around 20%, will have more than one risk factor identified. And again, that is the coexistence of two factors, for example, pancreatitism with genetic factors or things like that. Then in more than 20%, even after exhaustive investigations, the etiology will be a mystery. Next one. Then a few words about the pathogenesis of pancreatitis in children. We have seen the etiology, be it obstruction, injury, infection, genetic, idiopathic, metabolic, or drugs or whatnot. The inciting event will cause a calcium influx that will cause activation of the trypsinogen, trypsin, all these pathway, all these will be activated, and that will set out a whole lot of inflammatory reaction, resulting in the elaboration of inflammatory cytokines like TNF-alpha, interleukin-1, beta, interleukin-6, interleukin-8, etc., resulting in systemic inflammatory response syndrome, which will result in shock, multi-organ failure, pancreatic necrosis, kidney injury, and so many other complications. So this is the usual pathogenic mechanism. And to counter that, the body will be elaborating something called as anti-inflammatory cytokines, and a whole lot of molecules are there. And that will be determining the course of recovery. Then there are some important management points also that will determine the future course of events in the natural history of acute pancreatitis, like early institution of IV fluids and early institution of enteral feeds, which has got a very positive role on the outcome, as we'll see during the management aspect. Next one. Next one. So if we see acute pancreatitis as a clinical entity, it can be divided into two phases based on the period after the symptom onset. So the first week that we call usually as the early phase of acute pancreatitis, and the late phase is after the first week. And based on the severity, for which we rely upon a few set of parameters, which I will be explaining in subsequent slides, you can stratify it into mild, moderate, and severe. The basic tenets of severity will be like the presence of organ failure. If organ failure has been there, it has been a transient one or a permanent one. Permanent one in the sense it is lasting more than 48 hours or so. So on the basis of a pathological basis, it can be classified into edematous and necrotizing, and a small subset do go in for complications. If it is less than 4 weeks, if it is the edematous variety, they could go in for acute pancreatic collection. The edematous variety, if that fluid collection lasts for more than 4 weeks, that could result in the formation of pseudocyst. Whereas if it is a necrotizing variety, under 4 weeks, they will be developing acute necrotic collection, and more than 4 weeks, this is walled off necrosis. This concept is very important in the management aspect, as well as in deciding as well as in choosing the appropriate treatment or referral, as the case may be, depending upon the facility in the attending primary hospital. Next one. So what are the basic clinical features? So Riaz sir in his lecture was mentioning about the difficulty of eliciting symptoms, especially in the pediatric population. So the classical description of abdominal pain, like epigastric pain radiating to the back, etc., may not be there in a child who is presenting with acute pancreatitis, but acute pancreatitis is the predominant symptom in more than 3/4 of the children. The classical symptoms like epigastric pain with radiation to back, they may be elicitable only in a minority, like to the tune of 2 to 6% maximum. So you have an acute abdominal pain. So among the common list of differentials like acute gastritis, etc., we should keep this also as a differential, especially if it is an upper abdominal pain, and if it is associated with nausea, vomiting, or abdominal distension in another 40 to 80%, then 21 to 46%. Along with that, you can have other symptoms like fever, jaundice, ascites, and pleural effusion in a minority of cases. But we really have some practical difficulty in discerning this entity, especially if acute pancreatitis has developed in an infant and toddler, where we may have to pay attention to even subtler symptoms like irritability, nausea, and vomiting. These symptoms have been identified as discerning value in many studies. Next one. Then after the after paying attention to the clinical symptoms, how do we really diagnose? For diagnosis also, again, we have to have some set criteria. Previously, we used to extrapolate the adult guidelines or adult based guidelines, but now we have our own set of criteria, which has been proposed by an international consortium of pediatric gastroenterologists. This consortium is called as the INSPIRE Consortium. It is an acronym for International Study Group of Pediatric Pancreatitis in Search for Cure. They have defined acute pancreatitis, diagnosing acute pancreatitis in pediatric patients. They have reached this consensus. They advocate that it requires at least 2 out of these 3 criteria to emphatically make a diagnosis of acute pancreatitis in a child. So abdominal pain compatible with acute pain. That is the importance of looking at the symptom as a whole. I was mentioning that the classical symptoms you may not be getting, but if you have a real context of upper abdominal pain with associated symptoms, and we really suspect, then we venture for biochemical evaluations like serum amylase and lipase. Again, that has to be more than 3 times upper limit of normal. Along with that, you can order for an imaging finding consistent with acute pancreatitis. Again, there are so many caveats. I will be coming to that. So if you happen to have 2 out of 3 of this criteria, we can very well confidently make a diagnosis of acute pancreatitis. Next slide. So when we encounter a child with acute pancreatitis, what are the basic investigations that you will order? So amylase lipase we have to anyway do, because that forms one of the defining criteria for reaching the diagnosis. Then the other baseline investigations that are ordered are like hemogram. Hemogram is very essential, because you have seen that in the pathophysiology there is a whole lot of systemic inflammatory reaction syndrome, and this can be causing a lot of fluid sequestration in the third space, and that can give rise to a whole lot of other consequences like shock, end organ damage like kidney injury, etc. So we need to have a hemogram to monitor the fluid and hydration status. Renal function tests are important, again, from the prognostic point of view, determining the severity, whether it is a transient one or a long-lasting one, to decide on the severity assessment. Then liver function test, the full panel is required. The serum bilirubin, total direct, the enzymes, ALP, GGT, everything. This may offer a clue towards the biliary etiology in the form of gallstones, choledocholithiasis, etc. Then calcium and triglyceride also form one of the first line investigations in a first episode of acute pancreatitis, because rarely triglyceridemia and hypercalcemia also could be one of the reasons for pancreatitis in children. Next slide. Then moving on to the imaging studies, what are the purposes of doing imaging studies in the setting of acute pancreatitis in children? First and foremost is to make a diagnosis of acute pancreatitis. Then second one will be to exclude other causes. Some can be cholecystitis, sometimes it can be appendicitis, even though the pain is not typically in the epigastric region, but the other differentials can also be identified using an ultrasound evaluation. Then sometimes it may offer clue for a risk factor like biliary disease. You can have gallstones in the common bile duct, etc. And it can also be used for prognostication in assessing the complications. It can be a pancreatic complication in the form of collection, necrosis, etc. It can be extra pancreatic complications like pleural effusion, etc. Next one. So what is the easiest and cheapest tool available for diagnosing acute pancreatitis, imaging tool available for pancreatitis, that is ultrasound. But again, there are 2, even though it is widely available and it has the advantage of non-ionizing radiation, is more child friendly. But again, 2 caveats: the interpretations are highly operator dependent, and imaging pancreas is a tedious task for the radiologist, because it can be obscured quite often by an overlying bowel gas or an obese abdomen, making the imaging little tricky. So what are the diagnostic features at presentation? And another problem is that you may not get the features quite early also. Sometimes initially, if you happen to do quite early, it may be normal also. So at presentation, the features could be include parenchymal changes such as pancreatic heterogeneity, as you see in this image. And the other one you see pancreatic heterogeneity, and you can see the peripancreatic collection also. So all these can be identified using ultrasound abdomen. Next one. Next slide. Then suppose if ultrasound abdomen has been equivocal and we are not able to offer any clue, then probably this is suggested as the gold standard. That doesn't mean that in all cases should undergo this, but if it is the ultrasound abdomen is unrewarding, or if you are not able to clinch the 2 out of 3 criteria, probably you'll have to go for contrast enhanced tomography, which is the CECT. This is actually one of our child who developed severe pancreatitis. In fact, it was a necrotizing pancreatitis during the COVID era, where the child went in for all complications, including pleural effusion also. Again, a point of practical utility while ordering this investigation, this has to be a really timed investigation. No point in jumping for CT scan in the first day, second day like that. You have to wait for at least 72 to 96 hours after the onset of symptom. This is very important to bring out the changes of necrosis, etc. So it has to be a highly timed investigation if you want to get a credible information regarding pancreatitis. Next slide. Next slide, please. Then how do we classify the pancreatitis? I have mentioned previously that it is stratified into mild, moderately severe, and severe based on certain attributes. By mild pancreatitis, we mean that it is not associated with any organ failure. By organ failure, we mean the cardiovascular involvement, renal and pulmonary involvement as defined by international sepsis guidelines. I'm not going to the details of that. Or there is no local or systemic complications like collections and systemic, then pre-existing issues, pulmonary or cardiovascular or renal issues. Moderately severe means it is either the development of transient organ failure. For example, if there is a renal dysfunction that is lasting for no more than 48 hours, that it is a transient one, that it is settling within 48 hours, or development of local or systemic complications. And the severe one, we mean that there will be organ dysfunction that lasts for more than 48 hours, and there will be persistent organ failure that may be single or multiple and may develop and sustain beyond the first 48 hours of presentation. Next slide. So we have the INSPIRE criteria at our disposal based on with the make a diagnosis. Then the next step in the evaluation should be like, is there any organ dysfunction? So 3 organ systems are of main concern to us, whether there is some cardiovascular impairment, renal impairment, and pulmonary impairment. The international sepsis guidelines can be used for that. So if you happen to find that the answer for any of these is yes, then probably the next step would be to look whether the organ dysfunction is transient or whether it is lasting less than 48 hours. If it is yes, then probably we'll label it as a moderately severe acute pancreatitis. If it is no, that is if it is remaining permanent beyond 48 hours, that has to be labeled as severe pancreatitis. So if you don't have any of those end organ issues, dysfunctions, then probably it could be a mild or one that evolves into a moderately severe acute pancreatitis, depending on the presence or absence of local pancreatic or systemic complication, bar exacerbation of prior comorbid disease. The local complications, what we mean are the development of peri or pancreatic complications, which include fluid collections or necrosis, which I was alluding to earlier. And the systemic complications could include exacerbation of previously diagnosed comorbid disease, be it lung disease or kidney disease. Next slide. So what are the management principles while taking care of a child with acute pancreatitis? The most distressing symptom as far as a child is concerned is the pain. So pain amelioration is of pivotal importance in managing a child with acute pancreatitis. Along with, we should be on the lookout for probable inciting factors like gallstone or some metabolic factors. Then the next endeavor should be to halt the progression to severe acute pancreatitis. Here, the management policies that we institute early will determine the fate of progression. and also it will be helpful in preventing the complication of pancreatitis. Next slide. So again, just a recap of the pathophysiology. You have seen that various triggers result in intrapancreatic activation of proteolytic enzyme, which is actually heralded by a calcium influx resulting from a multitude of stimuli. The outcome of all these are mainly three types. One is a local inflammation that results from leukocyte activation, cytokine release, which I was mentioning, of which interleukin 6 is a major culprit, oxidative stress resulting in many end-organ damage. Then there will be a systemic inflammatory response syndrome that will cause cellular dysfunction that can result in local and systemic micro circulatory dysfunction. There will be a lot of microthrombi, hypoperfusion, and all this will be perpetuating. Along with that, there is a intravascular fluid loss resulting in increased capillary permeability, fluid accumulation in the into the extravascular space. This could manifest with ileus and GI losses. So this is like a two-way thing. You have hypovolemic shock one side, and that will progress to multi-organ damage, and this is like a cascade. So ultimately, if the compensatory anti-inflammatory response syndrome take an upper hand, then that will go in for recovery or regeneration. If the systemic inflammatory response reaction is not aborted and it continues unabated, that will go on for a whole lot of multi-organ dysfunction as well as pancreatic necrosis. Next slide. So the cornerstone of management is fluid resuscitation. Fluid resuscitation will help in tackling the hypovolemia that ensues acute pancreatitis. I mentioned that improves the pancreatic perfusion, it improves the microcirculation, then it reduces the risk of necrosis. So what are the fluids? What is the fluid of choice in managing? It could be any of the crystalloids, ring or lactate. If it is available, that could be the first line. If normal saline can also be a crystalloid of choice if an ringer lactate is not available. Then what is the rate of fluid administration? Here again, we don't have adequately powered pediatric studies. These are extrapolation. It is like 1.5 to 2 times maintenance IV fluids with monitoring, with the careful monitoring of the end-organ damage, especially the renal function. We have to monitor the urine output for the next 24 to 48 hours. So management along with the monitoring is the key. We have to monitor the vital signs at least every 4 hours during the initial 48 hours of admission and during periods of aggressive hydration to monitor for oxygen saturation. That will tell about the pulmonary involvement, blood pressure for the cardiovascular impairment, and respiratory again for for the pulmonary involvement. Along with that, we should keep a tab on the blood urea, creatinine, and urine output, and that should be monitored routinely during the first 48 hours as a marker of appropriate fluid management and also to screen for acute kidney injury. Next slide. Then pain management. Pain is again a multifactorial, which is not the purview of the current discussion, but this is a most distressing symptom the child faces during the insult. So it is a very important therapeutic goal also. So what are the drugs in the armamentarium? Acetaminophen, ibuprofen are the first line agents preferred, and for severe pain, opioids are advised. IV morphine or other opioids should be used for acute pancreatitis not responding to acetaminophen or NSAIDs. So this is the pain relief is a very, very important aspect in the management of acute pancreatitis. Next one. Next slide. Then a very important point to ponder upon. This is a very important, but at the same a very neglected point, because partly because managing acute pancreatitis in many centers used to be the realm of the pediatric surgeons. So there are several practices that are being professed, like keeping the child NPO for a prolonged period. These are all not desirable practices because we have elegant studies which have shown that early institution, how early, as early as 48 to 72 hours, if we institute enteral nutrition, that will prevent bacterial translocation. You have seen that SIRS, capillary leakage, and all these are the key factors in the pathogenesis. All these can be aborted if we start the natural way of nutrition. And it is so much so that it has been shown to decrease the cytokine response and the increase of and the incidence of gastroparesis and the attendant motility problems like intestinal ileus. Yes. So for a mild acute pancreatitis, we have to have early nutrition, preferably within 48 to 78 hours. Oral, it has to be wherever possible, it's by the mouth. It has been shown to decrease the length of hospital stay and also decrease the risk of organ dysfunction. If oral feeding is not possible, you can try enteral feeding using nasogastric or nasojejunal. Between the two, there is not much of a difference, and no need for a special formula and all. You can use a regular polymeric enteral formula when the child is not able to take orally. So if there are real contraindications like some complication, vomiting, ileus, etc., then we have to try for parenteral nutrition. So the bottom line is early enteral nutrition should come in as soon as feasible, and not to keep the child fasting for days altogether. Next slide. Next slide. Then this is the next common confusion. That is a common concern, whether we should start antibiotics per se. So anyway, there will be SIRS, there will be some sort of leukocytosis, elevated acute phase reactant, etc. Prophylactic antibiotics as a rule, as a guideline, are not recommended. Having said that, there are well-laid indications also. Wherever you anticipate some systemic infectious complications like systemic infectious complications, cholangitis, that is ascending infection of the biliary tract, or suspected infected pancreatic necrosis, these are the settings where you have to have an antibiotic. Again, there are some guiding principles in the selection of antibiotics also. The regular antibiotics that we may use may not be having the desired penetrability into the intrapancreatic tissue. So these are the antibiotics that have been found to be useful, like imipenem, meropenem, fluoroquinolones, and metronidazole, not the regular antibiotics that we use for respiratory or even urinary tract infections, etc. Next one. So these are the 3 or 4 points which we should focus upon, like fluid resuscitation, amelioration of pain, emphasis on nutrition. Then what are the settings where you will start antibiotics? Then there are a few settings. I have earlier elucidated the usual trajectory of acute pancreatitis. So we have two sets. If you recall the initial slide, we have the interstitial pancreatitis and necrotic pancreatitis, necrotizing pancreatitis. If they develop fluid collection and it is less than 4 weeks, we call it as acute peripancreatic collection. If it lasts for more than 4 weeks in the setting of an interstitial pancreatitis, it is called as pseudocyst. If it is in the setting of a necrotizing pancreatitis, if it is less than 4 weeks, it is called as acute necrotic collection. And if it lasts more than 4 weeks, it is called as walled-off necrosis. These are the scenarios where you will warrant referral, because many of the time they can develop complications. It can be not only infection, but other complications like hemorrhage. Then sometimes they may present with obstructive symptoms like gastric outlets obstruction, etc., as in the case of pseudocyst or walled-off pancreatic necrosis. Next slide. Is there any role for advanced endoscopic procedures? This is slightly higher end, but for the sake of completion and in the interest of the postgraduates as well as the practitioners, there are select indications for advanced endoscopic procedures in children with acute pancreatitis. This is one of the indications for ERCP. ERCP is endoscopic retrograde cholangiopancreatography. One of the indication will be like choledocholidiasis. There is a stone in the bile duct causing biliary pancreatitis. Then other pancreatic duct pathologies such as ductal stones or ductal leaks, that will be ductal stones that will be most usually encountered in the scenario of chronic, but ductal leaks, etc., are possible in the setting of trauma and all. Then there is another modality called as endoscopic ultrasound also. Here it has a diagnostic as well as a therapeutic role. Diagnostic in the sense for evaluation of choledocholidiasis, biliary sludge, evaluation of the pancreatic parenchyma, duct and hepatobiliary anatomy as in the case of many of the anomalies. Then it may have a therapeutic role, which I was earlier referring to the complications like pseudocyst and pancreatic necrosis, where you can have drainage without a scar using these endoscopic techniques. Next one. So this is actually a pictorial depiction of the endoscopic, advanced endoscopic procedure. The top panel shows the ERCP being done for a biliary calculi. You can see the pigmented stone. The second panel actually shows an endoscopic ultrasound image depicting the CBD stone. You can see that the arrows, the yellow arrows actually point to the stones within the CBD. You can see that the CBD is also dilated. Next one. So what is the role of pancreatitis? So if it is a biliary pancreatitis, we'll have to do cholecystectomy. That is one role. Then the other setting will be like for complications like walled off pancreatic necrosis, which are not amenable to drainage using endoscopic or radiological interventions. We may have to resort to surgery. Next one. So before I conclude, these are the key messages which I would like to deliver. As pediatricians, we all should be aware that incidence of acute pancreatitis in children are on the rise. And we should be aware of the clinical presentation, subtle presentation, especially in the toddler age group, etc. And the risk factors of acute pancreatitis in children are multifactorial. And the management of acute pancreatitis in children requires early aggressive fluid management, nutritional therapy. That is, you have to start early enteral nutrition. You have to have adequate pain control along with addressing the inciting factors, which has resulted in the acute pancreatitis. Thank you all for the patient listening.
Thank you, Dr. Prashant. It was a wonderful presentation. As was expected, you had highlighted all the key important factors in acute pancreatitis. So it is not a very rare disease nowadays, and we have to keep it in the differential diagnosis of all acute abdominal pain. And you have highlighted the importance of early enteral nutrition as far as possible. During the acute stages, we keep them nil orally without and with IV fluids. But enteral feeding as soon as possible, as is wanted by the circumstances, it can decrease the hospital stay as well as lead on to early recovery also. Thank you, Prashant, for that wonderful presentation. And can we have a few questions from the audience?
Sir, I think the questions are at the end of the third talk. It's like a combined session of 3 talks.
Okay then, okay then.
Okay.
Thank you, sir.
So we'll conclude this topic.
I request Dr. Jagdish Menon, pediatric hepatologist, Rela Institute, Chennai, to give a token of appreciation, a memento to Dr. P.M. Salim for chairing this important session. Thank you, Dr. Jagdish. We move on to the next talk, that is acute viral hepatitis, the need for recognizing atypical variants, and is universal immunization for hepatitis A necessary? We have Dr. Adira Ravindranath, and chairing this session will be Dr. Harshida, pediatrician of CM Hospital, Vadagara. Over to Dr. Harshida.
Very good morning to all respected seniors and dear colleagues. It's a great privilege and honor to chair this session in the presence of my beloved teachers, Riyaz sir and Vijayamar sir. Since we have multiple diffuse outbreaks of viral hepatitis in North Kerala for the last 1 month, I would say it was talk of the hour. And with great pleasure, I introduce the speaker, Dr. Adira Ravindranath, consultant pediatric gastroenterologist, Apollo BGS Hospital, Mysuru. She did her post-graduation from AIIMS, Delhi, and super specialization from SGBGI, Lucknow. She is someone with an extravagant academic profile, bagging multiple gold medals and authoring multiple papers and chapters. Over to you, Dr. Adira. Thank you.
A very good morning to all of you. First of all, I thank IAP Kerala for this wonderful opportunity, and my sincere apologies for not being able to be there physically, and my heart goes out to the victims of the Wayanad tragedy. So without wasting time, let's go to this topic. Acute viral hepatitis. Is there a need for recognizing atypical variants? And the next part of my talk will be, is there a need for universal immunization for hepatitis A? So let's look at a typical case of hepatitis A. So it usually starts with exposure to the hepatitis A virus. It is usually fecal-orally transmitted. And then the child will develop, after an incubation period of 15 to 45 days, the child will start having prodromal symptoms in the form of fever, nausea, some abdominal discomfort, vomiting, etc. And thereafter, the icteric phase is there, during which the patient may present to us. In most of the cases, the icteric phase will resolve within a period of 1 to 2 months, and the child will recover uneventfully. And during this period, when you measure the IgM against hepatitis A, it will be positive, which will help us in making a diagnosis. So this is the typical hepatitis A, which most of us encounter, and most of the cases are falling into this typical hepatitis A spectrum. Apart from the classical hepatitis, we have complicated hepatitis and atypical hepatitis, which will be seen in about 30% of the cases. So in complicated hepatitis, what do we mean? They may present with liver failure. So it could be a hyperacute liver failure or an acute liver failure or a delayed, that is called a late onset hepatic failure or a subacute hepatic failure. Or if these children have an underlying chronic liver disease, which was silent until now, they may present like an acute on a chronic liver failure. So all these complicated cases will have one thing in common, a deranged PT-INR, that is a coagulopathy with or without an encephalopathy. How about atypical variants? They don't fall under the classical hepatitis category, neither a complicated category. So these atypical manifestations can be classified as hepatic and extrahepatic. So hepatic manifestations include prolonged cholestasis, relapsing hepatitis, a cytic form of acute viral hepatitis, and acute viral hepatitis which will act as an autoimmune trigger. Apart from these, there are a lot of extrahepatic atypical manifestations which we would encounter. That will include intravascular hemolysis, especially in a child with an underlying G6PD deficiency, sometimes aplastic anemia, immune thrombocytopenia, hemophagocytic lymphohistiocytosis, Guillain-Barré syndrome, transverse myelitis, glomerulonephritis, myocarditis, and myositis. These are relatively rarer than the hepatic manifestations, although we would still encounter a lot of cases with intravascular hemolysis. So classical viral hepatitis will form a lot of overlap with these. So a prolonged cholestasis, late onset hepatic failure, relapsing hepatitis, and the ascitic form, which we discussed. But they will have another overlap with cholestatic forms of chronic liver disease or cholestatic forms of drug-induced liver injury. So these may complicate a classical viral hepatitis, especially if they take some complementary alternative medications. What are the other differentials for a relapsing hepatitis? It could even be an underlying autoimmune hepatitis presenting as a relapsing form, sclerosing cholangitis, or even familial cholestatic syndromes, which can present again and again with jaundice. When a child comes with an ascitic form of acute viral hepatitis, the other forms that you should keep in mind are the decompensated chronic liver disease or acute on chronic liver failure. We will go to each of these conditions separately. So this is one of the articles that I had written with my teacher on the atypical variants of acute viral hepatitis, which is available open access in the World Journal of Hepatology, which you can refer to. So let's look at a case of prolonged cholestasis. So the child had baseline jaundice, which increased. By about 3 to 6 weeks, this jaundice suddenly increased exponentially, which was associated with pruritus, which again increased exponentially, and with pale stools. So this is the usual presentation of a prolonged cholestasis. And during this period, the child was also found to have coagulopathy, but after giving a dose of vitamin K, parenteral vitamin K, the coagulopathy got corrected. So meaning to say that it was a cholestasis which led to vitamin K deficiency that led to the coagulopathy. And during this phase, when we look at the liver enzymes, there is significant elevation of alkaline phosphatase and gamma-glutamyl transaminase, which is different from what we see in a classical hepatitis, where you see that the enzymes are elevated. The AST and ALT are elevated in thousands, and not especially the alkaline phosphatase and the GGT. The child had a lot of fatigue, and the family followed a lot of dietary restrictions, which is commonplace when the child has jaundice, and which led to an increase in fatigue and weight loss. So this is something which we should tell the parents, that there is no role of dietary restriction. There is no role of drinking sugarcane juice. They have to eat normal diet. So during this phase, he was started on ursodeoxycholic acid, to which he didn't respond. Later on, he required rifampicin and cholestyramine and also naltrexone for improvement in his pruritus and the cholestasis. So not all children require all these medications. Only the most severe forms we need to give it. So let's look at the prolonged cholestasis phase. How often do we see it? We see it in about 4.5 to 15% cases of hepatitis A. But look at this graph. Most of the cases with prolonged cholestasis happens in children more than 10 years. Look at the gray graph. So in more than 10 years, they had about 25% cases of prolonged cholestasis, whereas in younger children, it was much lesser. So this we attribute to probably some polymorphisms in the ATP binding cassette proteins involved in the bile acid transport. And it's also more predisposing the adolescents to cholestasis than the younger children. So how do we treat this prolonged cholestasis? So most of them required UDCA, some of them require rifampicin, some of them require cholestyramine, which is a bile acid sequestrant. Now, many a time people ask me, how does rifampicin help in cholestasis? Rifampicin has been notoriously named as a drug which causes liver injury when we use it for treatment in tuberculosis. Rifampicin helps in transporting bile acids, so by acting on certain pregnin X receptors, and that's how it helps in prolonged cholestasis as well. So if you have 100 cases of prolonged cholestasis, almost all of them require UDCA. About 1/3 will require rifampicin, and about 6% only will require cholestyramine. So not all of them require the other medications. And only for refractory cases, you need to give naltrexone. And sometimes when nothing works, they may require plasma absorption in the form of plasma exchange or plasmapheresis. So when there is prolonged cholestasis, apart from the atypical variant of hepatitis A, what differentials do we consider? One, most important, is a drug-induced liver injury, which will cause a cholestatic pattern. The natural tendency of a lot of people in our country is to take complementary alternative medications when there is jaundice. And the medications per se can cause cholestatic injury and cause prolonged cholestasis. The other differentials are a progressive familial intrahepatic cholestasis, sclerosing cholangitis, or any other cause of extrahepatic biliary compression. Why have I elucidated these diseases is because you may not always have the history of hepatitis A, and they may come to us for the first time in that cholestatic phase. In that case, you should have a wider differential diagnosis to consider. Next atypical manifestation is a relapsing hepatitis. How does that present? So there will be jaundice. The jaundice would have come down. Jaundice may be accompanied by elevated transaminases. After a period of 4 to 8 weeks, when the child was actually well with no jaundice, there is a recurrence of jaundice. Sometimes even the second phase may have a cholestasis. So it may be a combination of relapsing hepatitis with a cholestatic phase. And this may last for, again, 6 to 10 weeks. And they may have similar such episodes, varying from 2 to up to 7 to 8 episodes have been reported, even in a typical case of hepatitis A. So that is called a polyphasic relapsing hepatitis. So here, during this period of wellness also, the HIV RNA was undetectable in serum. Okay, so this is actually, it is not a reinfection, but people say that it is because of the change in the enterohepatic circulation, and the HIV RNA goes back into the liver and causing the relapsing hepatitis. So there is a lot of variation from relapsing hepatitis, because the interval of normalcy can vary from weeks to months. And this relapse can also be anectric. So they may just present with elevated liver enzymes without actually presenting to you with jaundice in about 2 to 4% cases. It's difficult to diagnose the anectric phase because we may not test the LFT if the child is otherwise well. And even in the second or the third relapse, there may be a prodrome preceding the relapse. So that is also variable. And the peak of the enzymes are also variable. And in any of these relapses, they can go into a liver failure or they can go into a cholestatic phase. So you must remember, when they come with a relapse, you have to work up similar to the initial workup. You have to check your PTINR. You have to see if the child is going into hepatic encephalopathy and follow up these patients to see if they're going into the cholestatic phase of hepatitis A. So again, when a child is coming with history of recurrent jaundice, when you don't know whether there was a hepatitis A or not, what are the other differential diagnoses that you have to consider? Autoimmune hepatitis. In about 1/3 cases of autoimmune hepatitis, the presentation will be like a recurrent jaundice. Okay, the other differentials are sclerosing cholangitis and again progressive familial intrahepatic cholestasis, where again the recurrent patterns of jaundice will be accompanied by a lot of pruritus, which will help you make a diagnosis. Now, if you don't know whether the jaundice is conjugated or unconjugated, then the differentials to be considered would be a Gilbert syndrome and an underlying hemolytic disorder, where they may present with recurrent episodes of unconjugated hyperbilirubinemia. In case of Gilbert syndrome, we don't have to do anything. We just have to confirm the diagnosis and reassure the family. But if you feel that it is not a hepatitis A, then we have to work up for the other causes of recurrent jaundice. The next atypical manifestation is acute viral hepatitis with ascites. So the routine teaching is that when a child with jaundice has ascites, what are we supposed to think about? We are only going to think about an underlying chronic liver disease. But interestingly, a small subset of patients with just an acute viral hepatitis can still develop ascites. So there was jaundice, the jaundice subsided, and the jaundice was accompanied by ascites. So if the child is presenting to you at this point of time, you would still consider an underlying chronic liver disease, because usually we don't see ascites in the presence of an acute viral hepatitis. So in most of the cases, the ascites will resolve between 2 to 8 weeks. A very small proportion may require diuretics. And if you do a diagnostic tap of this ascitic fluid and assess, 13% will have ascites, and out of which all of them will have a high SAG. What is SAG? Serum albumin ascites gradient. You measure the serum albumin and subtract the ascitic fluid albumin from here. And if it is more than 1.1, then it means that the ascites is associated with portal hypertension and not anything else. So in about all the cases, the ascites will be high SAG, and these cases may have an underlying predisposition for a spontaneous bacterial peritonitis or the ascitic fluid infection. And some of them may be accompanied by pedal edema and hydrothorax, and about 40% will require diuretics. But the reassuring fact is that all of them will have complete resolution by the end of 2 to 3 months. So if it doesn't resolve, then again, it is a point of concern that maybe you're dealing with an underlying chronic liver disease. So there is a thin line between working up for a chronic liver disease and also not overworking a diagnosis in a child with AVH with ascites. So how does this happen? Why does ascites happen in just an acute viral hepatitis? So when there is acute viral hepatitis, there is hepatocyte dropout, which will lead to sinusoidal collapse and leading to a transient portal hypertension. Although it is not a chronic liver disease, there is some portal hypertension, and many of these children are malnourished, and they may be having a borderline albumin levels, which will lead to formation of ascites. And as the hepatitis resolves, all the sinusoidal collapse and transient portal hypertension will go back to normal, and the ascites will resolve. Now, what do you do about the malnutrition? You have to tell them to feed normally. And second thing is to avoid unnecessary IV fluid administration. If the child can eat well, do not give IV fluids in a case with acute viral hepatitis, because it will only predispose to ascites and pedal edema, etc. So ascitic form, on the contrary, like how we saw the prolonged cholestasis form is seen more often in older children, the ascitic form is seen in younger children. They have a low serum albumin, low serum protein, and some of them had prolonged PTINR to start with, but not all of them have an acute liver failure. So avoid unnecessary fluid administration. And to begin with, you can advise them salt-restricted diet and fluid restriction. And about 40% of them may still require diuretics, because as we saw earlier, all these ascites are high SAG ascites. So they will all respond to diuretics. And if there is ascitic fluid infection, they may require antibiotics. But otherwise, there is no role of antibiotics in acute viral hepatitis with any atypical form. And only in very rare situations, you need to do a large volume paracentesis along with albumin infusion. But if it comes to that, you should still keep in mind an underlying chronic liver disease. So when you see an ascitic form of acute viral hepatitis, you rule out a chronic liver disease before saying that, yes, this is only an ascitic form of AVH. Follow up these children until the ascites completely resolves. So the differential diagnosis will be a decompensated chronic liver disease or an acute on a chronic liver failure or a late onset hepatic failure. Now, what is the difference between all these things? A decompensated chronic liver disease means that there was a chronic liver disease which has been present for a long period of time, and then the child is developing decompensation, synthetic dysfunction in the form of ascites, developing encephalopathy, etc. What is acute on chronic liver failure? There was a chronic liver disease which was stable or silent, known or unknown, and now there is hepatitis A infection which has unmasked the chronic liver failure, chronic liver disease, and which would have led to a liver failure. Late onset hepatic failure or the subacute hepatic failure is another atypical manifestation of AVH, which we will see. So usually when a child develops encephalopathy, we are concerned. That means a child has gone into a hepatic failure. So when the jaundice to encephalopathy interval is 1 week, that means child presented with prodrome jaundice within 1 week has gone into encephalopathy. That is called a hyperacute liver failure. Now, if this interval increases to 4 weeks, that is, a jaundice started 1 month back and the child became encephalopathic after 1 week, any time between 1 to 4 weeks, then you call it as an acute liver failure. But not all of them will develop encephalopathy within this time period. A small proportion will develop a late onset hepatic failure, wherein they will develop encephalopathy after 5 to 12 weeks of the onset of jaundice. So when you talk about severe hepatic dysfunction, it could be an acute liver failure. That means a child came and developed liver failure, which will be very obvious, especially the hyperacute and the acute variety. The other one is when the child had a chronic liver disease and the acute hepatitis A precipitated a liver failure. So again, there will be some clues for the acute liver for the presence of a chronic liver disease, like CLD stigmata may be present when you examine these children. The liver may be firm, spleen may be larger than usual. You may still find a tip of the spleen palpable in a typical case of AVH, but if there is a chronic liver disease, the spleen may be larger than usual. You may find some abdominal veins, and when you ask for investigations, especially on the ultrasound, you please ask for the portal vein diameter, the portal flow, or any other imaging features of an underlying chronic liver disease. If it is there, then we work up for the chronic liver disease. But these are two extremes. Late onset hepatic failure is the other end of the severe hepatic dysfunction, where they may present late with either encephalopathy or ascites. So when you look at the epidemiology of late onset hepatic failure, you see that 80% of all hepatic failure associated with hepatitis A could be acute liver failure. And about 12% may be like an acute on chronic liver failure. 8% will be a late onset hepatic failure. So you're going to see it very, very rarely. But when you see it, we have to see whether there is an underlying chronic liver disease or not. If not, he will fall into the criteria of late onset hepatic failure. So when the child presents with subacute hepatic failure, they are at risk of complications, just like a chronic liver disease, like a spontaneous bacterial peritonitis, pneumonia, urinary tract infection, bacteremia, acute kidney injury, coagulopathy, etc. So they behave like a chronic liver disease, but they do not have a chronic liver disease, okay? And they don't develop a raised ICP, raised intracranial pressure, like a hyperacute liver failure. All these children who present like a hyperacute liver failure will predominantly present with a raised ICP, whereas a late onset hepatic failure will present with chronic liver disease-like features like ascites and encephalopathy without any raised ICP. But liver biopsy in these cases, you should not do, but whenever they did in the previous studies, showed only multi-acinar necrosis. It did not show any underlying chronic liver disease. So 25% only will recover from a late onset hepatic failure over a period of 6 months. Poor outcome is noted in about 60 to 75% of the cases, with the cause of death being sepsis, acute kidney injury, coagulopathy, and GI bleeding. So again, the differential diagnosis here would be an underlying decompensated chronic liver disease, which we should actively look for. And a PELD score of 32 has a very good sensitivity to predict, more than 32 will predict the poor outcome in these children. Now, intravascular hemolysis is not a hepatic manifestation of acute viral hepatitis, but we see it very often because these children will present with jaundice preceded by prodrome. And what do we do when they come with jaundice? The immediate reaction is to give vitamin K. Okay, or some other medications which may be contraindicated. Some of these children may even receive anti-malarials, especially in the high endemicity belts. And after this, what would happen? There's a sudden increase in jaundice, fall in hemoglobin, and it may lead to pigment nephropathy. And the classical history that they would give you would be that the child had yellow colored urine, and now suddenly the jaundice has increased and the urine color is cola colored. Once you see it, you'll never forget it. It'll be like the Coke. And when you do the investigations, bilirubin will be extremely high and AST will be more than ALT. Okay. In acute viral hepatitis, ALT will be more than AST, whereas in this scenario, because of the intravascular hemolysis, AST will be more than ALT. And these children will have very high LDH. The smear will show a hemolytic picture. There will be a high retic count. And if you're able to do a plasma hemoglobin, that will also be high, or a urine hemoglobin, which will be detectable. So this is going to give you the clue for an underlying intravascular hemolysis. So about 36% of these children, especially boys, will have an underlying G6PD deficiency. But also remember that HAV per se can cause some amount of autoimmune hemolysis. And you should remember that when you see jaundice followed by a hemolysis, it may not always be an acute viral hepatitis. You can also consider cases of Wilson disease. An acute severe Wilson disease can present with intravascular hemolysis. And autoimmune hepatitis can also have an underlying autoimmune hemolysis. So these are the differentials that we have to consider. If you do not have an HAV IgM positivity in the background, then you should consider an underlying Wilson disease or an underlying autoimmune hepatitis as a cause of the intravascular hemolysis in association with jaundice. What is the other atypical manifestation? Children with acute viral hepatitis, about 63% will have autoantibody positivity. It could be an anti-smooth muscle antibody or an anti-nuclear antibody. Most of them have an ASMA positivity. Now, are we dealing with hepatitis A or are we dealing with autoimmune hepatitis? So we don't know whether it's a true autoimmunity or it is false positive. Why do we say false positive? Because all these antigens are secured. They are in a sanctuary within the hepatocyte. So when there is an acute viral hepatitis and destruction of the hepatocytes, these antigens are exposed, because of which there will be autoantibody generation. So it may be just transiently positive, and once the hepatitis settles, the autoantibodies will also resolve, and they may not actually have an underlying autoimmune hepatitis. But in some cases, hepatitis A can be the trigger. So it exposed the antigen, and now the child has developed autoantibodies, which is not resolving. So those are the confusions that you will encounter when you have an ASMA-ANA positivity. So when they looked at the gamma globulin fractions in these children, in controls, the average gamma globulin values were about 1.3 grams, whereas those with just hepatitis A, where hepatitis A led to a false positive ASMA, the IgG level was about 1.9 gram, whereas in true AIH, in true autoimmune hepatitis, it was much higher, way higher. It was about 2.9 grams. So the level of antibody elevation would, a level of gamma globulin elevation will give you a clue that this could be a true autoimmune hepatitis and not just a false positivity. So when you look at the ROC, when you, the cutoff point for IgG levels will be 2 grams. So anything more than 2 grams may suggest an underlying autoimmune hepatitis and not just a false positivity. So many of them will have some predisposing HLA loci, which will predispose them to autoimmune hepatitis and persistent HAV infection. So basically, HAV is persistently there at a small level. The RNA is there and causing liver injury, which is triggering the autoimmune response. So again, when do we do the autoantibodies in AVH patients? No, we don't do it. But we definitely would check for autoantibodies when they present like a relapsing hepatitis kind of picture. So we have to keep it in mind that apart from HAV per se, an autoimmune hepatitis may present like a relapsing hepatitis. Now, what are the other hematological manifestations? About 5 to 11% of hepatitis can be associated with aplastic anemia. Okay, this is more likely seen in adolescent males, and this is related to CD8 T cell mediated bone marrow suppression. But they have very, very poor prognosis because this kind of aplastic anemia will not recover on its own, and they will require bone marrow transplantation. And once they get transplanted, they have a good outcome. The other hematological manifestations include immune thrombocytopenia because of the IgG glycoprotein 2,3A, and leukopenia can also be seen. So these are the rarer hematological manifestations, but definitely we are concerned when there is an aplastic anemia. So HAV can sometimes trigger an HLH also, hemophagocytic lymphohistiocytosis. So they can present with HLH at the index admission itself, or they can even present up to 4 weeks of the hepatitis A infection. So if they're presenting with prolonged fever and cytopenias with splenomegaly, you have to think about HLH and look for the other criteria, measure their triglycerides, measure their fibrinogen, and then look for ferritin and hemophagocytes in the bone marrow. And in that case, then you can give them IVIG or methylprednisolone or follow the HLH protocol for management of these children. The other atypical manifestations, which are extrahepatic, which are not hematological, will include neurological. Sometimes it may trigger a Guillain-Barré syndrome or mononeuritis multiplex, transverse myelitis, myasthenia gravis. Acute pancreatitis may sometimes be there in an episode of acute viral hepatitis. So if a child is having persistent pain, don't assume that it is just because of hepatitis. Always check for your lipase levels. Glomerulonephritis is also rarely seen, cardiomyopathy, myositis, sometimes other autoimmune conditions like cryoglobulinic vasculitis, antiphospholipid antibody syndrome, and SLE may be the other atypical manifestations. So these are rare, but when you encounter them, it's important to recognize them. So this is a summary. Acute viral hepatitis, 75% will be classical, where you don't have to bother about the atypical manifestations. About 4% will be complicated. Complicated meaning they are going into some sort of liver failure. It could be hyperacute, acute, or late onset. But if it is a late onset, always look for an underlying decompensated chronic liver disease or an acute and chronic liver failure. Even in the others, hyperacute and acute liver failure, also look for underlying chronic liver diseases. About 20 to 30% cases may have atypical viral manifestations, atypical viral hepatitis manifestations, which will include prolonged cholestasis, relapsing hepatitis, acute viral hepatitis with ascites, or intravascular hemolysis. The other manifestations are rarer. The hematological, neurological manifestations are rarer. So we look for these atypical manifestations and work up. So here there is you have to have a very thin line to decide when to investigate further, when to stop investigating after acknowledging the fact that, yes, this is an atypical manifestation, so let us wait. So if the child is not a liver failure, definitely the child is giving you time to wait, and also rule out an underlying chronic liver disease. Now, the next part of my talk is about hepatitis A, whether universal immunization is recommended or not. Now, if I look at it from my point of view, it's going to be a very biased opinion, because I'm going to say that, yes, please vaccinate these children so that these children don't develop these atypical manifestations or complicated hepatitis A requiring liver transplantation, etc., etc. But let's look at it more pragmatically. Let's look at the epidemiology of hepatitis A. So if you look at this is a very recent study done in India, where they looked at the seropositivity of children between 1 to 5 years of age. So when you look at it, between 12 to 23 months, for the second year, about 39% only had the seropositivity. But as they grew older, it increased up to 47%. But still, in a country like India, this is a multi-center study, the increase in the seropositivity, even at 5 years, is not very impressive. That means they were still not exposed to hepatitis A infection, because most of these children may not be symptomatic. Most of the younger children with hepatitis A may have an anecteric hepatitis A, and you may not even recognize that this was a hepatitis A infection. We may treat them like a routine viral fever and leave it at that. Okay, but what is the problem here? the factors which are associated with the hepatitis A seroprevalence, if you look at it, those who used candle filter, those who used boiling, reverse osmosis, those who had a past history of jaundice and the education of the mother, if it was better, they all had a they all had a lower seropositivity. Meaning to say, better the hygiene, lower the chances of acquiring hepatitis A in childhood. And now what has happened because of this? The epidemiological curve has shifted to older age group. So what we see as an anecdotic hepatitis in a young child may lead to a very severe form of hepatitis leading to liver failure in an older child or an adult. So this is the concern that we have right now. So let's have a look at the endemicity pattern of hepatitis A. If you look at a high endemicity area, by 10 years of age, 90% of these children will have seropositivity. That means they would have been exposed to hepatitis A in some way or the other. In intermediate endemicity, by 15 years, 50% will be having seropositivity, but less than 90% by 10 years. When you look at the low seroprevalence areas, by 30 years also, only 50% is seroprevalent. But by 15 years, it is less than 50%. And the very low endemicity means even by 30 years, less than 50% only have seropositivity. That means more than 50% of these adults at around 30 years of age are still predisposed to developing hepatitis A. So this is the population that we are worried about, the older children and the adults, because if they get a hepatitis A, they may develop a more complicated disease than the young children who are getting hepatitis A. And with improvement in the socioeconomic status, India is slowly going from a high to intermediate to low and very low seroprevalence patterns. Of course, it is varying between state to state, district to district, and the vaccination decision making should be based on which state or which district we are considering. Now, when you look at, this is a systematic review which looked at the economic evaluation of hepatitis A vaccine in various countries. Okay, so here they included high income and middle income countries where they concluded that vaccination without screening is cost effective. What does it mean? So if a child comes to you, say about 10 years of age, when you don't know whether the child had hepatitis A or not, you can measure the anti-HAV IgG antibody or the total antibody against hepatitis A. If it is positive, it means that the child was already exposed to hepatitis and you don't need to vaccinate. If it is negative, then you vaccinate. But in this systematic review, they have concluded that even without screening, vaccination is cost effective in middle income countries. That is, irrespective of their anti-HAV IgG status, you vaccinate all of them. But here, most of the included middle income countries were from the intermediate endemicity areas. So the same rule may not apply in a high endemicity area, even though it could be a middle income country. But definitely in adults, screening and vaccination is cost effective. But in children, it is doubtful because in middle income countries, intermediate endemicity alone were included. Now, this is a very interesting article which was published very recently in PLOS One, where they looked at the cost-effective analysis of hepatitis A vaccination, especially in Kerala. So HAV seroprevalence in Kerala in those less than 15 years has been varying between 4 to 10%, which is very, very, very less. So it may be a low or a very low endemicity area. So in our state of Kerala, if you want to vaccinate all those children less than 15 years of age, if you vaccinate all of them, either with killed or live vaccine, the government or the whole the vaccination strategy per se will actually save so many rupees, like 5.8 million rupees to 10 million rupees. Okay, at 15 years and even at 1 year. Why? Because of the gain in the quality adjusted life years. So look at this graph. I'll just summarize this. So this is, you vaccinate everybody at 15 years. So what happens? So there is incremental quality adjusted life years. So when we are considering this, if you vaccinate all of them and prevent hepatitis A, we are still saving money. Look at this. There is no added implication here. The incremental cost is not increasing. What happens if you screen and vaccinate? If you screen and vaccinate also, you are not losing money, you are actually saving. And what happens to those about 1 year of age? If you vaccinate everybody, you are still saving money. Okay. And here, the incremental quality adjusted life year is also more at about 15 years of age. So what do you learn from this? How do we summarize? So in a state like Kerala, which has a low to very low endemicity level of hepatitis A, it would be recommended to include hepatitis A vaccination in the universal vaccination program. And in certain pockets, you can consider screening and vaccinating 15-year-olds. So that's all from today. Thank you. If there are any questions, I'm happy to take it.
Thank you, Dr. Adira, for the elaborate and crisp talk. I think the emphasis is on recognizing the typical variants and the need for universal immunization. So the session is open for questions.
Shortage of time. We'll move forward. Any questions? Thank you, Dr. Adira. Request Dr. Harris N.K., pediatrician of Government Hospital Nadavaram and now working in Velam. I request Dr. Harris to give N.K. to give memento to Dr. Harshida as a token of appreciation. Thank you. You have a short inauguration of 20 minutes.
Can I ask a question, Prashant, before
Yes.
the inauguration?
Yes, sir. Please, sir.
Because of the last suggestions by Adira, definitely all of us agree hepatitis A vaccine should be included.
Yes.
And the incidents and the other vaccine economy part you have presented, but what we need to consider in the present context, 2023 onwards, the confirmed cases of hepatitis A in Kerala is more than 12,000 till now. And 40 deaths has happened in Kerala. So the whole scenario which proved as a 10%, it must be almost 80% of all the kids in Kerala must be having this serological status now. That point need to be considered. Definitely, that changes only the one policy. Without a serological proof, you can go for the vaccine. To another strategy, maybe for the next few years, the other strategy for proving this thing and then giving. Definitely, younger children may be spared, and as you rightly point out, an adolescent age group, maybe 10 years or 15 years is the right time for the vaccination, and we should be encouraging the vaccine. But the policy need to consider the serological status at present. There's a need for the study. Then only you decide about the thing.
Yes, sir. Sir, have you concluded? Have you concluded?
Just one question to Prashant also, because
Yes,
the last 4 or 5 years, pediatricians all over Kerala is very well aware of the pancreatitis. First stage due to COVID, next stage due to the mumps epidemic and all ranges of these things. My doubt is during the COVID, we had many cases of pancreatitis leading on to endocrinological disturbance. Vijay Kumar must be knowing. Transient endocrine diabetes was much higher at that stage. So, what is your experience of the complicated type of the pancreatitis during that stage compared to the other side? Is there any follow-up of those cases following COVID? Is there any case of lasting problems due to that pancreatitis?
No, sir. During that pandemic period, we had just one case of pancreatitis, and that too was severe. Just for the sake of illustration, I have used COVID, but that is only the exceptional thing. As you said, the common reasons are what you have mentioned. And the whole idea of assigning this topic to Dr. Atira was actually to highlight this problem, that is the regarding the hepatitis A vaccination. We need to have a different strategy from rest of India per se. In fact, Dr. Atira, along with her teacher, Professor Podar, has written an editorial in the Indian Pediatrics years ago. I hope Adira will remember. Is the time ripe for vaccination? So, and I felt it very apt and pertinent to include the topic in the scientific program of PED GASTROCON because of its contemporary relevance. And if any vaccine has to be incorporated into the national immunization schedule with reference to Kerala, I think hepatitis should be the top contender. I request the valuable guidance and the inputs from the senior academicians and the top officials of IAP Kerala in this regard.
Thank you, sir. We will move on to the inauguration now. Good afternoon, ladies and gentlemen. With kind thoughts of warm friendship and sincere affection, we, the members of IAP Vadagara, wholeheartedly welcome you all to the inauguration of PED GASTROCON Kerala 2024, 14th Annual Conference of Pediatric Gastroenterology Chapter, IAP Kerala. Now, we request the following dignitaries to occupy the seats in the dais. Dr. Naushid Ani, President IAP Kerala, Organizing IAP Vadagara, Organizing Chairperson Dr. Prashant Pavitran, Vice President IAP Kerala, Dr. Shimmi Paulos, President IAP Kerala, Dr. Vijay Kumar, HOD Pediatrics, Calicut Medical College, Dr. P.C. Haridasan, Treasurer, Organizing Treasurer IAP Vadagara, Dr. Salahuddin, Secretary IAP Vadagara. Thank you. Ladies and gentlemen, may I kindly request you all to stand for a silent prayer for 1 minute in the remembrance of the innocent souls in the environmental catastrophe we had in Wayanad. Thank you. May I welcome Dr. Naushid Ani, President IAP Vadagara, for the welcome speech.
Good morning, all ladies and gentlemen, esteemed guests and delegates. Welcome to GastroCon 2024 and to our branch IAP Vadagara. We have gathered here to exchange our ideas and open discussion on our theme, Fixing the Young Gut and Liver. Thank you, leaders, for accepting our invite and coming to our state GastroCon 2024. We all know that the sad and disheartening state and situation of our people at Wayanad and nearby village Velangad. I support our team who has taken a challenge to do a hybrid meeting in such an unfavorable condition also. I am very glad that IAP Vadagara was able to conduct so many projects and pediatric workshop in this year. I congratulate our team Vadagara who supported me this year to fulfill all presidential action plan. Thank you. And first of all, I would like to thank our state president, Dr. Shimmi Paulos, and his team who have always supported us and given us the opportunity to conduct state conference. Our last one was Summer Pedicon, which went successfully with all our support, sir. Sir, IAP Vadagara team would like to welcome you to this conference, sir. Next, I would like to welcome our Vice President, IAP Kerala, Dr. Prashant, sir, to this program. Next, I would like to welcome State Pediatric Gastroenterology Chapter, Dr. Prashant K. Sir. He was in Zoom meet, who supported to arrange scientific session meticulously. And sir, welcome to this program.
Thank you, Naushid.
I would like to welcome our dear past president, IAP Kerala, Dr. Vijay Kumar sir, to this program, sir. And also, I would like to welcome our organizing treasurer, Dr. P.C. Haridhar sir, to this program. And also, I would like to welcome all the eminent speakers and senior faculties and senior pediatricians and delegates who have gathered here. And also, I would like to welcome my half, I can tell, better half, Dr. Salahuddin, our secretary, IAP Vadagara. I welcome Salahuddin to this program. And once again, I welcome all to this GastroCon 2024 IAP Vadagara. Thank you very much.
Thank you, Dr. Naushid. Next, we request Dr. Prashant Pavitran, Vice President, IAP Kerala, to address the gathering.
Respected seniors, respected dignitaries, seniors, dear colleagues, good afternoon, and it is a great honor to welcome you all to this State Pediatric Gastroenterology Chapter Conference of IAP Kerala, the PED GastroCon 2024. It is a hybrid conference. In this unique format, we are combining the advantages of both in-person and virtual participation. I want to express my sincere gratitude to the organizing committee, speakers, sponsors, and all delegates who have made this conference in a difficult time, a very difficult time for us. And also, why not two words, my deep condolences to those victims. And I think this weather report should be read properly, like a blood report, and we should be steady, as BBC had reported 3 weeks back about the wet weather, most wet weather in the world in Kerala, and about landslides. And I think here no weather report is concerned, and I think it should be the most essential part to move forward in this climate change period. I also, Dr. Shimi Paulos, my president of IAP Kerala, whose full support has made this conference possible. He said to go ahead with it, and we have reached this state to just get it across. And he had taken, from the first he said go ahead for us. And Dr. Vijay Kumar, Medical College HOD, who's always supportive to IAP Vadagara, is past president of IAP Kerala. Then Prashant KS chapter, beautiful case scenario, and what are topics, actually the best I've seen, and really, and good discussions also going on. And he has taken the initiative for putting up the topics. And Dr. Naushid and PC, Naushid is doing the great job this year, and the president and as my organizing secretary, he has got this virtual, and it's to him, because of him, this went ahead with full confidence. And then Dr. PC, treasurer, as steady as always with his accounts, and I think that that's also a major thing to go forward for us as we are planning to conduct the state conference in the future years, within 2-3 years here, hopefully. Dr. Jagdish Menon, a pediatric hepatologist, I thank him for coming from Chennai, from all the way from Chennai here, and always Rela Institute has been very supportive. This is the third meeting and of the year for IAP Vadagara, and also Aster, MIMS, Kochi, and Miyatra, Calicut, great support to us, and really thank them. And all the pharma companies also, the Rantac part, and the pharma companies, I thank them. Looking forward to an enlightening conference. Thank you, everyone. JIP, Jai Hind.
We invite Dr. Prashant KS to deliver the presidential address of the State Gastroenterology Chapter.
Am I audible? Audible? Am I audible? Audible to the crowd?
Yes.
Sir.
Yes. A very good afternoon to all of you. It is my proud privilege, and I am humbled to address this August gathering as the chairperson of the Pediatric Gastroenterology chapter of IAP Kerala for the calendar year 2024. At the outset, let me congratulate the IAP Vadagara branch under the leadership of Dr. Naushid Ani, Dr. Salahuddin, ably guided by Dr. Prashant Pavitran, for turning the adversity into an opportunity at a very short notice. Actually, the meeting was conceived to be a physical one long back, and we had went ahead with all the formalities, and we have selected the best possible topics and the best array of speakers from across the country. But unfortunately, this Wayanad landslide happened, and very quickly, because as short as last Wednesday only, it was Tuesday, Wednesday, just immediately after the landslide, we had a discussion with the senior faculty and all, and it was decided to go for either defer the meeting or go for an online option. So they discussed in-house and decided in consultation with the state leadership that we will go in a hybrid manner. And I'm really happy to see that the meeting has been going on in an excellent manner with very engaging discussions and meaningful deliberations. And I would like to extend my warm welcome to the IAP State President, Dr. Shimi Paulos, sir, the Secretary, Dr. Krishna Mohan, in his absence, Treasurer, Dr. Ranjit, and to the Senior Academician and Professor and Head of Department of Pediatrics at Calicut, Professor Vijay Kumar, sir, and the other senior IAP officials and distinguished pediatricians of Vadagara, and all the delegates who have gathered. Along with that, I would like to extend my deepest gratitude to all my senior colleagues, friends, and other faculty members who have joined for this academic fiesta. I wish all success for this endeavor. Thank you. Jai Hind and Jai IAP.
We have great pleasure to invite President of IAP Kerala, Dr. Shimmy Paulos, for the inauguration and lighting the lamp.
Respected Chairperson of the Gastroenterology Chapter, Dr. Prashant, State Vice President and Organizing Chairman of GastroCon 2024, Dr. Prashant, branch president, Dr. Naushid, secretary, Dr. Salahuddin, our the treasurer of the conference as well as of the branch, Dr. Haridasa, past state president, Dr. Vijaykumar sir, esteemed faculties, the delegates that are online as well as those who are present physically over here. I think so first and foremost, I think I should congratulate those who are here physically for the program today, for having come, especially the faculty all the way from Chennai, Dr. Jagdish. So I know, so then you all will be thinking, this man has traveled also. Definitely, that is our duty to travel. So definitely these are bad times, I think so. The situation in Wayanad we are going through, yes. But definitely academics can go through because it's a learning process for us. Maybe we learn a lot of things. That is what the idea behind academics is. So doing other kind of activities like sports activities and all that can be kept onto the side. So academics is definitely our forefront, being an academic body. So that is why when Dr. Prashant and Dr. Naushid asked me regarding the conference, so actually they were planning to postpone it off. So I said, don't postpone it because there are no other dates in the calendar for me also for the IAP itself. So I told them, go ahead. I think so since things are there, unless you declare it as an emergency or something, then we can pull back. Otherwise, we can go ahead. So then I think so the beautiful idea that came up to them was the hybrid option. And I think so that is really a good option since I think so because of the COVID, now we know what is Zoom and also hybrid is also come in. So I think so we are able to listen to all the speakers that we want, all the faculties that are there. The topics that were selected were very well placed. That is a practicing pediatrician require these topics. So to hear it from the faculty that was designated that topic was really nice because otherwise you can imagine we all being over here very few. I think so Dr. Jagdish would have, and Dr. Vijaykumar sir had to keep on taking all these topics that were posted for to be heard. So luckily we have the online version, so that is why the hybrid is also there for us. Definitely these are bad times for all of us, and IAP Kerala is also planning to extend out to the relief activities at Wayanad. Over a short period of time we will be coming out with the ideas because the things at the ground level has to be decided, what is going on, where we can approach and what we can do. So IAP Kerala is waiting for that gap to see what can be done, and then we will be moving forward. So we will let the respective branches be intimated about it and what to be done. So let's all join hands together to make it happen. Let all of us get together also to help those who are needy out there also. So I'm happy, and I should really congratulate the Vadagara team with Dr. Naushid and Dr. Salahuddin for taking up the activities in Vadagara, and also the various activities, especially the Green Army and also the BLS program, and also I think so they are also been out to provide relief for some of the people who had been involved in the recent landslide in a local area over here. So it is nice to see that Dr. Naushid is running around and doing activity. So, and the team of Vadagara supporting him is even more beautiful. So that is why, when you have a person running around, everybody supports him, it is even more beautiful to see more work being done. So congratulations to the team and also to the organizing team for having planned out this PED GastroCon. So wishing the program all the best, and I officially declare that the PED GastroCon 2024 is inaugurated. So Jai AP and Jai Hind. Thank you.
Thank you, Dr. Shimi Paulo sir, for the kind words. As a token of appreciation, we request Dr. Naushidani to hand over a memento to Dr. Shimi Paulo sir. Thank you all. Next, we welcome Dr. Vijaykumar sir, HOD, Pediatrics, Calicut Medical College for the felicitation.
Respected Dr. Shimmy Paulos, President of IAP Kerala, Dr. Prashant Pavitran, Vice President of IAP Kerala and Organizing Chairperson of this program, Dr. Naushid Ani, President IAP Vadagara, Dr. Haridas, Organizing Treasurer, and Dr. Salahuddin, Secretary IAP Vadagara. Hearty congratulations for organizing such an interesting and very informative conference. And special congratulations to Dr. Prashant KS. He is the State Gastroenterology Chapter of IAP Kerala for making this a very pediatrician friendly conference. And we have a blend of very senior, eminent legends of pediatric gastroenterology like Riya sir and Banu sir, and also very young, energetic pediatric gastroenterologists like Dr. Jagadish, Dr. Prashant, Dr. Geeta, and Maya. And without wasting my time, because everybody is going for and they're interested in the academics. So again, all the best for this program. Jai Hind and Jai IAP.
Thank you, Dr. Vijaykumar sir. We welcome Dr. P.C. Hardasan sir, Organizing Treasurer, IAP Vadagara, for the felicitation.
Respected State President Dr. Shimmy Paulos, Vice President Dr. Prashant, our President Dr. Naushid, dignitaries on and off the dais, and my dear friends. Actually, the State President പറഞ്ഞ ഒരു ഘട്ടത്തിൽ നമ്മൾ പോസ്റ്റ്പോൺ വരെ എത്തിയ ഒരു കോൺഫറൻസ് ആയിരുന്നു. I think this is the first branch to conduct a state subspecialist chapter in a hybrid manner. Anyway, it is very proud to speak to you in presence of great teachers like Riya sir, Dr. Vijaykumar, and senior IAPians and dignitaries of the platform. And I wish all the best for today's conference and a great CMA hours for you. Thank you all.
Thank you, Dr. P.C. Hardas sir. We welcome Dr. Salahuddin V, Secretary IAP Vadagara, to deliver the vote of thanks.
Respected State President Shimmy Paulos sir, State Vice President Prashant sir, Branch President Naushid, Dr. Naushid, Vijaykumar sir, Haridas sir, and all the faculties and all the delegates here. This is the 14th State Pediatric Gastroenterology Conference. First of all, I would like to thank IAP Vadagara for IAP Kerala for giving us an opportunity for IAP Vadagara for conducting this program. Actually, we had conducted a summer pedicon 2 months back, and now we got this one, subspecialty conference. So, first of all, thanking IAP Kerala for that. And for inauguration, we have our State President, Shimmy Paulos sir. Actually, we were in confusion whether to proceed with or not. Then he said, like, this is an academic session, so you can proceed like that. So, with his confidence, we proceeded the session. Then, the chairperson of the Pediatric Gastroenterology Chapter, Prashant K. sir, he selected the topics and the faculties. So, topics which are more important for the pediatricians. So, he selected a topic like that. So, we thank him for his work. Then about the faculties, we have faculties from all over Kerala, Karnataka, and Tamil Nadu. And we have eminent faculties. I'm not naming each one of them. I thank all on behalf of IAP Vadagara for spending their time. And I thank all the delegates, including seniors like Rajiv sir, Haridas sir, Amit sir, everyone, and PGs for coming here, for their physical presence, and those who are online also for participating in this program. And I thank MCs Danya ma'am and Ashida, Dr. Ashida for, and about This program is sponsored by many pharma companies and hospitals. I thank all on behalf of IAP Vadagara. And about this one, regarding the landslide, നമ്മൾ വടകര IAP ലാൻഡ്സ്ലൈഡ് സംഭവിച്ച ഉടനെ തന്നെ നമ്മൾ അതുമായിട്ട് ബന്ധപ്പെട്ട് ഡിസ്കഷൻ നടന്നിരുന്നു. നമുക്ക് എന്താണ് ചെയ്യാൻ പറ്റുക എന്നുള്ള ഡിസ്കഷൻ നടന്നിരുന്നു. അപ്പോൾ വയനാട് ഏരിയയിലും വെലങ്ങാട് ഏരിയയിലാണ് മെയിൻലി ഇത് സംഭവിച്ചത്. അപ്പോൾ വയനാട് നമ്മൾ നോക്കുമ്പോൾ പിന്നെ ഗവൺമെൻറ് സൈഡിൽ നിന്ന് കൂടുതലായിട്ട് ഗവൺമെൻറ് സൈഡിൽ പിന്നെ പബ്ലിസിറ്റി കൂടുതൽ കിട്ടിയതുകൊണ്ട് കൂടുതൽ ആളുകൾ അങ്ങോട്ടേക്ക് പോയിരുന്നു. അപ്പോൾ നമ്മൾ വെലങ്ങാട് കോൺസെൻട്രേറ്റ് ചെയ്ത് കുറച്ച് പ്രോഗ്രാം ചെയ്തിരുന്നു. നമ്മളൊരു മെഡിക്കൽ ക്യാമ്പ് നടത്തിയിരുന്നു. വടകരയുള്ള ഹോസ്പിറ്റൽസും പാർക്ക് ഹോസ്പിറ്റൽ, ആശാ ഹോസ്പിറ്റൽ അവരുമായിട്ട് കമ്പൈൻ ചെയ്തുകൊണ്ട് IAP വടകര വിത്ത് IMA നമ്മളൊരു മെഡിക്കൽ ക്യാമ്പ് നടത്തിയിരുന്നു. അതിന് പുറമെ നമ്മളൊരു ഫണ്ട് IAP വടകരയുടെ ഒരു ഫണ്ട് പുറമെയുള്ള ടീമുമായിട്ട് അസോസിയേറ്റ് ചെയ്തിട്ട് നമ്മൾ അവർക്ക് കൊടുത്തിട്ടുണ്ട്. ഇത്രയും കാര്യങ്ങൾ നമുക്ക് ചെയ്യാൻ പറ്റിയിട്ടുണ്ട്. So finally, I thank everyone for participating in this program.
Thank you, Dr. Salahuddin. Thank you, all respected dignitaries. Now we move on with the academic sessions. We move on to the next session, which is a case scenario-based session. How do I approach? The first speaker is Dr. Banu V. Pillai, sir, and the session is chaired by Dr. Vijaykumar, sir, HOD Pediatrics, Calicut Medical College, past president, IAP Kerala.
Hello.
Hello.
Sir, Banu, sir.
Hello.
Yes, sir.
I'm online.
Yes, sir. So it is my great pleasure and privilege to chair this session, which is done by none other than Banu, sir. He is very senior faculty, senior pediatric gastroenterologist of Kerala. And like Dr. Riyaz, sir, he is the legend in pediatric gastroenterology in Kerala. So sir has done his MBBS from Alappuzha and his MD pediatrics from Government Medical College, Kottayam. And then he moved on to USA and he got the certificate in pediatrics and pediatric gastroenterology by American Board of Pediatrics. And he had almost spent 20 years as a practicing pediatric gastroenterologist in various universities in USA. And then he moved to Amrita Institute of Medical Science. And for the past 11 years, he is the head of the Department of Pediatric Gastroenterology in Amrita Institute of Medical Science, Cochin. And I'm very much happy that I am chairing this session. And we used to have a lot of discussion among us with some of the very critical and difficult gastroenterology cases from Calicut Medical College. Sir, and his topic is also constipation in children. There is a perplexing situation that is faced by the patient, by his parents, and by the pediatricians themselves. So, over to you, sir, for this talk. Thank you.
Thank you very much, Vijaykumar, sir. And also thanks the IAP Vadagara and Prashant for selecting this topic, which is one of the extremely common problems that pediatricians are facing in day-to-day practice. Constipation. And what is constipation, first of all? Constipation, everybody knows it, but to define it can be very difficult. It's a term used to describe the subjective complaint of passage of abnormally delayed or infrequent passage of dry or hardened feces. So it is, the frequency is important, the consistency is important, as well as the discomfort with the defecation. It's a combination of all that which is causing what is recognized as chronic constipation. So it is hard stools, large stools, sometimes pebble-like stools, discomfort with the stooling. They are all extremely important to identify the constipation. Now, Bristol stool chart is easily available for all of us, which is available online. This will help us to identify the character of the stool, because many of the times the children, they will not be able to describe what is the character of the stool. So for them, if you put this picture there and tell them to show the type of the stool, then the children can easily identify it, and that would help us to identify and treat these children. So what is, so we told about the frequency. So what is the normal defecation? Infants, as all of you know, as pediatricians, the frequency generally ranges from 1 to 7 times a day, especially a breastfed baby. And on an average, it's about 4 times a day. Children around 2 years of age, it's around 1.2 to 2 times a day. And the adult pattern is reached by around 4 years of age, and average is from 3 times a week to 3 times a day. So the frequency is important, and the character is also important. So all the constipation, majority of the constipation are what we call functional constipation. That is not because of any organic disease which is causing the constipation. So what are things clinically, as Riaz already pointed out, history and physical exam, especially history in constipation. History is the most important, the tool that we have to identify and discriminate the functional from chronic and the organic constipation. If the constipation is starting from very early in life, especially in early infancy, one must worry there's an organic pathology. Also, if there's a delayed passage of meconium or family history of Hirschsprung's disease, all of you know Hirschsprung's disease, there is a genetic predisposition. So if there's a family history of Hirschsprung's disease, that makes the child more vulnerable or likely to have Hirschsprung's disease. And also ribbon-type stools or small caliber stools, and blood in stools without presence of anal fissure. And if the child, along with the constipation, also has poor weight gain and intermittent fever, one must worry there's an organic pathology. If this constipation also associated with vomiting, especially bilious vomiting, it is definitely an organic pathology one we need to think of. Abnormal thyroid gland, thyroid swelling, or goiter, and severe abdominal distension. So in Hirschsprung's disease, typically they come with failure to thrive or poor weight gain with a chronic constipation and abdominal distension. That's a three very characteristic symptom they would come with. So abdominal distension along with that chronic constipation, one must worry there's an organic pathology behind. And as Dr. Geeta also already pointed out earlier, it's very, very important to look at the perianal area. Look at the perianal area to see is there a fissures or a perianal fistula or abnormal position of the anus. So many times the children may have constipation because of ectopic anterior placement of the anus. So if the anus is more ectopically anteriorly placed, that can result in chronic constipation and difficulty in passing stools. And absent anal or cremasteric reflux definitely indicate a spinal cord pathology one must think of, and you have to rule out and evaluate for the same. If the child also has got decreased lower extremity strength, tone, or reflexes, you have to think of as an organic pathology, especially spinal cord pathology. Tuft of hair on the spine, which may indicate a spina bifida occulta, deep sacral dimple, gluteal cleft deviation, which also may indicate a spinal anomaly, and extreme fear during anal inspection. This is something we have to think of, because all children will be very, very hesitant to let us examine the perianal area. But if there's extreme fear, we also have to worry about the possibility of child abuse, which is causing the child to have that extreme fear and resulting in chronic constipation. And anal scarring. So most of the constipation is non-organic, or what we call functional, but there can be organic pathologies. Organic pathologies can be because of the colon or the rectum, and we'll come to that in a second. Spinal cord anomalies, neuropathy causes or metabolic causes, systemic disorders, especially child with a depression. I mean, a 3-year-old is unlikely to have a depression, but child is taking antihistamines or too many doses of cyclopam, which can make the child get constipated. Drugs, so very, very important, especially teenagers. It's very important. A child with a depression may be taking antidepressant. One of the notorious side effects of chronic constipation. So in an infant, so this first line, the infant dyschezia, it's something all of us see. and it is something which we need to identify and recognize. So a 3-year-old or 3-month-old or 4-month-old baby may come to you with the mother telling the child is having severe difficulty with the defecation, and child is, if you take the history, the mother may say child is crying, the face turning red, child is, pulling the hands up and legs up, and child is having extreme difficulty with the defecation. At the same time, at the end of that discomfort, child passes stools which is soft or loose stools. So this is what we call infant dyschezia. This is basically lack of the coordination of the abdominal wall muscles with the pelvic floor muscles. So this is recognized as one of the functional gastrointestinal disorders in the wrong criteria also now. Children, all of us children with ADHD are notorious to get constipated because they will not spend enough time to sit on the toilet to defecate. And child is starting school, they refuse to sit on the toilet in the school, and they get hold the stool and get stool, the withholding behavior, make the stool very hard. Next time when the pass stool gets hard, and child will refuse to sit the following time. And toilet phobia, toilet training. So difficult toilet training can also be very, very, causal for the chronic constipation in children. And as I mentioned earlier, child sexual abuse is something which we need to think of. It is not uncommon as we think of it in our society. It is getting more common. And genetic predisposition may be a familial trait. Child passing stools only 3 times a week. The child may be very comfortable and without having any problem. And it may be because of the dietary habits. So the organic cause I told earlier, ectopic anus, as I mentioned earlier, anal stenosis. And one of the most important things we have to think of is spina bifida or meningomyelocele. Meningomyelocele, many times the pediatrician would have identified at the time of birth itself, but the spina bifida could be easily missed. And also anteriorly placed ectopic anus is also something which could be missed in the neonatal period in the labor room. So we have to think of, or in the nursery. So it's something which you have to pay attention to. If the child is having difficulty with the defecation, you have to think of. Tethered cord or spinal cord lipomas can come with difficult constipation, and also can have symptoms of central nervous system problems in the lower extremities. Hirschsprung's disease is the most common organic pathology, especially young child when they come with the chronic constipation, is something we have to think of. We'll come to a little more detail about Hirschsprung's in a minute. Now, hypothyroidism is something which we have to think of in a child with chronic constipation because it is treatable condition. It is not only affecting the constipation, it has affected multiple other systems, so including the development. So very, very important. Check the thyroid function test in a child, any child with a chronic constipation, and you must appropriately treat these children. And these things I already mentioned. Celiac disease is very uncommon in our population, but in North India, especially suburbs of Delhi and circle around the Delhi, it's very common. They can come with a chronic constipation, even though majority come with a chronic diarrhea. I had picked up children with a chronic constipation as the presenting symptom of celiac disease. Hypopituitarism, yes, it can, along with the hypothyroidism. Dermatomyositis along with the scleroderma, yes, all this, the GI motility is affected. They can come with the chronic constipation as a problem. Lead poisoning, thankfully, it is getting very uncommon in our population, but it's something to keep in mind if there's a refractory constipation. Drugs, we already mentioned about this 2 minutes ago. Now, history, as Dr. Riaz already put multiple times earlier, this is the most important thing, which clue to give the diagnosis of chronic constipation and the etiology and point towards the functional constipation or towards a possible etiology organic pathology. And along with that, the physical examination. Most of the children may not need any physical test or any test, except for probably thyroid function test. Rest of the tests may not be necessary except for history and physical examination. But if the child is not improving with the management, one must consider doing further investigations. So history and physical examination along with the blood test. Thyroid is the most important thing I will point to again and again because it's something which is a treatable condition you must think of. Hypercalcemia, it also can cause it. Lead level again, which is uncommon in our population right now, but something to keep in mind. do a CBC to make sure is that the child is having also anemia, iron deficiency anemia. And also to think about in the history, one very important thing is what the child being fed. Is the child taking too much milk? Yesterday we had a child actually from Maldives who was taking 1 liter of milk a day. Has come with actually iron deficiency anemia. So we, day before yesterday we just saw in the hospital. So it's something with the history is extremely important. We have to worry about and ask. And in an infant, you have to also worry about if the child is being exposed to cow's milk protein, which may be causing the part of the problem, or maybe the problem. Now, imaging, we'll come to a couple of imaging techniques, and manometry in refractory cases only, manometry will be required. And X-ray KUB will be very useful in an obese child or if the child refuses a rectal examination. That's the X-ray KUB. And also it's a crucial thing we can help us to convince the parents to make sure they give the medicines, because many of these children may not be coming as constipation, they may be coming with abdominal pain. So if you do an X-ray and show the proof the child is constipated, they'll be more likely to continue the medication correctly and as we suggest. So getting but it's very important in an obese child and who in a rectal examination can be very difficult, and also if the child refuses a rectal examination or a perianal area examination. Unprepped berryemia, if the child has started constipation very early in infancy, one thing you need to think about the possibility of Hirschsprung's disease. The berryemia is useful and helpful, but berryemia, when you ask for it, make sure you write unprepped berryemia, because it's very, very important. You do not do as a suppository or an enema before you doing the actual berryemia, because if you evacuate, that could change the dimensions of the rectum and the sigmoid, so that could change the interpretation. So it's very, very important that you do it in unprepped fashion. So it's make sure you write in the request also unprepped berryemia. Now, if the child has got any neurological symptoms, or if the child is having very difficult and not improving with the management, also has urinary symptoms, getting an MRI lumbosacral spine can be very, very useful and and life-saving. So it's very important to consider that if the child is not improving. SITS marker study is something that can be done, which will help us to identify. If you look at the first picture again, so this is after giving a 24 markers. There are different ways to do it. The well accepted way is to give 24 markers and take an X-ray on day 5 and X-ray KUB. So if you see less than 5% of the 24 markers are retained, that's a normal transit. And if the radiopaque materials are staying throughout the colon, that will suggest if the patient has got colonic inertia. The whole colon is affected with the colonic dysmotility. And if it's all coming and sitting in the rectum, that tells us it's an outlet dysfunction which is causing the constipation. So this is a very useful thing to do, especially sometimes when you are planning for a surgical intervention. It's something we have to do. The anorectal manometry, it can be done even for infants, it can be done, but it is done for somebody with refractory cases. You don't have to do it for every child with a chronic constipation. You do not have to do it, but something which it is useful and is available to do it, and you can change the management in the particular child, especially if the child is starting very early in infancy with the chronic constipation. If you strongly suspect Hirschsprung's disease as a possibility and the berryemia is not that reliable or conclusive, doing an anorectal manometry can be very helpful before making the child go through a surgery, anesthesia, and getting the biopsy to get a full thickness biopsy check for ganglion cells. So obviously, rectal biopsy is very confirmative to get the Hirschsprung's disease. You find there is absence of ganglion cells in the submucosa, not the mucosa. So the colonoscopy or sigmoidoscopy biopsy is not useful. It is only because they are looking at the ganglion cells deep in the lining. So you need to get the biopsy, deep biopsy. So you need to get either rectal suction biopsy, with the equipment is not easily available in India, or you have to get a full thickness biopsy, which gets done by surgeons to look at the whole layers of the rectum. Manometry, this is one of the most important thing. You check it to see. So in Hirschsprung's disease, normally you expect there's the internal anal sphincter relaxation, absence of internal anal sphincter. So you can see they're supposed to relax. If it is not relaxing, the internal sphincter is not relaxing, that tells us and concludes and confirms the Hirschsprung's disease as the reason for the chronic constipation. Again, coming to the making a diagnosis, most importantly, history and the physical examination. In selected cases, laboratory examination, imaging, and manometry. If it is not consistent with, if they are not pointing towards functional pathology, and if you do these tests also, and if you don't find a reason, you can confirm it is functional pathology. But you do not need to do investigation for every single child. It can be clinically made the diagnosis of functional constipation, because almost 95% of the chronic constipation in childhood, leave alone the infancy. I'm not talking about the infancy. Organic pathology is more likely, but in older children, if it's almost 95% is functional constipation. It is a functional constipation is because many times it's because of the decrease in the propulsive force or impaired rectal sensation, especially when the rectum gets enlarged and enlarged because of the large amount of stool retained in the rectum. So normally this is not for the pediatric gastroenterologist, only for the pediatricians. So normally when we want to defecate, when the stool comes to the rectum distance, that gives a signal to the brain, you need to go to the toilet. But if the child is in the uncomfortable location or unfavorable location, or the patient is in an unfavorable location, you try to contract the sphincter so that you can reach a comfortable position or appropriate position to defecate. So that if it happens the next time, then everything is set. But if the next time also when the feeling happens, if the child is not going it, larger and larger volumes of stool retain the rectum, and that makes the rectal diameter larger and larger. So every time it takes more amount of stool in the rectum to get the sensation to go to the toilet. So each time it gets bigger, larger volume that will require. So if the child is not going and keep withholding, ultimately the stool starts leaking around the large ball of stool, become the fecal soiling, or in the previously called as endocrine-related. Now where we so-called fecal soiling. So there are certain triggers that can come with, which can precipitate the chronic constipation. So there are 3-4 stages in life in childhood or in a human being. One is when you change the breast milk to the formula milk for some reason. Because until then, there's a whey predominant, the milk the child is getting, then you get the casein predominant, that makes the child more likely to get constipation. Also, when you start the weaning and change of milk to other table food items, the whole routine is changing. That's the second time. And the third is when you start the toilet training process. The parents want, or the grandmother or grandpa wants the child to sit when they want them to sit, but the child refuses to sit when they want to sit. The child will sit only when he or she wants to sit. So it becomes a fight between the two, and the child will refuse to sit and it becomes stool withholding behavior, and that can result in chronic functional constipation. And the next stage is when they start the school, when the child gets the feeling to go there, they cannot go because either they don't like the school bathroom, or if it is not clean, they refuse to sit and becomes an issue. They keep holding the stool and keep going, and result in chronic constipation, fecal retention and impaction. And the next stage is actually teenage years, even when they have the time to go, they don't want to go because they're busy with other things. They refuse to sit when they get the urge to go. So this, we mentioned about this one thing, but one more thing I need to mention: the fecal soiling is more common in boys than girls. Okay, can you hear me now? Can you hear me?
Sir.
Yes, sir, we can hear you now.
Sorry, something happened and muted me in between for 30 seconds. I'm sorry about that. Okay, so, so this is what becomes in the fecal soiling, and the parents will think the child is passing soft stools and is daily passing the stools. Then when we say child is constipated, they refuse to believe it, and they don't understand. They at least say they don't understand why the child is, having so early. Now, this one, so the most important the differential diagnosis one is to consider an infant with a chronic constipation or a young child is Hirschsprung's disease. So Hirschsprung's disease is a segmental colonic aganglionosis. And there is absence of ganglion cells. All of you know it's the absence of ganglion cells in the submucosal and the meandric plexus. It is not the mucosa, it is the submucosal and the meandric plexus. That is the reason I said we need the biopsy that is deep enough to see the ganglion cells. And the prevalence is 1 in 5,000, and it is more common in boys than in girls. Trisomy 21 or the Down syndrome is one of the most common associations of Hirschsprung's disease, and also other chromosome anomalies also can come with the chronic constipation. And also we have to think, remember, when in the nursery, for example, or an ICU, when you are suspecting Hirschsprung's disease, the surgeon intervenes immediately because they are not worried about the couple of constipation the child may have because of the risk of severe enterocolitis that the child can get. This can be detrimental and sometimes can be fatal. So one of the important presentations of Hirschsprung's disease in infants is Hirschsprung's enterocolitis, which has got a higher mortality. So that is the reason surgeons will intervene when they suspect Hirschsprung's disease. They intervene immediately, do a diversion or ostomy, and do definitive surgery later on because they don't want the child to get enterocolitis. So they can enterocolitis, one of the important presentations in infancy especially. And later on, as I told earlier, they can come with abdominal distension, poor weight gain. Also, they come with the obstructive symptoms and severe chronic constipation and fecal impaction and poor weight gain. And if you do a rectal examination, stay away from the rectal area, stand on the side of it, but because you will find the rectum is empty. At the same time, when you withdraw the finger, you'll find a gush of air or liquid stool come out because of the, especially if it's ultra short segment or short segment Hirschsprung's. If it's a total colonic aganglionosis, the rectum will be empty, but you may not get the gush of the air and liquid stool. You may not get that. And the ultra short segment or short segment Hirschsprung's disease may manifest in a younger child, not necessarily infancy. It could be later on also. So majority of the Hirschsprung's disease are sporadic, but 20% can be familial, and 30% there can be genetic abnormality can be seen. And red gene can be seen in these patients, many of them in the genetic variety. Down syndrome, as I mentioned, one of the important associations of Down syndrome. One is, of course, the duodenal atresia. Second is the Hirschsprung's disease, the GI tract anomalies that could be present. Neurofibromatosis also can be associated with Hirschsprung's disease, and Waardenburg-Schwarz syndrome, as you know, they can also come with Hirschsprung's disease. Now, this is the Indian guideline, and so Dr. Yachai, now who was in SCPGI, now of course in all of you know are familiar with him. Now he's in Bengaluru, so he was the to put up these guidelines, and so as per the guidelines, so the management he suggested, the panel suggested, not only the child teaching, the child and the parent counseling, and the toilet training, the diet modifications, the drug management, and extremely important is the follow-up. So it's very important to look at the etiology and pathophysiological aspects, and that could be explained. The retention cycle and swelling cycle has to be, pain retention cycle has to be explained to the parents for them to take the medicines correctly for a longer time. Otherwise, they may refuse to take it. And causative factors, if there is any excessive milk intake, yes, stop it. If the child is not taking adequate fiber, supplement it or improve it. So it's all those, and if the psychosocial factors, get the counseling or whatever necessary intervention need to be done, also need to be addressed in these patients to treat in the management. In the toilet training, the panel suggested they not to start the toilet training before 2 years of age, but in the Kerala scenario, as all of you are familiar, many times the grandparents will make them sit on the legs or whatever it is, even when it's around 1 year of age or even sometimes even earlier, and to gradually toilet train them. So if they train them, it's appropriate, but don't force them to sit on the potty, because forcing them to sit on the potty, we are not going to gain it. We will fail, because ultimately the sphincter, only the child has got the control of the sphincter. We don't have the control for the sphincter, or we have the control of our sphincter. So make the child sit on the toilet for 2 to 3 times a day after food. So this is very important, even in the toilet period, even in the management of chronic constipation. I always tell them, after food, about 20 minutes after the food, make them sit on any major meal after that for 5 to 10 minutes, even 5 minutes. Sit on the potty, sit there, try to poop. But if they're not poop, that's okay. But you have to make them sit, gradually make them lose the fear with the defecation. And it's very important, you have to facilitate painless defecation. Without pain, the child is not going to relax. If they have any fissures, we must treat it. Otherwise, the child is not going to sit on it, will refuse to continue to sit. Squatting position, I always remember one of Dr. Riaz's slides, the child sitting on the squatting position, showing that's extremely appropriate. That is the best Indian toilet, or the squatting position, very appropriate, and that is, help us to get the correct angle between the rectum and to the sphincter, so that make them defecate much better. And the English style toilet is okay, but if you're European style, if you're doing it, make sure the child has got a step stool to make the child sit. The feet is resting on a hard surface. If the child's feet is hanging down, the pelvic floor muscles are not going to relax. Make sure the feet is touching on a solid surface for them to defecate. And very important is positive reinforcement. If the child is pooping in the toilet, make sure you give some reward for them. So put a star on the calendar. So initially you can give every day some reward. Later on you can put a star on the calendar, but get the 7 stars in a row. Make some, you buy a toy or whatever they like. So make some food, really nice food item which they will like. So make them get it feel rewarded for them to sit on it again and again to do it. It's very important the child to take adequate fluids, fiber, and fruits. It's very important to do that, because if the child is not taking that, you will end up in taking the medication for a much longer time. So still they need the medication, but if they need the medication for a shorter time, if you are modifying that diet in such a way, there's adequate amount of fruits and vegetables and fluids the child is taking. Giving excessive fluids is not going to help us, because that is going to pee out, it is not going to poop. But make the child is taking adequate amount of fluids the child is taking. And normal activity, of course. Fiber, yes, what's a good number of fiber? 18 years plus 5 grams per day, that would be a good guideline. So basically, make sure child takes some fruits, some vegetables, and limit the amount of cow's milk the child is taking to 1 glass a day. That will help us to identify, help us. And also, very important to avoid biscuits and bakery items, because that is one of the killers that is causing the constipation in our country. Fiber-rich items, I don't need to teach you because you know it, okay? And it's very important. The fiber is useful only so long as you are giving it. So it's very important the child take it, continue to take it, otherwise we will not be able to withdraw the medication. Now, medical therapy is very important. The 2 phases of treatment is the disimpaction and the maintenance treatment. Unless you disimpact appropriately, you will not be able to continue with the correct management of the maintenance therapy. Disimpaction can be done if you are admitting the child is severely impacted. Sometimes you admit the kid and you treat, but not necessarily always it is necessary. You can always do the disimpactions at home. So you can be done, it's a very good success rate. We can do it at home too. Now, in the hospital, sometimes you put a nasogastric tube and give polyethylene glycol continuously, just like the colonoscopy preparation. And along with that, if they're very impacted, sometimes you give intermittent enemas to get them cleaned out. And rectal enemas can be used, especially this is very useful in a child with a chronic fecal soiling. Enemas, at least one enema can be helpful, because if there is that much soiling that is happening, the rectum is so impacted, unless they evacuate that, whatever stool laxatives you are giving orally, that's going to continue to initiate to make the soiling worse. So it's important to help us to give a one enema at least to help us to treat this impacted children. And after that, of course, the oral route is the preferred because the non-invasive, of course. Unless it's severely impacted, always oral is very, very useful and preferred way to do it. Very occasionally, very, very rarely, but after getting the polyethylene glycol being available, manual evacuation has become very uncommon way of disimpaction. But occasionally may require it. But previously, yes, even before polyethylene glycol was available, manual disimpaction also had to be attempted sometimes to get them, get them out of the impacted stage. And after the impaction, make the child, continue on the maintenance therapy. Without the maintenance therapy, the child is going to get impacted again, and the child will be on square one. We will not be successful treat this patient. And you have to make sure follow-up is extremely crucial for these children. If they don't, we don't see them and reiterate and constant reinforcement, the parents also will stop the medication and the child will also stop it. Now, laxatives, the majority of us use the osmotic laxative. We'll come to in a second. And then sometimes if that is not successful, we may use stimulant laxatives also. The osmotic laxatives in infants or small children, many times we all use lactulose, a time-tested medicine, very effective, and you see the dose, many times Saharid dose may be inadequate. You have to use 1 to 3 ml per kilo per day. So if you give a higher dose like this, and you can divide and give it, that will help us to treat these children. Even disimpaction can be done. If it's milder disimpaction can be done by even with the lactulose. Sorbitol, the same dose, same side effects, flatulence and cramping. In an older child, a teenager or something, lactulose may not be enough, because if they take this particular dose for a 10-year-old child or 12-year-old child, the dose will be very high, and that is invariably going to cause flatulence and cramping and bloating. So because of that, they will refuse to take the next time. So that may not be appropriate for an older child, but the lactulose is very, very appropriate. If the lactulose is not enough, even in infants, sometimes we use polyethylene glycol. So polyethylene glycol can be used in infants too, but many times in a younger infant, I always start with the lactulose, and if it is, and increase the dose, and make sure if it is not working only, go to polyethylene glycol in an older infant. Mineral oil can be used, it is safe, but do not use it for somebody who is lying down all the time, or like a cerebral palsy child, because they could aspirate. And also do not give it at bedtime, because that can cause aspiration pneumonia. And with a child with recurrent vomiting, avoid using mineral oil. So those three situations, try to avoid it. Otherwise, it is a useful medication to use. Senna is a stimulant, laxative. And if the other one is not working, sometimes we do use it. Polyethylene glycol, we come to a little more detail, because one of the mainstay, especially in an older child, is polyethylene glycol that we use. The PEG is otherwise called macrogols. It's a non-toxic, chemically inert, and water-soluble polymer. So it's very effective and osmotic laxative. Because it's not absorbed, it is very, it doesn't have any systemic side effects. So it can continue even for a longer time if you need it to be. There comes in different, molecular weight, the size. So most of the one that we use available is a PEG 3350, but also the PEG 4000 is also available. They are both effective drugs. Both can be used very effectively for disimpaction and for maintenance treatment. It's minimally absorbed, as I mentioned, and doesn't influence absorption of other solutes or anything. So, but one thing I tell the parents, when you are giving polyethylene glycol or any other, or lactulose, is do not give other medication within 30 minutes of administration of this medicine. Because, for example, if you are giving an antibiotic, don't give it the same time as the polyethylene glycol, because if that medicine is not absorbed and goes along with the polyethylene glycol, you don't want to decrease the effectiveness of the antibiotic. So because of that, I tell them to give it 30 minutes away from other medications to be less problematic. Now, as I mentioned, it's very effective both for disimpaction and maintenance. And initial dose, we start at 0.4. but can give one up to even 0.8 gram per kilo per day, depending on the necessity, because it is well tolerated. You give it as much as it takes to get it cleaned out. And then you continue to, give the maintenance dose, adjust dose in such a way to make sure the child is pooping soft, painless stool. The problem with all these medications is it is very effective and useful. But the problem is you prematurely withdraw the medication. Do not stop the medication abruptly. So I tell them to give at least for 3-4 weeks, let the child have painless stools every day without any discomfort and pain. Then only decrease it very small amount. Suppose you are giving lactose 15 ml daily. I tell them to cut back to 12 ml, wait for 2-3 weeks. If things are okay, then cut back to 10. So very slowly cut back. When it becomes very slow, of course, you can stop. Because if you stop abruptly, the child gets impacted again. The child is going to withhold the stool again. Same for polyethylene glycol. So withdraw the medication, smaller dose. That is a very, very important, management, guideline that we should follow. Most children have frequent relapses. One of the important reasons is because of the abrupt cessation of the medications. But even after appropriate cessation, they can get relapses. And so you want the parents ahead of time. They may need to multiple, therapies later on may require it. And if require, make sure you continue it. So about 60%, they can treatment success even after 1 year of the therapy. But that means about 40% either may require continued medication or they could relapse. So it's very, very important to continue medication as long as it takes. Now, if the child is not improving, yes, then we consider, what is considered as a refractory. Then you can consider making the referral to any of the pediatric gastroenterologists of your choice and decide about it. And then you can decide about, after evaluation, decide whether we need to do either investigation, including, the manometry or whatever we need to do, and or behavioral medication or whatever we need to do, and then decide on what is the next step in the treatment. And very, very refractory patients may need surgical intervention and a diverting ostomy versus antegrade enema. Antegrade enema is at the cecum area. Appendix is used as a conduit to use instead of the enema from the bottom, you flush it out through the appendicostomy or the gastrostomy tube button, G button, put at the cecum area, cecostomy button, and you flush it with the enema, flush the poop out. So basically helping them to have a continence of the bowel movements. Thank you very much. I'll stop here. If you have any question, I'd be glad to answer it. Or if it's at the end of it, I'd be available sitting here. Thank you very much.
Thank you, sir, for that lucid presentation of a little bit complicated case. And I think we can have the discussion at the end of the session. Thank you so much for this.
Thank you, Banu sir. Thank you, Vijayamma sir. May I invite Dr. Shimmi Paulo sir to hand over a memento to Dr. M. Vijaykumar sir. Thank you. Next, we invite Professor Dr. Riaz sir for the next talk. I invite Dr. M.V. Arida sir to tie the session.
Can I start sharing? Prashant?
Sir.
Very good afternoon, everybody. I am introducing Professor Riaz for the second time today. This time the topic is sick child with cholestasis.
Over to you, Riaz sir.
3-month-old child, sick child with the cholestasis.
Prashant, can I start sharing? One matter off our camera. Prashant? Hello?
Hello. Yes, sir.
ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല, മറ്റൊന്നും
Yeah, okay, okay.
സാറേ സ്ലൈഡ് അതല്ല തോന്നുന്നുണ്ട്, കൊറോസീവ് ഇഞ്ചറി ആണ് കാണുന്നത്.
ഇല്ല ഇല്ല, എൻ്റെ നെക്സ്റ്റ് വേറെയാണ്, ഞാൻ ഷെയർ ചെയ്യാൻ.
ഓക്കെ ഓക്കെ ആ
സാർ ക്ലോസ് ചെയ്താലേ സാറിന്റെ
ഓക്കെ ഓക്കെ ക്ലിയർ.
It's a 3-month-old sick infant with cholestasis.
Okay.
He deliberately selected the child, a 3-month-old sick infant. Sick infant excludes the possibility of extrahepatic biliary atresia. In extrahepatic biliary atresia, infants may not be that much sick. Probably he may be talking about intrahepatic cholestasis cases. And Professor Riaz, as I earlier introduced, is an excellent teacher and an academician, formerly Professor Head of the Department of Pediatrics, Calicut Medical College, and now working at KMCT Hospital. He has contributed several papers in Indian and international journals and has written a textbook on pediatric gastroenterology. This year he got the IMA Best Doctor Award also. With these few words, I introduce Professor Riaz, and over to you, Riaz, sir.
Okay, thank you, Jidesh. Am I audible?
Yes,
Hello?
yes.
Sir, yes,
Mic
sir.
കാണുന്നുണ്ടല്ലോ?
Yes, sir.
Yes, sir. It's
Thank you so much, Sambhanu, for that excellent talk on constipation. From constipation, we shall move on to cholestasis. So neonatal cholestasis is actually one of the most daunting problems, one of the most challenging problems encountered in neonatology, pediatrics, as well as in pediatric gastroenterology practice. So what exactly is neonatal cholestasis? Cholestasis that is present at birth or develops within the first 3 months of life. You don't have to refer strictly to the first 28 days of life. Even if a child presents on the 80th day with cholestasis, that can also be called as neonatal cholestasis. This may be due to a score of conditions, right from anatomic causes to obstructions of the biliary tract tree. So what is the biochemical definition? Conjugated bilirubin is more than 1 milligram per cent if the total serum bilirubin is less than 5 milligram per cent. Or if the total serum bilirubin is more than 5 milligram per cent, then the conjugated bilirubin should be more than 20% of the total. What about the clinical definition? Any child with dark urine, that is coluria, staying in the diaper with or without pale stool. So this is the coluria or the high colored urine, and this is the pale stool of cholestasis. What are the effects? What are the consequences of cholestasis? What happens if the child has got cholestasis? You know that a lot of substances are normally excreted in the bile. All these substances will be retained. For example, when bilirubin is retained, that causes jaundice. When bile acids are retained, that damages the hepatocyte, that causes pruritus and deficiency of the fat-soluble vitamins. And if cholesterol is retained, that will cause xanthoma, as in this child with Alagil syndrome. So it's actually a differential diagnosis between well-looking versus sick-looking neonates with cholestasis. These are the well-looking babies with neonatal with cholestasis, like biliary atresia, choledochal cyst, etc., which I'm not going to discuss. So we shall be discussing mainly the sick-looking babies with cholestasis, starting right from sepsis to spontaneous perforation of the bile. All these babies appear very sick at birth. So what is the relevance of gender in neonatal cholestasis, or which gender neonatal cholestasis is more common? Females. It's mainly biliary atresia, which is 1.5 times more common, and this is choledochal cysts, which are actually 4 times more common in females compared to males. As a tip to the postgraduates, you can remember that both surgical causes, that is the biliary atresia and choledochal cysts, are more common in female babies. Consanguinity, several autosomal.
Hello.
Hello, we can't hear, sir.
Sir, mute ആയിട്ടുണ്ട് തോന്നുന്നു.
Yes, sir.
So I think it's pressed the button, mute button. So this.
Hello.
We have some technical issue regarding the network. So we are facing a little pause here. Meanwhile, we will have a working lunch. So we request all of you we inform you all of you that the lunch is open.
കഴിഞ്ഞു കേട്ടോ.
Hello.
ആ കിട്ടി കിട്ടി.
Ah, okay.
കാണുന്നുണ്ടോ?
Yes, yes, sir.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Yes, sir.
We are receiving the session.
എവിടെ വരെ എത്തിയെന്ന് ഓർമ്മയുണ്ടോ?
Antenatal.
ഇത് കണ്ടിരുന്ന?
No.
Yes,
sir,
sir.
it's back. So, and the consequences of Corrosive. Consequences of.
ഇതല്ലേ? Okay.
Yes.
ഇതല്ലേ?
Yes,
Okay,
yes.
start. Sorry for the mishap. What are the consequences of cholestasis? All substances which are normally excreted in the bile will be retained. For example, when a bilirubin is retained, that results in jaundice. When bile acids are retained, that results in hepatocellular damage, pruritus, and deficiency of fat-soluble vitamins. And when cholesterol is retained, that results in xanthomas, as is in this patient with Alagil syndrome. So a sick-looking versus a well-looking baby. Well-looking baby, we are not going to discuss. We shall be discussing sick-looking babies with cholestasis, starting right from sepsis to perforation of bile ducts. So what is the relevance of gender in neonatal cholestasis, or which neonatal cholestasis is more common in females? Biliary atresia is 1.5 times more common, and choledochal cyst is 4 times more common in females compared to neonatal cholestasis, that is 4 times more common. So the tip for postgraduates is both surgical causes of cholestasis are more common in females. Consanguinity is also very relevant because several autosomal recessive diseases like PFIC, galactosemia, etc. can also cause cholestasis. Antenatal history, the mother gives a history of febrile chills and rigor or foul-smelling vaginal discharge, or the diagnosis that is neonatal sepsis, most probably urosepsis, and the commonly implicated organism is E. coli. Suppose there's a history of seizures, it may be due to intracranial hemorrhage secondary to vitamin K deficiency. It may also be due to severe hyperglycemia, as is seen in galactosemia, hypopituitarism, etc. What is the significance of history of intrahepatic cholestasis of pregnancy in the new intrahepatic cholestasis? Suppose the mother gives a history of intrahepatic cholestasis, then you should think of PFIC, especially type 3 PFIC. The practical difficulty of assessing color of urine stool in a neonate is, suppose the diaper is already stained yellow by high-colored urine. Okay? The diaper is already stained by the high-colored urine. And if you are collecting the stool in the same diaper, then it may be difficult to visualize the pale stool in the yellow diaper. So this can be very easily solved if you collect stool and urine, different transparent containers like this. Now, urosepsis is a very important cause of cholestasis, as I already mentioned. The most common bacterium being E. coli. The lipopolysaccharides released by the cell walls of E. coli release pro-inflammatory cytokines like IL-1 and IL-6, which may lead on to cholestasis. So it's very important to do basic investigation, especially urine routine examination, as well as urine culture in a child with a suspected cholestasis. And when you are requesting for USG, please make sure that the radiologist is evaluating the kidneys also for obstructive uropathy. Now this child has got neonatal cholestasis due to herpes. You can see the typical skin lesion is more commonly caused by the type 2 herpes virus rather than the type 1. This is a very severe disease, can cause disseminated infection, can cause encephalitis, and the babies will be very sick, and it's got a very high mortality of almost or more than 80%. This is that traditional method of diagnosing herpes. What is it? This is the Zang preparation. But nowadays we do not require Zang. We have got DNA, PCR, and viral cultures. So if the mother has got herpes in the antenatal period, it's important to give her acyclovir. And the neonate with herpes hepatitis should be treated with IV cyclovir. This may be life-saving. Another case, a 3-month-old boy born to consanguineous parents, pale stools, FTT, that is typical cholestasis, abdominal distension. I got a peculiar order of urine orders. What is the relevance of urine order in neonatal cholestasis or cholestasis in an older child? These are the clues. Boiled cabbage urine or rancid butter urine may be seen in type 1 tyrosinemia or the hepatorenal tyrosinemia. These children may subsequently develop rickets and the USG may show nephromegaly, nephrocalcinosis. Alpha-fetoprotein may be extremely high, and the urinary serum succinylacetone acetone will be very high. And most of these babies will be having severe coagulopathy, so it will be difficult to do a liver biopsy in these patients. Now coming to gestational alloimmune disease, which is previously called neonatal hemochromatosis. These babies are also be very sick. They have got severe intrauterine growth retardation. They have got intractable or severe hypoglycemia. Hepatosplenomegaly may be rare. And interestingly, the transaminases may be normal or only very minimally elevated, but the ferritin will be very high, and the alpha-fetoprotein, as in tyrosinemia type 1, will also be very high in babies with the GALD. So this is one condition wherein the baby may present with cirrhosis at birth itself. The neonatal cirrhosis, think of GALD. This is very similar, the pathogenesis is very similar to that of Arch incompatibility, fetal alloimmune injury. The treatment is with the IV, IG, and exchange transfusion. And if they do not respond, these unfortunate babies may require liver transplantation. The very high chance of recurrence in the next pregnancy, almost at the tune of 90%. With simple non-genetic test may help in the diagnosis of GALD, that is a biopsy of the lower lip. Minor salivary glands with hemocytin granules may be demonstrated. This is actually a minor surgical procedure which will help you to diagnose this condition. Another relative new point is that a baby with the GALD should not be given mother's breast milk. You know why? Because the mother's milk, his mother's milk may contain the metal antibodies which are directed against the neonate's liver. So it's very important to make sure that the mother does not give her milk. Somebody else's milk, that is called somebody else's breast milk may be given, or from the pool it may be given, but not the mother's milk. Another case where a 3-month-old baby, 6th child of consanguineous parents. Unfortunately, all the 5 children had died in infancy of an obscure liver disease which was never diagnosed. So when the 6th baby was delivered, the mother stubbornly refused to breastfeeding. She said that there is a poisonous snake in my breast milk which is killing my babies. There is the poisonous snake in my breast milk which is killing my babies. I won't breastfeed my baby. And the mother is absolutely right, because we diagnosed galactosemia in this baby. We put him on the usual treatment for galactosemia and he was doing extremely well. Unfortunately, he was lost for follow-up. So then he was treated by Ayurvedic doctors, ആയുർവേദക്കാർ പറഞ്ഞു പാല് കൊടുക്കാതെ പറ്റില്ല, എന്തായാലും പാല് കൊടുക്കണം. He was put on cow's milk, and after a few months he came back with decompensation. You can see he has developed hepatosplenomegaly and cataract, and he also died of spontaneous bacterial peritonitis. Mitochondrial hepatopathy is another important cause of neonatal cholestasis. These babies also present with severe IUGR, very weak cries of multi-system disease, involvement of the brain, maybe the involvement of cardiovascular system. Transaminases will be very high, and lactate will also be increased. Coagulopathy is another hallmark of mitochondrial hepatopathy. HLH is also very important. There are two types essentially. One is the inherited type, which is the autosomal recessive type. But remember that HLH may be secondary to viral infections also. Diagnosis is actually easy because the cytopenia, very high levels of triglycerides, very high levels of ferritin. At the same time, the fibrinogen level may be very low. And it can be, the diagnosis may be confirmed by bone marrow examination, which shows a typical cells like that is the hemophagocytosis. What is the treatment for HLH? Steroids, cyclosporin, etoposide, and bone marrow transplantation. So it's very important for pediatricians and neonatologists to do the HLH workup concurrently when you are evaluating a sick baby with neonatal cholestasis. So it's the duty of pediatricians to differentiate an extrahepatic cholestasis, which requires surgery, from intrahepatic cholestasis, which will not require surgery. So what all things will you look for in the eyes? Apart from icterus, you look for a subconjunctival hemorrhage, oil drop cataract of galactosemia. This is the cataract galactosemia, bite spots. Now, I usually ask my PGs, have you examined the fundus of this child? The most of them will answer that, and sir, I have not examined because most of them do not buy ophthalmoscope. So this is the iPhone, which may cost more than 1 lakh, whereas the ophthalmoscope costs only 10,000 rupees. It is essential for all postgraduate students because only if you have seen thousands of normal fungi can you ever pick up an abnormal fundus. Now, what is this? And you have to practice on your friends and all your patients. This is a lifelong possession, unlike iPhone. Now, what is this? Anybody in the chat box? The usual answer is this is a cherry red spot. Remember, this is not the cherry red spot. This is the normal fundus. This is the cherry red spot, which may be seen in Niemann-Pick C disease. What is this? This is the retinitis pigmenta, which may be seen in hepatocerebrorenal syndrome, that is a Zellweger syndrome, which may also present with neonatal cholestasis. This is optic atrophy, which may be seen in septo-optic dysplasia, which is known as de Morsier syndrome. That is hypopituitarism, which can also present with cholestasis. Now, how will you evaluate neonatal cholestasis if the baby is sick or FTT? It's very important to rule out sepsis, especially urosepsis. You rule out galactosemia, high ferritin suggestive GALD and HLH, very high alpha fetoprotein suggestive type 1 tyrosinemia and GALD. Serum lactate is increased in mitochondrial hepatopathy and citrin deficiency. I do the various tests for GALD. As I already mentioned, lip biopsy may be a simple test. MRI of the abdomen for hepatic hemostenosis may be sometimes done. And there is a role for bone marrow examination to help in the diagnosis of HLH. Now, when should a pediatrician refer a child with cholestasis to the pediatric gastroenterologist? I suppose all babies with cholestasis are more than 2 weeks duration. If you are not, it's not possible for it to come to a diagnosis, it's better to diagnose. Or if there's a family history of cholestasis, it's better to diagnose. And if the baby is present with hepatic failure at birth, neonatal hepatic failure, it's very important to refer to the pediatric gastroenterologist. So what are the causes of delayed referral? Misdiagnosis of physiological jaundice. So physiological jaundice is seen almost 60 to 80% of our normal babies. This may be unfortunately mistaken for, the cholestasis may be unfortunately mistaken for physiological jaundice. Or a child has got jaundice, the follow-up is not proper. Or you ignore the mother's complaint that the urine is high colored. If the mother is worried, you should also be worried. If the mother is saying that, doctor, the urine is high colored, you have to take it very seriously. This baby may be having cholestasis. And people resort to what's called heliotherapy, and we are very familiar, very happy with drugs like Li52. So go on giving such drugs, and the diagnosis and the referral may be quite delayed. So this type of referral is known as a road roller base of referral. The pediatrician is not aware of the importance of neonatal cholestasis, adopts the wait and watch policy, or tries non-specific drugs, which we already mentioned, refers quite late, and the baby will be very critically ill by then. But fortunately, thanks to the effort of the Indian Academy of Pediatrics, NNF, and ISGAN, our pediatricians, our brilliant pediatricians, as well as our postgraduates, are aware of the importance of the significance of neonatal cholestasis, and these babies are being referred more promptly now. And this is known as the fire brigade pace of evaluation. So it's very important for us to refer urgently all sick neonatal cholestasis. So the approach to any disease, and I think I did mentioned in my last class also, history taking will give you 80% of the diagnosis, physical examination 15%, investigations 5%. So we should be, once again, we should be like Sherlock Holmes. But unfortunately, the youngsters are bangor aggressive. So if you request for an ultrasound, they will do an MRI also. So you should not be, you should be like Sherlock Holmes, but definitely not like James Bond. So what is this? This is the Chakraviyuha. So Chakraviyuhathil ശരിക്കും 6 ആൾക്കാരുണ്ടായിരുന്നു. But what about the Chakraviyuha of neonatal cholestasis? There are 3 people in this Chakraviyuha. Who are they? These 3 unfortunate people. Number 1 is the unfortunate patient, the parents, and finally the pediatrician. All these people are in the Chakraviyuha of neonatal cholestasis because it's a very, very difficult condition to come out and to treat at times. So take-home points are conjugated jaundice is always abnormal in rule out biliary tears in neonatal cholestasis, identify treatable cause of neonatal cholestasis, and sick neonatal cholestasis is always an emergency. So vitamin K should always be given to all babies. The first thing a pediatrician should do is to give a shot of vitamin K at diagnosis. Now, how should pediatricians tackle neonatal cholestasis? This is please don't take it very seriously, a very lighter answer. Okay. This is how pediatrician should be. This is the pediatrician, this is the cholestasis. You should be aggressive. The European pediatricians are actually more aggressive. So that's how they tackle neonatal cholestasis. Whereas who are the most aggressive people in the world? They're the Americans. So let's see how the American pediatricians tackle sick neonatal cholestasis. Extremely aggressive. Now, how we used to tackle neonatal cholestasis in the past, not now. So we believe in non-violence. We are happy with heliotherapy in D52. So previously we never used to make a diagnosis, and the unfortunate patient used to die of his own without a diagnosis and proper treatment. This is not happening nowadays, thanks to IAP, NNF, and ISPA. So thank you so much for listening to me.
Thank you, Professor Riaz, for the excellent presentation. Questions, if any, can be entertained after this session. Thank you, sir.
Thank you, Riaz, sir. Thank you, M.V. Haridas, sir. Now I request Dr. Vijay Kumar, sir, to hand over memento to Dr. M.V. Haridas, sir. Thank you. Next, we invite Dr. Adira Ravindranath, the speaker for the next session, and Dr. Rakesh Raju to chair the session. Thank you.
Respected teachers, honored guests, and friends. Today, coming to the third case scenario-based session, a 4-year-old boy with chronic diarrhea and FET went to suspect malabsorption. Chronic diarrhea and FET has a significant impact on a person's quality of life. Both the child and parents are affected. To enlighten us on this topic, we have a distinguished speaker, Dr. Adira Ravindranath, who is presently working as consultant in pediatric gastroenterology, Apollo BGS Hospital, Mysuru. Over to you, ma'am.
Thank you very much. I thank Riya sir for making my job very easy because he has reiterated the fact that history is everything in analyzing a child with any GI problem, be it cholestasis, be it diarrhea. So here we're talking about a 4-year-old boy with chronic diarrhea and failure to thrive. So when do I suspect malabsorption? So before we go into the details of this case, let us try to understand digestion. Is it only malabsorption that we are worried about, or are there more layers to this term? So when you have food, there are different steps to absorption. First thing is solubilization. The food should be made into a form which can be digested. So that is called solubilization. After which the pancreatic enzymes, the enzymes at the tip of the villi will cause digestion of the food. Thereafter, mucosal absorption. And after the mucosal absorption, there is a post-mucosal transport, which is important. And finally, to coordinate all these things, a normal sensory motor neurohormonal regulation is also important. Why should we understand each of these steps? Because disorders can affect any of these steps. For example, if somebody has a problem with the bile acid secretion, the solubilization will not take place. Solubilization of fat, the micelle formation is not going to take place. So if micelles are only not formed, it's not going to undergo digestion and absorption. Similarly, if somebody has a pancreatic exocrine insufficiency, there is no digestion. So you don't have your lipases, you don't have your amylases to digest the food. So only if it is digested and broken down, it can be absorbed. Then comes mucosal absorption, and this is what we classically call as malabsorption, where the problem is in the surface, in the epithelium of our intestines. After mucosal absorption, especially fats, should undergo post-mucosal transport via the lacteals. So if there's some problem in the lacteals, it will again result in diarrhea. And how does sensory motor neurohormonal function help in digestion? It coordinates all these things. So if there is any abnormality, say the classical example is irritable bowel syndrome, where there are problems with the contractility of the intestine. Another example is, say, if somebody has an endocrine tumor, which will increase thyrotoxicosis, or a VIP secreting tumor, that is also going to cause diarrhea. So chronic diarrhea may be the manifestation of any of these disorders, and we have to understand what is the primary problem in a given child to tailor make our investigations accordingly, because you cannot do all investigations in all children who are coming with chronic diarrhea. So as I told you earlier, any problem in the luminal digestion because of the absence of the enzymes or the other things which are required for digestion will result in maldigestion. And any problem in the villi or in the surface of the epithelium will result in malabsorption. And any defective post-mucosal transport will affect the veins or the lymphatics. And finally, abnormal motility. Say a thyrotoxicosis patient can come with diarrhea exclusively because of increased motility. So the intestines are contracting fast, because of which there is no time for digestion and absorption to take place. So first step is to understand what is a predominant mechanism of diarrhea, and thereafter look at the underlying causes. And finally, reduction in anatomical surface area. A classical example is a short bowel syndrome. Say a child had malrotation and underwent resection, and the total surface area of the intestine itself is less. That will also lead to diarrhea. So when we look at this, this classification which I'm telling you is a very mechanistic or a physiological classification for our understanding. But to put it clinically, we have to look at a pathogenic classification of diarrhea, because the type of stools and the type of diarrhea will help you. So if it's a watery stool, then it can be either an osmotic diarrhea or a secretory diarrhea. Now, if the stools are because of an inflammatory pathology, then that inflammation could be because of infection, it could be because of allergy or an immunological phenomenon. Sometimes the diarrhea is actually fatty. It is a steatorrhea that we are dealing with than a watery diarrhea, which could be because of a maldigestion of fat or malabsorption of the digested fat. And finally, we have the functional causes of diarrhea. which may present like a chronic diarrhea, but we know that there is no obvious organic pathology happening here. So the first step is to differentiate whether we are dealing with a watery diarrhea, an inflammatory diarrhea, or a fatty diarrhea, and thereafter look at the underlying possible causes. So let's go to osmotic diarrhea. A classical example is a lactase deficiency. So all of us have the enzyme lactase at the tip of the villi, which will convert lactose to glucose and galactose, which can be absorbed directly. So if there is a deficiency of lactase, the lactose will go unabsorbed into the colon. And what happens to the lactose? The lactose will be acted upon by the colonic bacteria, and that will produce a lot of gas and will produce a lot of acidic stools, because of which these children will have the characteristic features of an osmotic diarrhea. They are explosive stools. Why? As soon as the child is passing stools, there will be a lot of gas production because the lactose has been acted upon by the bacteria in the colon. Gaseous abdominal distension, again because of the gas production. Perianal rash will develop when the child is having an acidic stool. So if you look at the stool pH, it will be less than 5.5. And when you measure the stool for reducing substance, it will be positive. More than all this, the stool osmotic gap will be more than 100 milliosmoles per kg. Just like how we measure the osmotic gap in our blood gases, similarly, apart from sodium and potassium, there is some other osmolar substance which is contributing to the stool osmolality, which will give rise to a widening of the stool osmotic gap. And classically, osmotic diarrheas will improve with fasting. Why? Because you need a substrate like lactose to be malabsorbed. And hence, these are the clues that you will get in a child with osmotic diarrhea. Lactase deficiency is one example that I'm giving, because lactase deficiency we see very commonly, which we call it as a secondary lactose intolerance. Okay, this can happen with any diarrhea, which will cause any problem with the tips of the villi. When the tips of the villi are affected, the lactase enzyme is lost, and many of these children can have a transient lactose intolerance even after an infective diarrhea. But here again, I want to clarify, lactose intolerance is different from a cow's milk protein allergy. We'll come to the details later, because cow's milk protein allergy is an allergy to the antigen. It is not because of lactose intolerance. However, lactose intolerance may be a part of the cow's milk protein allergy, just like any diarrhea, which will cause some denudation of the tips of the villi. And lactose elimination will work in a secondary lactose deficiency, but lactose alone elimination will not work in a cow's milk protein allergy. You have to eliminate the antigen. So do not get confused between a secondary lactose intolerance and a cow's milk protein allergy. Next, coming to secretory diarrhea. What are the usual causes of secretory diarrhea that we encounter? A classical example is because of an exogenous secretagogue like cholera, okay, where the toxin itself is causing the secretory diarrhea. E. coli infection, certain types of E. coli infections will also activate the CGMP and cause secretion of the fluids, and along with that, electrolytes. How about endogenous secretagogue? So this goes out of our equation because we're dealing with a chronic diarrhea in this case scenario. But an endogenous secretagogue, like a VIP secreting tumor or a Zollinger-Ellison syndrome or carcinoid, can also present like a secretory diarrhea. And VIPoma can be very commonly seen in a 4 or 5-year-old child. They may be actually having a neuroblastoma, secreting a lot of VIP and presenting like a secretory diarrhea. The other cause of secretory diarrhea are absent ion channels, like congenital chloride diarrhea, congenital sodium diarrhea, which again will not present at 4 years of age. But yes, in a newborn or an infant, you should keep this also in mind, an absent ion channel. And loss of surface area, like a short bowel syndrome, will also be leading to a secretory diarrhea, because in the proximal part of the intestine, most of the enzymes are just secreted. And thereafter, distally, they are reabsorbed, okay, in the distal ileum and in the colon. So if you don't have enough surface area in this intestine, we will be in a net secretory state, which will lead to secretory diarrhea as a manifestation. So what are the clues that you will get here? The stools are going to be watery and they may be dehydrating stools. And the classical finding is no response to fasting because you don't need a substrate for manifesting diarrhea. And stool osmolar gap will be less than 50 and stool pH will be more than 5.5 because you don't have an osmotically active substance. And stool reducing substance are mostly negative in this case. It could be positive only if there's an associated denudation of the tips of the villi. Next, coming to inflammatory diarrhea, where there is inflammation in the inner lining of the intestine because of any cause. It could be allergy, it could be inflammation, it could be infection. So cow's milk protein allergy is a classical example, but again, a 4-year-old child is not going to come to you for the first time with a cow's milk protein allergy. We are going to consider it more in a younger infant. An ulcerative colitis, it will not cause malabsorption. They can still come to us with diarrhea, and if it is very severe, they can have some features of malabsorption, but classically among the inflammatory bowel diseases, Crohn's disease can present with malabsorption because Crohn's disease can affect the small intestine, whereas ulcerative colitis is going to exclusively affect the large intestines alone. And primary immunodeficiency disorders, which are now termed as inborn errors of immunity, because they may not just have immunodeficiency, they may have an altered immune response. And these are the disorders, like what Dr. Geeta ma'am told, will present like a very early onset inflammatory bowel disease. So there's a very gray area here when there is an inborn error of immunity and they're presenting to you like an inflammatory diarrhea. So we have to keep these etiologies in mind if you're dealing with inflammatory diarrhea. So how do we know whether it is an inflammatory diarrhea or not? So these are the clues that you will get from history. Is the diarrhea bloody? Is there mucus in stools? And if the colon is involved, they will have urgency and tenesmus. And when you do a stool examination, you will see plenty of pus cells. Okay, and another clue is if you do a fecal calprotectin, that will also be very high in an inflammatory diarrhea compared to the other causes. Fecal calprotectin is measured to see if there are excess of activated neutrophils coming in the layers of the intestine, because of which the calprotectin in stool may be high. So any inflammation will cause an excess of fecal calprotectin. So do not do it in a proven infective diarrhea. When you do not know whether you're dealing with an inflammatory bowel disease, this could be an easy screening test to say that yes, there is an underlying inflammation going on and I need to work up further. Next, coming to steatorrhea, fatty diarrhea. Here the mother will say that the stools are bulky, foul-smelling, oily, difficult to flush. So why would anybody develop a fatty diarrhea? So let's just have a quick look at how fat is digested and absorbed. So what is important in fat digestion is this emulsification with the help of bile salts to form the micelles. So anything which will cause an inadequate bile acid pool can also cause a fatty diarrhea. Sometimes bile acid synthetic defects will present like a fatty diarrhea rather than a cholestasis. So keep that in mind. Then next, after the micelles are formed, what do we need? We need the pancreatic enzymes like colipase, lipase, phospholipase to form the mixed micelle and then thereafter undergo absorption. So any exocrine pancreatic insufficiency will present with steatorrhea. Classical example is cystic fibrosis, or even a child with a chronic pancreatitis can develop a secondary exocrine pancreatic insufficiency. Then here at the end of micelle formation, the fat has almost got digested, okay, and then the fat, it is broken down into fatty acids, triglycerides, etc. And thereafter it needs to be absorbed also. So any mucosal disorder which is extensive can also present like a steatorrhea. So not just as an osmotic diarrhea, they can have components of steatorrhea. And thereafter, after absorbing into the enterocyte, it has to go into the blood, okay, by a proper lipid transport mechanism. So if there is a problem in that, there will be a lot of fat lipid accumulation, lipid droplet accumulation in the enterocytes, which will again lead to a fatty diarrhea. So these are the causes of a steatorrhea. So the clues here will be that the stool is very bulky, foul-smelling, oily, difficult to flush. And another important thing is they will have deficiencies of fat-soluble vitamins because you need these substances, the same fat, bile acids, and the pancreatic enzymes for absorption of the fat-soluble vitamins as well. So they can have history of night blindness, rickets, ecchymosis because of vitamin A, D, A, D, E, K deficiencies. So these are the other clues for you to judge whether it is a steatorrhea that you're dealing with. So in history, what will you ask? We will ask about the onset of diarrhea. How did it start? Were there any triggers to the diarrhea? If you're dealing with something like a food protein allergy, exposure to that type of food will trigger the diarrhea. And if you're dealing with something like celiac disease, exposure to gluten history should also be asked. Then another important clue is the presence of nocturnal symptoms. In a 3-4-year-old child, it's very common to see toddler's diarrhea, where the child is eating food and as soon as he eats food, he goes to the washroom to pass stools. Okay, but the stools are otherwise normal in consistency, child is thriving well, and these children will not wake up in the middle of the night to use the washroom. So toddler's diarrhea has to be kept in mind if everything else is normal. And this usually happens when they are consuming excessive high osmolar substances like juices. So you have to stop them from consuming juices and then give them some fatty meal because fat will activate the ileal brake because of which the diarrhea will reduce. So we have to differentiate whether you're dealing with a functional disorder or a truly organic disorder. And weight loss and poor weight gain is a real red flag, which is also there in our case scenario. And whether it's a dehydrating type of diarrhea. Remember, a steatorrhea or an inflammatory diarrhea like Crohn's will usually not be a very dehydrating type of diarrhea. Okay, it has to be a secretory or an osmotic diarrhea to cause a significant dehydration. And then type of stools. As I told you, the pander of information is there in the type of the stool. So ask the mother each and every point about the characteristic of stool. Show them pictures. Ask them to take pictures and send it to you because half our phones are filled with pictures of stools for us to ascertain what type of diarrhea are we dealing with. So it's very, very important to ask the mother to describe the stool and also see it for yourself. And also look at the associations. If there are a lot of fat-soluble vitamin deficiencies, then we know that we're dealing with something to do with the enterocytes because there is a mucosal malabsorption of the water-soluble vitamins. If there's a fat-soluble vitamin deficiency, it could be a problem with pancreatic enzymes, the bile acids. It could be a problem with enterohepatic circulation because the bile acid pool will reduce if there is a terminal ileal disease. Say if a child has a Crohn's disease affecting the terminal ileum and there is affection of the enterohepatic circulation, the bile acid pool will be lost in the stools. So you will have a relative bile acid deficiency that will also lead to fat-soluble vitamin deficiency. Then ask about abdominal pain. If there is associated abdominal pain, then you may be dealing with an inflammatory type of diarrhea. Most of the children with diarrhea may still complain of some colicky pain, but a child who has an underlying Crohn's disease, the pain is going to be very significant. And if the child is having any edema, if there is significant edema, it means that there is a protein malabsorption or the protein is being lost in the stools and you may be dealing with a protein losing enteropathy because half the information or more than that, the information is carried from the history itself. And when you're examining, you're basically confirming the diagnosis that you would have made after the history and also look for other factors. So an examination, what will you look at? These are some of the examples that I could give you. So look at this child. This child is having angular cheilitis. She's almost developing a Castle's necklace. She's having dry, scaly skin. Okay, these three pictures belong to the same kid and some clubbing. So if there are fat-soluble vitamin deficiency, I know that I'm dealing with something to do with the small intestinal mucosa. There is some clubbing. Clubbing can happen in celiac, in Crohn's disease. And look at this. This is a classical example of a erythema nodosum, which could be an extra intestinal manifestation of Crohn's disease. This belongs to another child. So these are the peripheral stigmata that you should look at during examination. So look for features of water-soluble vitamin deficiency, look for features of fat-soluble vitamin deficiency, and of course, signs of protein energy malnutrition is important. What else? Look for pedal edema, because that is also a clue to the underlying etiology. So when you look at the etiology of chronic diarrhea per se from the Indian group, this was done from SGPGI, less than 5 years of age, majority were CMPA, cow's milk protein allergy, because it was less than 5 years. It also included infants, and another 37% were because of celiac disease. But celiac disease is very rarely seen in the southern part of India, especially if they are basically from South India. But rarely we do see celiac disease here as well. And another 16% was because of toddlers' diarrhea, which we already discussed. And about 7% they had giardiasis, 3% had immunodeficiency, 1% had Crohn's disease, and 0.5% had lymphangiectasia. So we may not always deal with a pathological entity, but even though the percentages are small, we should not miss a case of organic disease leading to a chronic diarrhea. This is another study from the West where they included age up to 12 years. And here what has happened? 28% were functional diarrheas. It could be IBS, irritable bowel syndrome. It could be toddler's diarrhea. Here you will not have any red flags. But look at this. Almost 24% were inflammatory bowel diseases. So we should not forget Crohn's disease and ulcerative colitis. And Crohn's disease will present like a malabsorption syndrome. 8% were celiac disease. Another 8% were post-enteritis diarrhea. So after an infective episode, some of them will have some small intestinal bacterial overgrowth, some dysbiosis, which will lead to a post-infectious IBS sort of presentation. About 15% had allergy and food allergies, which could be a cow's milk protein allergy. It could even be an eosinophilic enteritis, which would be triggered by particular types of food. 8% were infectious diarrheas, 1% were congenital, 9% did not have diagnosis. In infectious, in this group, they also included Clostridium difficile, especially in children more than 1 year. When they had received antibiotics for a prolonged period of time, they acquire Clostridium difficile infection and cause pseudomembranous colitis and diarrhea. So these are the different etiologies which they have found real time in studies. So what is the clinical approach for a secretory diarrhea? So after the history and examining the stools, examining the child, you know that, okay, you're dealing with a secretory diarrhea. In a newborn, you should think of the congenital disorders of transport defects, enterocyte polarity defects, which needs to be confirmed by an upper GI endoscopy, histopathology, genetic study, electron microscopy. But in an older child, which is our case, we can think about, if it's in a secretory diarrhea, think about endogenous secretagogues like a VI poma, a carcinoid, Zollinger-Ellison syndrome. So then you can target the investigations and do the particular scans and send the levels. I'll give you a small anecdote here. There was a child about 10 years of age who was coming with recurrent episodes of diarrhea. And the mother said, each time the mother said that, oh, when he takes this medication, he improves. And what did she show us? She showed us a proton pump inhibitor. She showed us pantoprazole. And initially, we just thought it is a placebo effect that the child is having. But later on, when we worked up this child, he turned out to be a case of Zollinger-Ellison syndrome, which is rarely seen in childhood. But any history which the mother is giving will definitely have some importance. So do not disregard anything that the mother is saying. Now, if you're dealing with an osmotic diarrhea, you can see micronutrient deficiencies, and you know that there could be perianal rash, explosive stools, okay, where child becomes very gassy when he's passing stools. There is abdominal distension and improvement with fasting. Then again, we know osmotic means there's a problem in the inner lining of the mucosa. So the next step will be to do an upper GI endoscopy, histopathology, and work up for the causes. Like if you're dealing with a celiac disease, do the tissue transglutaminase antibody, work up for immunodeficiencies. If the histopathology is suggesting an autoimmune enteritis, then we send anti-enterocyte antibodies. So this is how we work up for an osmotic diarrhea. If it's a steatorrhea, we know it could be a fat maldigestion or fat malabsorption. So if you ask for a stool microscopy, if your pathologist is seeing fat globules and not fat crystals, that means the fat has not got digested. Okay, fat globules means there is no digestion of the fat. Fat crystals means fat has got digested but not absorbed. So if it's a fat crystal that they're seeing, Then you do the endoscopy histopathology, and you can do a breath hydrogen test for small intestinal bacterial overgrowth, and also do an imaging to see what is wrong with the small intestine. Whereas if you're seeing fat globules, it means the fat has not got digested only. So then you look for pancreatic causes, biliary causes. So look at the fecal elastase. Okay, if the fecal elastase is normal, liver functions are normal, then it could be a bile acid malabsorption. That is, bile acid is coming, it is not absorbed, like a terminal ileal disease. If the fecal elastase is low and if the LFT is normal, then we know that the problem is somewhere in the pancreas. If the fecal elastase is normal but the LFT is abnormal, then we know that it's a cholestasis which is associated with a steatorrhea. Why are we emphasizing so much on fecal elastase? Because this is one pancreatic enzyme which does not undergo digestion in the intestine, because you cannot measure fecal lipase and fecal amylase. Okay, and fecal elastase is passed as such in stools. So all of us will have fecal elastase, okay, in a good amount, more than 250. But if somebody is having an exocrine pancreatic insufficiency, it will be very low, it will be less than 50. So that will be the first clue to tell you that, yes, I'm dealing with an exocrine pancreatic insufficiency. If it's an inflammatory diarrhea, of course, from the history and the examination of the stools, and your investigations will tell you the elevated CSR, there is elevated ESR, CRP, elevated platelets, all as inflammatory mediators, low hemoglobin, albumin, and elevated fecal calprotectin. Here, calprotectin is a marker of the inflammation within the intestine. So if it's a newborn period that you're dealing with, then it could be an NEC, it could be cow's milk protein allergy, it could be infantile IBD, and also do not forget Hirschsprung's enterocolitis, which may present like an inflammatory diarrhea, okay, and not as a predominant constipation. But in an older child, like the child that we are dealing with, okay, rule out a CMPA if a child is like less than 2 years of age, okay, but also look for inflammatory bowel diseases and again immunodeficiencies. Okay, if it is inflammatory bowel disease, we have to do upper GI endoscopy, lower GI endoscopy, that is colonoscopies, take biopsies. And if the colon and the upper GI is not giving you an answer, then we look at the small intestine. We do an MR enterography or a capsule endoscopy. And once we know which is the area involved, then we do a double balloon enteroscopy to go deep into the area, take biopsies to prove that we are dealing with Crohn's disease before starting treatment. So although our case is a 4-year-old child, the etiology of chronic diarrhea in children will depend upon the age. So if you're dealing with an early infant, in early infancy, you can consider channelopathies, which are all because of abnormal ion channels, abnormal enzymes, etc. If it's an enzyme defect, it could be lactase deficiency, sucrase isomaltase deficiency, an enterocyte polarization defect. Here, the problem is with the enterocyte, or immune dysregulation. So immune dysregulation is more like an autoimmune enteropathy and other inborn errors of immunity. So immune dysregulation disorders, except for autoimmune enteropathy, all of them will present like an inflammatory diarrhea. Autoimmune enteropathy may present like an osmotic diarrhea. Enterocyte polarization defect, again like osmotic diarrhea. Enzyme defects, osmotic diarrhea. Channelopathies will present like a secretory diarrhea. And the others are lipid metabolism defects will present like a steatorrhea. Pancreatic disorders can also present in early infancy, especially when they have congenital problems like a Shwachman-Diamond syndrome or a Pearson syndrome. They'll all present like steatorrhea. And enteroendocrine cell defects, they will also present like a secretory diarrhea. Allergic, which is very common, cow's milk protein allergy and other food protein-induced enterocolitis syndromes can happen. And even eosinophilic enterocolitis can happen in early infancy. Others are Hirschsprung's enterocolitis, aganglionosis, pseudoobstruction. All of them may have an associated component of diarrhea in the background of a constipation. When you're dealing with toddlers, okay, most commonly we see functional toddler's diarrhea or post-enteritis diarrhea, but mucosal malabsorption can be a part of celiac disease, cow's milk protein allergy, autoimmune enteropathy, eosinophilic gastroenteritis, okay, some infections like Cryptosporidium parvum, tropical sprue, and inflammatory bowel diseases. And post-mucosal malabsorption can present like steatorrhea or protein-losing enteropathy in lymphangiectasias and A-beta lipoproteinemias. And again, pancreatic disorders can present in toddlers as well. In childhood, the list remains almost the same, but I've also included intestinal tuberculosis, although the incidence is coming down, and also small intestinal bacterial overgrowth. And any terminal ileal disorder can present like a steatorrhea. So let's look at this case. This is a 3-year-old child who came with history starting from 18 months of age with explosive gaseous abdominal distension, perianal rash with watery diarrhea. So we know that we're dealing with an osmotic diarrhea here. On examination, the child is having angular cheilitis, stomatitis, again pointing to water-soluble vitamin deficiency, pallor, and failure to thrive. So there is micronutrient malabsorption and growth failure. And we came to know that the gluten was introduced at 8 months of age. This was a North Indian child. And when we did the endoscopy, we saw the typical scalloping here. Look at the duodenal folds, okay? They are like scalloped like this. And when we took biopsies, it showed villus atrophy, crypt hyperplasia, and increase in the intraepithelial lymphocytes. Okay, so this gave us a clue that it could be celiac disease, and this child had a positive TTG IgA. So this is a classical example of a malabsorption, where the defect is in the epithelium of the intestine. So they will have osmotic diarrhea and they will have micronutrient malabsorption. Let's look at this other case. This is a 3-year-old child who came with bulky stools, difficult to flush, and oily. Okay, so this is a steatorrhea that we are dealing with. And the child is also having difficulty night vision, and there is rickets on examination. So again, pointing to underlying fat-soluble vitamin deficiencies. Stool showed a lot of fat globules, but fecal elastase was normal. So we saw fat globules. So I assume that, okay, fat digestion is affected, but fecal elastase is normal here. There is no exocrine pancreatic insufficiency. And interestingly, the peripheral smear here showed acanthocytes. Now we have the diagnosis in place. When we did an upper GI endoscopy, there was a complete whiteout of the duodenal mucosa. And what did the biopsy show? It showed all these lipid accumulation within the enterocytes, confirming a diagnosis of an A-beta lipoproteinemia. So if a child is having chronic diarrhea and has peripheral edema, low total protein, low albumin, and hypocalcemia and lymphopenia, then we know that we're dealing with something like a protein-losing enteropathy, a lymphangiectasia. So they will have edema, okay, which could be because of a lymphangiectasia, sometimes even lymphoma and tuberculosis of the retroperitoneal lymph nodes will increase the pressure in the lymphatics and lead to rupture of the lymphatics and lead to protein-losing enteropathy and lymphopenia. So upper GI endoscopy in this case will show a classical snowflake mucosa over here, and histology will show dilated lacteals. You can see this picture here. And in all the cases of lymphangiectasia, we should do an imaging, a CT or an MRI, to rule out secondary causes like lymphoma or tuberculosis before saying that they have a primary lymphangiectasia. So the take-home messages are that history is a guiding light in all the cases of diarrhea. Spend maximum time in history taking and examine thoroughly to narrow down the etiology, and always do only a targeted evaluation, because otherwise there are a big list of tests that you can do in every child with chronic diarrhea, and initiate specific therapy only after confirming the diagnosis. Do not just start on immunosuppression just because on the CT somebody said that, okay, there is thickened bowel loops, could be an inflammatory bowel disease, and then you start in immunomodulation or immunosuppression. Please don't do that. Always initiate specific therapy after confirming the diagnosis. Thank you so much.
Thank you, Madam, for the valuable insights. Madam highlighted various types of diarrhea and their pathogenesis. History taking is very important. And the topics are open for discussion.
Thank you, Dr. Adira, and thank you, Dr. Rakesh Raju. I invite Dr. Prashant Pavitran to hand over the memento to Dr. Rakesh Raju. The session is now open for discussion. Any queries can be raised.
Adira,
Yes, sir.
may I ask you one question? Because it is just a wonderful discussion based on the age and the macroscopic appearance of these stools, the watery, secretory, osmotic steatorrhea, and the other pattern you have discussed. In most of the cases, the stool macroscopy change is there. How is the classification of a selected micronutrient only? The channelopathy, like chloride diarrhea, sodium, the other things will ascend more. Watery diarrhea will be there. In the case of Imerslund syndrome, where the micronutrient, one selected micronutrient only is deficient, is it included in the malabsorption? Is one question. Another one is among the disorders, the intestinal lymphangiectasia is a special group which doesn't belong to any of these things, where once absorbed, the nutrients are coming down. Is there any possibility of an estimation of albumin in the stool? So that there can be a definite clue, because the thing which is produced inside the body is being lost, and that can be estimated in the stool. Can that be utilized for intestinal lymphangiectasia? The other thing is the motility disorders, carcinoid, many VIPoma, all these things are considered. Whether dysautonomia also need to be intestinal motility disorders. What is the classification of dysautonomia in this group?
Yes. Very nice question, sir. First question about the malabsorption of specific nutrients, like Imerslund-Grasbeck syndrome, where there is a problem with absorption of vitamin B12. There is a problem in the amnionless protein. That is a protein which is in the terminal ileum for vitamin B12 absorption. So when it is a specific nutrient defect, they may not always present with diarrhea. They may present with only that particular nutrient deficiency, except for, say, Actodermatitis enteropathica, where zinc absorption is a problem. But because zinc is very, very important for epithelial integrity, they can present to us with diarrhea. But the other specific disorders can present with that specific micronutrient deficiencies. But yes, they will also come under that umbrella of malabsorption. So same thing with the bile acid malabsorption. Okay, they may present with just a fat soluble vitamin deficiency. They may not always have a diarrhea. So when there is a particular nutrient deficiency, we evaluate for nutritional causes first. If nutritional are ruled out, then we can look at the specific receptor defect which is causing this malabsorption. Now, second question is about lymphangiectasia. So in lymphangiectasia, what happens is there is increase in the pressure in the lymphatics, because of which they rupture and we lose the absorbed substances. So as you said, instead of stool albumin, the measurement that we use is a alpha-1 antitrypsin in the stools, which is very specific for diagnosing protein-losing enteropathy, but its availability is an issue in India. And the other thing that we can do is a technetium 99 labeled albumin scan. So once we give that, we know that the albumin is coming in the body, we give parenterally, and then it is lost in the intestines. But both these tests are difficult to do because of the deficiency in availability. So because of which we are relying on the other parameters, like the biopsies will give us that there is lymphangiectasia. So then we can work up for the secondary causes. One more question you had asked, sir. What was that?
The dysautonomia.
Yes,
motility disorders will
yes.
be included in that.
Yes, dysautonomia, the classical example is, say, thyrotoxicosis, where there is just increase in the rate of contractions of the intestines. Even IBS is a type of dysautonomia, but there are so many other aspects to IBS where there is dysbiosis also. So dysautonomia, especially in hormonal disorders like thyrotoxicosis and even enterocyte and endocrinosis, will have an increase in motility. They will present with diarrhea. So how do we evaluate? Since these are rarer disorders, we will still go stepwise because they may present like a secretory diarrhea because there'll be a lot of watery stools, but you will still rule out the other common disorders before looking up for the other dysautonomia features. And most of the time, the dysautonomia per se will be more of constipating phenotype. Like if there is a problem in the in the in the intestinal nervous system, so the enteric nervous system, many of them will present with a pseudo obstruction or a slow transit constipation rather than diarrhea. So when it is a diarrhea, it's more of an external factor which is stimulating these nerves, which is causing the increased motility.
In the dysautonomy in the adults, diabetic and all, will present more with diarrhea. And why it is not so in a child?
Yes, in neuropathies, yes, they can present with diarrhea, but here again, it may not be diarrhea, they may just present with increased frequency of stools. So how do we assess them? It is very difficult to assess the enteric nervous system. So manometry and all these things have been developed mainly for assessing dysmotility. And sometimes we can assess that, okay, there is increase in the rate of contractions, but to specify that, yes, this is a neuropathy which is causing it, we will need full thickness biopsies to prove it. But most of these patients will present more like a slow transit constipation and pseudo obstruction in children.
Thank you, Dr. Adira. So we move on to our next session. The next session is timing the intervention in GI emergencies. It's a time-based discussion. We have 3 talks, 15 minutes each. I invite the first speaker, Dr. Jagdish Menon, sir. I invite Dr. Shimi Paulo, sir, to chair the session.
Good afternoon, everybody. I think so Dr. Jagdish has already been introduced, but keeping it short, Dr. Jagdish, I think he's done his MBBS from Government Medical College at Calicut, and then his MD as well as his DM, he had done it from PGI Chandigarh. And presently he is working at Dr. Rila's center at Chennai. So I think so we already heard his first talk, and now the second talk that he's going to be talking about is upper GI bleeds. Something I think so very rarely that we see in pediatric, but of course once we see it, we have to think many things. And then I think so Dr. Jagdish will take us to the journey of upper GI bleed. Over to you, Dr. Jagdish.
Thank you, sir. So good afternoon. I think probably the first slide will finally land up in the whatever the conclusion is in my session. I think we always believe that when a child has upper GI bleed, the next modality is endoscopy. But actually that is not true, because the life doesn't solely lie in the hands of a gastroenterologist. It lies on all those doctors who are actually managing, that I'll take through in the subsequent slides. Let's go to the ligament of Treats. I think whatever the basic anatomy topic of the MBBS first year. I think this is a ligament which actually suspends the...
There is, I think the audio is not clear.
Okay. Sir, is it audible?
Yeah,
Okay,
yes.
I think I should stand straight rather than almost like this. No, it's okay, sir. I think so. Yeah, I'm sure. So basically, there is the suspensory ligament of the duodenum, which is known as the ligament of Treats, which actually suspends the duodenum, but functionally they say that it is not like something that actually suspends the duodenum, but that helps us to delineate the landmark between the upper and the lower GIT. So the upper GIT basically has esophagus, stomach, and duodenum, and the rest actually happens in the later gut. So this is a geographic distribution. I think I'll go to the slide next. There is a gross division of etiology of upper GI bleed between the west and the east. This west and east is probably not related to a midline between west and east. It includes, I think, wherever the Caucasian race is mainly dominant, I think the etiology is different. Where the Asian race and the African race is different, the etiology is actually different there. So this is a paper from the west, actually, where they have seen that the duodenal ulcer, the peptic ulcer, that is the commonest cause of GI bleed in the Western countries. And if we see their review articles, I think that is the upfront thing that is mentioned in 1 month to 2 years and greater than 2 years. Whereas the varicose bleed is somewhat in the middle, or sometimes you can even see it down. Again, a study from the Eastern globe, this is basically from Dhaka, in which they have seen the varicose bleeding as the most important cause of upper GI bleed in the Asian countries. And we have a corroborative review article from India, which actually again highlights that the most common cause of an upper GI bleed in the Asian part is again a varicose bleeding. So there is a difference between etiology between the west and the east. So what are the commonest cause of esophageal varices? So this is a study which was done from Chandigarh actually, in which they have seen that EHPVO was the commonest cause, followed by cirrhosis, and later rare disorders like congenital hepatic fibrosis, NCPF, and HVOTO. So when we go into the management aspects, I think clinically or practically, the single most important clinical sign that I always believe which will help in between differentiating between an duodenal or a gastric ulcer bleed versus a variceal bleed is the presence of a splenomegaly. So if there is a spleen, then the varices are, and it is predominantly a variceal bleed. If spleen is absent, it could be something related to mucosa. Why GI bleed is an emergency condition? A large volume of loss of blood. In variceal bleed, it will be the vein that is opened up, the blood will go. Second is an ulcer can have a bleeding vessel. It seems apparently that an ulcer is a small thing. It could be a small thing, but there could be a feeder vessel behind that. Rather than a feeder, it will be a vessel that has been eroded actually. So that will bleed like an artery. And it cannot be managed just with the PRBC or anything else because it is not a defect of coagulation and it is not a defect of platelets in fact. And the underlying cause, for example, the child has EHPV or cirrhosis, it can lead to repeated episodes actually. This may not be the only episode. So this is an emergency. Finally, there will be severe hypovolemia, anemia, all those things which lead to a cardiorespiratory failure. So when we go for resuscitation, I think the first thing when we get a call from the ER or anywhere that the child has a GI bleed, please come and do the endoscopy. But that is not the first step in managing a child with upper GI bleed. So this is the point that I want to emphasize. The survival of the patient just does not lie in the hand of a pediatric gastroenterologist. It mainly lies in the physician who is there in the emergency room and also with the ICU doctor who is there. Because the first step of resuscitation is probably going to make the child survive the initial stages. So it is a big no. I think putting the scope is not the first thing that is always to be done. Majority can be managed medically actually. When I go to the subsequent slides, will show that there are wonderful drugs which can arrest variceal bleeding, and medical management is actually life-saving. Endoscopy obviously is an invasive procedure. It's not safe in an unstable child. There are concerns of anesthesia. There could be recent food intake and actively bleeding. This is a practical thing that we see. Even though we have a lot of machines, we can say we can suction the blood. Something is bursting like hell. I think sometimes when you insert the scope, you won't be able to see from where this blood is gushing. Only when we see that location, we can put a band or inject things there. So these are the practical issues why upfront endoscopy is not the thing that we do in a child who is actively bleeding. Stabilize the child and then only take up for endoscopy. So how to identify the severity of bleed? There are two classifications which are usually used, but for practical purpose, I think we should take it as mild or severe. There is no moderate bleed because moderate and severe, almost the management are the same. That is why the Sheffield group, which is probably the world authority in pediatric GI, like endoscopy thing, has proposed this as the child had a melena. There is a heart rate which is more than 20 beats. With respect to the age, hemoglobin drop by less than 2, if at all we know the hemoglobin, baseline hemoglobin, and there is an increased capillary refill time. That is more, it is mainly a severe bleed. Immediately what we do, I think the steps, basically, so this slide actually shows how we approach it in fact, rather than, I think so there is an immediate step, there is a resuscitation that we do, then we determine the site of bleed, and then goes the absolute treatment for this bleed. So along with the clinical, for example, if somebody is assessing the child, there is no harm in touching the abdomen, we'll obviously get a spleen, but we have to remember that in a subtle cases of EHPVOs, the spleen may be absent, which is known as Smith-Howard syndrome. This condition where there is an autonomic response, where the body tries to squeeze the spleen so that the circulatory volume is somewhat maintained. It is not very common. So it is nowadays we have bedside Doppler, which can actually show whether there is a portal vein cavernoma. So it is always prudent to have a portal vein Doppler on bedside, and it is quite available in all hospitals nowadays. The first step is basically stabilization, as basically airway and breathing. Endotracheal intubation may be needed when the child has massive bleed because they may aspirate it. and when the child has altered mental status. Supplemental oxygen if the child is putting tachypneic and saturation is somewhat less than 94%. Circulation, we have to target a normal heart rate and BP for age. We should not target a higher BP because the varices may again open up because of the hyperdynamic circulation. So these varices can actually open up and again they can cause bleeding. If there is a persistent shock, we have to consider colloids, but the fluid of choice is always crystalloid, but the shock is persistent, you go by colloids. Central venous line has to be inserted, the child requires any inotropes. The target hemoglobin is 8 to 9. Do not keep the HB low, hyperdynamic circulation, again bleed. If it goes up again, the same thing which increases bleed. The blood products are, I've mentioned the criteria there when to use the blood products. Continuous monitoring of vitals is very important and the child has to be kept nil by mouth, in fact. There are certain scenarios in which certain things needs to be emphasized. From the picture, we know that the anterior abdominal wall veins are there. This condition happens only in cirrhosis, not in extrahepatic causes, in fact, not in EHPV or other things. Cirrhotic bleed means the blood, I think this child already has issues in the gut in form of bacterial overgrowth. So there will be, whenever the bleed happens, there is a high rate of endotoxemia because of the underlying mechanical changes and whatever is there. So we have to start upfront IV antibiotics and anticipate a rapid deterioration in such cases because whenever a cirrhotic bleeds, this is not a good bleed. This child can develop ascites, HE, and all those things can happen, rapidly worsening jaundice, etc. So there is always a debate between nasogastric tube whether to insert or not. There are some authorities who says that we insert the nasogastric tube, the clot can be dislodged. But finally, the majority of the societies and even the IAP recommends to insert the NG. Why we should insert the NG? If we insert the nasogastric tube, we are almost sure that if the child has a melena, it is somewhat from the upper GI tract because middle gut can sometimes lead to melena because of the acid going down and reacting with the hemoglobin. If there is no blood in the lavage aspirate, unlikely to be proximal to ligament of Treats. So that rules out most likely an upper GI bleed. If it is a coffee ground, that means it is a reacted blood. No fresh blood is happening, exclusively coffee ground. But if there is a fresh blood with coffee ground, still by logic, it should be a new bleed. And ice cold lavage is no more recommended because that does not go by that principle that it causes vasoconstriction and arrest bleed. It can actually have detrimental effect because it may affect the platelet and all those functions and aggravate the existing bleed. The cornerstone of management of upper GI bleed, especially I think in even variceal bleed, is pharmacological agents. In all cases, give vitamin K. Pantoprazole is the drug of choice. Many authorities stick on to infusion, but there are no head-to-head trials between infusion versus a twice daily higher dose. They say both are equally effective. The drug of choice in variceal bleeding actually is octreotide. I think the doses I have mentioned, it has to be given as a bolus followed by continuous fusion. You can see the efficacy. It is known as pharmacological tamponade. At approximately 70 to 80% of the bleeds will be stopped by octreotide, in fact. The duration to give this is 3 to 5 days. And they recommend that we have to ideally demonstrate with a repeat scopy to show that the bleeding has been arrested before we stop. But for practical scenario, we usually don't do this thing. It is even partially effective in non-variceal bleed, it seems. So the mechanisms, this acts by splanchnic vasoconstriction and inhibition of the hormonal secretion actually. So that's how it probably works in a non-variceal bleeding too. Sengstaken-Blakemore tube, it is a thing that is used since ages. Still, there are scenarios which it needs to be used actually. It used to be a lifesaver during the time when the endoscopic services were not readily available. It works by balloon tamponade effect actually. Basically, we have something like a gastric balloon and an esophageal balloon. In children, we usually inflate the gastric balloon because the blood flows from below to up, and so only gastric inflation is necessary to stop variceal bleeding in children. The efficacy of SB tube is almost equivalent to that of octreotide, that is 70 to 80% of bleed can be arrested. If it is not getting arrested, then probably the location of bleed is different or your position of the tube is not right actually. It is not getting arrested, then the patient has to undergo an endoscopy in fact. The most important problem with this is the child has to be anyways intubated before inserting the Sengstaken Blake motive. So that is the only necessity which is required before using this tube. So do we need to intubate a child before doing endoscopy? Because endoscopy comes to the fourth step of that arrow that I had shown actually, because that proves the ultimate management. The patient has altered sensorium and is actively vomiting blood. Yes, we have to do. Always there is a golden question. You get a call when to do scopy. People have told 6 hours immediately. They have told 12 hours, 24 hours. Even certain papers mention 24 hours. But this Baveno consensus, which happens in Italy, they always revise like every 4 to 5 yearly. So the latest Baveno says that in a variceal bleed especially, the first endoscopic timing should be within 12 hours of when the child reaches the emergency. This can be early too. Only thing is the child needs to be stable. So that is the most important necessity that is there. There are certain scores which may say that this child probably requires endoscopy. This is from the Sheffield score. There are some analysis in which it has been found to be useful. So many a times when we insert the scope, you may see things very, very clearly. It looks like it is there and you are just going to apply the bands in a very nice way. It is just looking at you and you apply the bands. It looks so smooth here. Even the ulcer is looking at you. But that may not be the scenario always. You can see the pool of blood. The varices is just injecting blood there. You need to isolate the varice there, suck out the blood around, apply the band. Same applies to the duodenal ulcer. Totally clean picture versus a totally dirty picture. So endoscopic variceal ligation is the preferred endoscopic modality to control a variceal bleeding. It is usually ligated in a spiral fraction, and the gastroesophageal junction has to be avoided because it subsequently may lead to a narrowing there. So various ligators are available even for young kids. It has started getting available now. Rapidly downgrades the varices. It has to be repeated every 2 to 4 weekly so that the varices are completely gone. So usually on an average, they take around 3 to 4 sessions in EHPVO, but in cirrhotics, it may be actually more. There are complications which can happen like ulcers, strictures, and sometimes dysmotility. The major disadvantage is for small varices, you cannot actually do it with EVL. So there is, that is a time when the role of endoscopic sclerotherapy comes by using various sclerosins, morovate and tetradecyl sulfate, alcohol. It is basically good for small esophageal varix. This is important because sometimes you may have a small esophageal varix which can have a red veil sign. That means some part of that vein would have a very, very weak wall which can even rupture and cause bleed. So in that case, this is probably useful. But the complication rates are actually more for endoscopic sclerotherapy. So it is done only in the later scenario that I described now. So this is a study by Dr. Zargar's group from Kashmir in children, in which they have seen that the efficacy of EVL and EST was almost equal, but the side effects caused by EST, the sclerotherapy, the injection was slightly higher than a variceal ligation. For gastric varices are a bit resistant for applying the band because of the anatomical location and the numbers that are there. So we have to inject a glue so that it is totally sclerosed. For the bleeding gastric and duodenal ulcers, thermocoagulation, adrenaline injection for vasoconstriction, etc., and even hemoclips. We can introduce certain clips and apply it to that base of ulcer where the vessel is bleeding. And in recurrent or refractory cases, you have to go for a shunt surgery, TIPS kind of shunt and surgical shunt like a spleen or renal shunt, sometimes vessel embolization. And cirrhotic recurrent bleeds, finally they will land up in a liver transplant because they will decompensate in the form of encephalopathy, ascites, and worsening of the liver functions. So concluding my talk, upper GI bleed is very scary for the patient and the treating physician actually. Endoscopy is not at all the upfront modality to treat the upper GI bleed because the initial step of stabilization and resuscitation would save the life of the patient, followed by the absolute management of endoscopy, which actually seals it. Octreotide does wonders in variceal bleeding. Ideal time to do endoscopy is probably within 12 hours of GI bleed. Thanks a lot.
Thank you, Dr. Jagdish. I think so. think so. You're the only gastroenterologist who put up the slide saying that the pediatricians have to do the big work first before you send it. But anyhow, what he said is very true, stabilization. But I think so, like your first word and your key messages is the main thing. Scary for all. So that is why I think so we send it to you. Thank you for that beautiful talk.
Thank you, sir. Thank you all.
May I invite Dr. Shimi Paulos, sir, to hand over the memento to Dr. Jagadish Menon. I invite Dr. Selim, Senior Consultant Pediatrician, CM Hospital, to hand over the memento to Dr. Shimi Paulos. For the next session, I invite Dr. Rama Krishnakumar, Consultant Pediatric Gastroenterologist, Maulana Hospital, Perindalmanna, for the talk on foreign body in GIT. To chair the session, I invite Dr. Sharath Babu, Intensivist, Srijant Hospital, Kannur.
Thank you. Hello, am I audible?
Yes, sir.
Okay. So next topic is foreign body GIT. So hope you all face this kinds of several times and in the emergency department. So accidental ingestion of coins is the most common actually we come across in emergency department. If it is not in the airway, then we are all are cool, and then we'll take the X-ray, and then we'll just ensure that whether it's in GIT or in the airway, or if it's in above the diaphragm or below the diaphragm. If it's below the diaphragm, we will wait, and then to come with the stools. Okay. Then so today we have the eminent personality, Dr. Rama Krishnakumar. She's a senior consultant gastroenterologist in Maulana Hospital, Perindalmanna. And then she did both MBBS, MD from Calicut Medical College, and later completed DM from Madras Medical College. And then she has an excellent academic achievements with a lot of gold medal. And then also she has a lot of publications, both national and internationals. So over to you, madam.
Thank you, Dr. Sharath, for the introduction. I seek to correct Dr. Sharath in that I don't have any international publication. Anyway, thank you so much, sir, for the kind words. My topic at the very outset, my thanks to IAP Kerala as well as IAP Vadagara for the opportunity. My topic is foreign body in GIT. My profound apologies for not being able to come and deliver the talk in person. So foreign bodies in the GIT, particularly the pediatric foreign bodies, have really astonished, and they've really taken the limelight even as early as a century back, when Chevalier Jackson, the father of endoscopy, had a pioneer's collection of pediatric foreign bodies that he had collected. And here he had even elaborated a lot of scenarios where children used to ingest foreign bodies close to a century back. So it was such a rampant issue, right, even 1 century back, and it was addressed by foreign body removal even then. Now, it's a very complex topic, but my topic is to make the timing of intervention in foreign body clear. So I'll try to stick to that. So when to suspect, as far as the pediatrician is concerned, I would like to repeat what Dr. Jagadish said, because here the heroes are the pediatricians. They need to identify the foreign bodies, and they need to timely refer it to us gastroenterologists. So when to suspect and when to refer is the most important part, is rather one of the most important parts of dealing with foreign bodies in children. We have certain guidelines, so I'll try to touch upon that. And how do we do it? That will be of secondary importance, because the timing is of the most importance in this talk. And the case scenarios and experience of our Maulana experience also I'll touch upon. So I will be sticking to the guidelines that the NASGAN and the SGAN have postulated, the North American Society of Pediatric Gastroenterology, Hepatology and Nutrition, as well as the European Society. So foreign body ingestion, as Dr. Sharath pointed out, is the major cause of pediatric ED visits. And 80% of all foreign body ingestion happen in children. And most of that, unfortunately, in smaller children, were, general anesthesia will be required, and removal and retrieval will be far more difficult than in older children. So in the nature of ingested foreign bodies, you could look at Dr. Jackson's collection. It was more of coins, toys, jewelry parts and all that. Now it has moved to magnets and button batteries. I seek to correct Dr. Sharath in that, coins are forming a very big bulk of our ED presentations, but button batteries are striving to catch up, and now many of them are button batteries too. So fewer reports of metallic coin ingestion and more often button battery ingestion and food bolus impaction is being seen nowadays. So 80 to 90%, they are uneventful. The foreign body passes out without complications and are evacuated in feces. But 10 to 20% of our foreign bodies, they require removal, especially the longer ones, the wider ones, the ones with more diameter, and those in children who have had previous gastric surgeries, those who have esophageal strictures, etc. Now, they may not tend to, move it down the GIT. So what the foreign body is, where it is impacted, and when it was ingested, these are the three factors which are, those are the things that decide the morbidity of pediatric foreign body. So the complications are rare, include perforation, obstruction, bleeding, airway compromise, peritonitis, fistula, abscess formation. Though they are rare, we have to be on the lookout of these complications. So because of that, pediatric foreign bodies assume a lot of significance. So I would like to reiterate again that pediatricians are the kingpins as far as the initial assessment of foreign body is concerned. So concerned. So did you witness the child ingesting? You have to ask the parent whether they witnessed the child ingesting a foreign body. That is a positive history. Or did the child report to you that he ingested a foreign body? What is the foreign body, especially if it's a earring or something where they have a second piece like that, or a button battery or something where they have a second piece like that, they can bring it and show us. So that we'll have an idea as to what was ingested, whether there are any sharp parts in that, etc. When the child ingested the foreign body, has it been found in the stool already? Sometimes they will bring the child with the foreign body which has been passed in the stool already. So we have to ask them, and also whether the child has previously swallowed any objects before. This is very important as far as two things are concerned. One is, if the child keeps on having impacted foreign bodies, then we'll have to think in terms of if it's in the esophagus, some esophageal pathology like an underlying stricture or an eosinophilic esophagitis, those things have to be suspected. Or if the child has swallowed one magnet and just prior to that the child has swallowed another magnet, if you get that history, it's very important, because a single magnet may not be that problematic, but two magnets are very problematic. So this diligent history taking as well as the physical examination will give a fairly good idea as to how foreign body, what is the situation where the foreign body is. So the esophageal symptoms, child may be totally asymptomatic, or because of the luminal obstruction, the child may have dysphagia, drooling. Sometimes little children may just present with food refusal. So if a child is refusing food, if the child is having vaguely, vague stridor and all that, you have to have a significant index of suspicion of a foreign body ingestion. If there is any hematemesis, emesis, foreign body sensation, chest pain, stridor, cough, unexplained fever, all these are indications of possible esophageal foreign body impaction. Coming to stomach, mostly they may be asymptomatic, but again, they may present with abdominal distension, pain, vomiting, and lower GI ones with hematochezia, etc. So a diligent history again is the pediatrician is really important in obtaining a diligent history. Now, coming to the physical examination, look for signs of perforation, look for signs of obstruction, look for signs of tracheal compression, and sometimes you think the foreign body is in the esophagus, but actually it is in the trachea. So look for stridor, wheezing, etc. also. So a diligent, and also have a good look at the airway, breathing and circulation, and manage it before you send the child for a foreign body removal. The next thing that a pediatrician should do is to take an AP and lateral X-ray of the chest and abdomen as may be required in the case, as well as lateral films, because lateral films can help in distinguishing foreign bodies, coins, etc. in the esophagus versus trachea. I'll come to it later on. Contrast studies nowadays are of limited role and are contraindicated in perforation or obstruction. So please don't go in for contrast studies. And endoscopy is the single most important diagnostic and therapeutic therapeutic tool as far as the foreign body removal is concerned. Now comes the most important slides that I wanted to convey, the most important messages that I wanted to convey for the pediatricians are in the next two slides. When do we suspect, what to do, and when to refer? High index of suspicion in all the symptoms that I mentioned just prior, all these symptoms. Also, ascertain the history, a good history, as well as note the time of ingestion at referral. For example, if it is 10 p.m., please note down 10 p.m. on 10/7/24, so that by the time it comes to us, we will know how long has elapsed since the ingestion, because it's very important as well as corrosive things like button batteries are concerned. And also distinguish tracheal versus esophageal, so that you can triage there itself and refer to a pediatric pulmonologist or a pediatric gastroenterologist. What to do? The airway, breathing and circulation. Secure the airway, look at the breathing in the circulation, take the appropriate radiographs, and then refer. So when to refer? All esophageal foreign bodies need to be referred. Most of the foreign bodies need to be referred. So let's look at what all need to be referred positively. All esophageal foreign bodies need to be referred. One thing is, if you have a high index of suspicion, if there is no esophageal foreign body seen on the X-ray, it may be radiolucent. But if you have a high index of suspicion, if a symptomatic with a high index of suspicion, even if it is not visible on X-ray, please refer. If it's a long or a sharp foreign body, button battery, magnets, large coins in the stomach of children less than 5 years. You know why? Children less than 5 years, they have smaller pyloroduodenal openings. So coins more than 20 millimeters are very unlikely, 20 millimeters in diameter, that is more than 2 centimeter in diameter, are very unlikely to pass through stomachs of children less than 5 years of age. So large coins in stomach of children less than 5 years, please refer. And surgical referral for those who have for those foreign bodies beyond the stomach staying in the same location for over a week. When can you consider waiting? Small blunt objects in the stomach of older children. Immediately you needn't refer. 7 to 14 days is the time limit. So if it doesn't move down by then, you can consider referring, but it should be older children more than 5 years, as well as it should be very small. If the diameter is more than 20 millimeter, again, you have to think in terms of referring. It's a very small thing. It might pass down the pyloroduodenal opening. And asymptomatic objects which are likely to be beyond the reach of an endoscope. So you look at the pediatric foreign body on the X-ray and you find it's quite down into the small bowel, etc. Then there is no point referring for an immediate endoscopy. So asymptomatic objects likely to be beyond the reach of an endoscope, you can consider waiting, but again, all this has to be individualized. Now, what about the timing of intervention? Depends on the age, the body weight, the clinical presentation, the time since ingestion, the time of the last meal, the type of foreign body, and the current location in the GIT. So, as I said before, all esophageal foreign bodies need to be removed, especially esophageal button battery. They need to be emergently removed within 2 hours of ingestion. So, try to rush the patient to the pediatric gastroenterologist. And others also need to be removed very early if secretions can't be controlled. If secretions can't be controlled, it means there is a risk of aspiration, and also it is completely obstructing. So, you need to remove fast. If the secretions can be controlled, definitely still you have to remove within 24 hours, even if asymptomatic. And long foreign bodies also need removal. And stomach, button battery and coin, etc. Button battery you have to remove within 2 hours in symptomatic children, but more than if asymptomatic and in older children, there is a caveat that you can consider waiting is what the recommendations say. But again, if you are unable to take a decision, please refer. Magnets, which are symptomatic within 2 hours, asymptomatic within 24 hours, coins, symptomatic within 24 hours, and if it's asymptomatic, you can consider waiting, especially in older children and in smaller sized coins. Button battery, initially it used to be the alkaline button battery. Now it has come down to, it is graduated to the more lethal button battery, which can cause necrosis of esophageal walls due to electric current. The lithium battery has higher voltage. So anyways, it won't be, so obvious on the X-ray, but just to impress upon you the fact that button batteries are getting more and more lethal as well as common. Now, this is recommendation, NASCAN recommendation. The ones underlined in red, the button batteries, the magnets, the sharp foreign objects, food impaction as coin, as well as long objects, as well as absorbent things. Like for example, sometimes theoretically sanitary, parts of sanitary napkins, glass beads, etc. All these need to be removed, especially from the esophagus, except for again, coins which are gastric, which are asymptomatic, and which are there in older children, you can consider waiting. But not beyond 1 to 2 weeks. Button battery, again, asymptomatic, and in older children, there is a proviso to wait. If not moving on serial X-ray, you need to definitely go in for a removal. Now, again, in esophageal button battery ingestion, if there is active bleeding, you have to definitely, even if it's an older child, go in and do it in the operation theater with a surgeon present. And if there is an evidence of an esophageal injury, significant corrosive injury in the esophagus, a CT angiography to exclude aortic injury is required. If there is an aortic injury, you may even have to go in for a graft. And after the removal, you may have to go in for a contrast study to exclude leak before advancing the diet. And then one more scenario where you remove the foreign body and the child appears reasonably stable, but later on, after a few days, develops upper GI bleed, you have to suspect aortoenteric fistula, just to impress upon the entity of an aortoenteric fistula. Gastric button battery, less than 5 years, more than 20 millimeter, remove, and simultaneously also assess for a esophageal injury and manage, because you are focused on removing the gastric button battery, but the esophagus would have been corroded on the way down. So please look at the esophagus and assess for esophageal injury. Otherwise, it may lead to an esophageal stricture formation later on. Age more than 5 years, smaller size, you can consider observation and repeat serial X-ray. So I hope I've been able to carry across the message that all esophageal foreign bodies need removal, and gastric depending on the type of foreign body and depending on the time of impaction. Now, how do you distinguish a coin and a button battery on X-ray? A halo or a double ring sign on AP view and step off on the lateral view differentiates a button battery from a coin. See, this is a button battery. You can see the double rim, 2 rims there. So that is suggestive of this is on the AP view. On the lateral view, there is a step-off sign also, which can distinguish a coin from a button battery. So look, when the patient comes to you in the ED with that X-ray, when you take the X-ray, please try to distinguish a coin from a button battery. If you don't get a proper history, please try to distinguish it from the X-ray, because the management really can, the timing of management can really be urgent in case of a button battery. And this is the button battery, double rim sign here, and a step-off sign on the lateral radiograph. This is a button battery with significant corrosive injury of the esophagus, and the inflammation can even extend across the anteriorly from the esophagus to the proximity of the aortic arch. These are the kinds where there can be a fistula formation. In magnets, a single ingested magnet is usually low risk, but more than one magnet ingestion indicates preemptive removal, because they can stick together and they cause necrosis of the bowel in between them. So single magnets, better consider removal. If not, if you cannot go about it, serial X-ray and confirm passage. And also one more thing, even if a single magnet is ingested, educate the parents. If it's not being removed, remove the magnetic objects nearby, avoid clothes with metallic buttons or buckles close by, and ensure that there are no further magnets in the environment. Multiple magnets, endoscopic removal, if there is stomach. If it is beyond the esophagus or stomach, you can consider a pediatric surgical referral if there are multiple magnets, because it's beyond the endoscope but it definitely needs to be removed. Then you have to consider a pediatric surgical referral. So this is multiple magnets. And what about sharp pointed objects? They have a 15 to 35 risk of perforation in the esophagus. So immediate endoscopy is required. Radio opaque, you determine that it is there, you have to consider removal in esophagus or stomach. Small bowel, if asymptomatic, if it has come down into the small bowel beyond the reach of the endoscope and it is asymptomatic, you can reasonably wait. If seen. If it is still not seen, even on the other modalities, just observe for symptoms. What about esophageal footballers impaction? It needs to be removed, and also assess for underlying stricture or eosinophilic esophagitis, especially if it is getting impacted again and again. In older children, there can be peptic stricture. I had a child with a peptic stricture, severe erosive esophagitis, peptic stricture, and keeping on developing esophageal foreign body impaction in the lower esophagus. We had to, after the esophageal foreign body removal, first time child didn't come to me, second time child came, then there was an underlying stricture, and then we had to go in for an esophageal dilatation and a course of PPI after that. So don't stop with the esophageal foreign body removal alone if there is history of recurrent foreign body impaction. Now, coming to coin, again, esophagus how do you look whether it is esophagus or trachea? How do you distinguish? If the coin is in the esophagus, in the AP view, it appears in a coronal orientation. And if it is in the trachea, it appears in a sagittal orientation. So that's one way to distinguish. Now, we keep talking about coins. What are our coin sizes? 1 rupee coin is 2.5, 2 rupees 2.6, and 5 rupees 2.2. So as per the recommendation, it is 20 millimeter. So all of these are more than 20 millimeter. So especially in smaller children with these sizes, definitely I think we should go in for a removal. Older children, you can possibly wait if it is a smaller coin. Rare absorbent, I took it from PGH in 2023 journal. So it's, you see, there are glass beads and it had to be surgically removed. Now, SGAN guidelines are more or less like NASGAN guidelines, the same guidelines for esophageal and gastric foreign body. Now, actually, the timing of intervention is what I was given, that I've completed. But just to complete the rest of the scenario, what are the things that you use? The flexible endoscope as well as a laryngoscope has to be a laryngoscope when anesthesia etc. is required. Accessories: polypectomy snare, domia basket, rock nets, rat tooth, alligator forceps. The baskets and the nets can be the nets especially can be used for blunt foreign bodies, not sharp ones. The sharp ones are usually removed by the forceps. So this is a snare, this is a forceps, this is the one on the right is a net, and this is an open safety pin. Overtube and a latex hood are being used, but overtube very difficult for very small children because pediatric scopies and overtube may be difficult. And colorectal foreign body impaction is more seen in adults, less in children. But again, if you have index of suspicion, abdominal and pelvic radiographs, and there can be impaction at the ileocecal valve, sigmoid curve, anorectal junction, etc. And you can even remove it if it's impacted there. A proctoscope or a flexible sigmoidoscope can be used for removal, and there are many retrieval devices. The last 2 minutes of my talk, we have had various things at Maulana: footballers, button batteries, coins, bones, jewelries, plastic toys, sewing needles, safety pins, capsule foils, lot of things that have been. This was one of my earlier cases. Coin in the upper esophagus. Child had stridor because of the tracheal compression, and it had to be removed. And this was another one, esophageal foreign body removed with a roth net, the one in the second picture. This was a meat bolus in the esophagus of 11-year-old, which was removed somewhere during the Ramzan times. And it was a large one, which was removed with a roth net again. This is a fish bone, which is removed with a rat tooth forceps. Now, this was one of my earliest tryst with a foreign body, a 9-month-old baby. So it was an open safety pin in the stomach. It was just close to 13, 14 years back. And then always when you remove a foreign body, it's technical, but still when you remove a foreign body, the open end should be facing caudally when you remove it. This is recent, 2 button batteries from the stomach of a 2-year-old. There were 2, and then we could remove both. Then this is a needle in an 11-year-old child. A lot of mafta pins come in nowadays. And this is a anklet with sharp edges from the stomach of a 3-year-old. So that was also removed. This is a long lead pencil. Long foreign bodies more than 6 centimeters are better removed. So this is a long lead pencil from a 4-year-old child. So the take-home messages are: the GI foreign bodies are very commonly seen in children. The management depends on the type of foreign body and location. You have to have a high index of suspicion because many of them are not radiopaque. So I have a high index of suspicion and go about accordingly. All esophageal foreign bodies, better removed. Button batteries, better removed. Sharp, long foreign bodies, multiple magnets, they all generally warrant early removal. And once it is not picked up by a diligent pediatrician, late presentation is likely, and then the retrieval may be difficult, especially with corrosive things like a button battery. And management depends on the existing guidelines. Various endoscopic accessories are available, and rising awareness levels and parental education to prevent ingestion. This is as important as taking care. The primary prevention is more important. One needs to tell the parents that they have to be diligent in preventing children dislodging and ingesting, especially button batteries, which are very, very, very lethal. I thank you all from the bottom of my heart for a very patient hearing. And this was our endoscopic team. This was a picture which was taken close to 10 years back.
Thank you, Dr. Ramakrishna Kumar and Dr. Sharad Babu.
Thank you, ma'am.
Next, we wholeheartedly invite Dr. Banu sir for the next talk, corrosive injury in esophagus. I invite Dr. P.C. Haridas sir to chair the session. Thank you.
Good evening. Corrosive injuries to esophagus are most often caused by accidental ingestion of corrosive substances, which can cause severe acute and long-term complication, especially development of esophageal strictures. To enlighten the subject, we have an eminent speaker, Dr. Banu Vikram Pillai.
Thank you very much. So we will discuss about the corrosive injury of the esophagus. So as I correctly pointed out, it's often accidental, but it is so accidental in younger children. There are 2 peaks in life corrosive injury can happen. One is less than 5 years of age, and second one is the adolescent and young adults. The adolescent young adults very often can be intentional and suicidal. However, the children, young children, it is usually accidental or sometimes out of curiosity, or sometimes, corrosive substance kept in an unlabeled bottle like a Sprite bottle or any of those things, which child will drink it. So any of the, whatever way the way, the problem is once it is ingested, it is likely to cause problems. Now, there are 2 kinds of corrosive substances, for one is the alkaline substance, one is the acid containing. The alkaline substances, usually the household bleaches, most of them are alkali. Then drain openers, toilet bowl cleaners, is actually to your bowel, B-O-W-L, spelling mistake, sorry. Dishwashing agents, detergents, then acid containing agents, toilet bowl cleaners, vinegar, formic acid. When there's a rubber plantation around, formic acid is something that is kept around that can cause the child may ingest accidentally or deliberately. So this is the same thing, which is a little more detailed about what are the chemical substances. The drain openers that contains usually sodium hydroxide and sodium hypochlorite. Oven cleaners are usually high sodium hydroxide. Household cleaners are ammonium hydroxide and ammonium chloride. Bleach products, sodium hypochlorite and hydrogen peroxide. Dishwashing detergents, sodium carbonate, sodium silicate. They are all alkaline agents. Now, acid agents, toilet, again, it's a toilet bowl, B-O-W-L, bowl cleaners. It's hydrochloric acid or phosphoric acid. Metal cleaners can be hydrochloric acid. Anti-rust product, hydrochloric acid or sulfuric acid. Battery fluid, sulfuric acid. Jewelry cleaners, it is nitric acid. So is it alkaline or alkali? Both can cause injury. Now, what is the difference between the two, alkali and acid? All of you know the alkali means pH is more than 7 and acid is less than 7. The problem with the alkali, it is tasteless and odorless. So they are likely to ingest larger amounts, especially if they're taking it accidentally. And that will result in liquefaction, severe necrosis, and is more likely to cause deeper injuries. And some of the alkaline agents are solid form, like detergents are solid detergents, powder forms, and that is likely to cause injury in the proximal, like oropharynx and upper esophagus and mouth. And liquid form is more likely to cause esophageal and more likely to be extensive injury. Acid is less than 7 pH. It has got a pungent odor and noxious taste. So often they ingest smaller amounts unless it is accidental. Coagulation necrosis, unless it is suicidal, then they will take, even if it's pungent odor, they will take a large amount. And acid agents typically cause coagulation necrosis, unlike liquefaction necrosis for alkali. So the difference is the coagulation necrosis, the damage is typically limited to the mucosa, and it is more, the depth of injury is less compared to alkali. And less esophageal injury, but also can significantly cause gastric injury for acid. Now, what happens when you ingest it? Both degree of injury depends on acid or alkali. Either way, both can cause it. However, that depends on the concentration of the corrosive substance, the quantity, the physical state, as I said, solid or liquid, duration of exposure. Was it taken, just now versus maybe several hours earlier, maybe 2 days earlier? Presence of the absence of food in the stomach, intentional or accidental. The pathology, both will cause thrombosis and ischemia, and they just say dominant process. Inflammation, even though happens, is less important compared to the necrosis that is happening. The sites affected with acute ingestion, it is lips, which will cause the lip burns. Oral mucosa and pharynx can cause ulcers and bleeding and drooling. Larynx and vocal cords, because once it reaches the pharynx, vocal cords and larynx are right there. So it can injure the airway and cause hoarseness, stridor, respiratory difficulties, and they can come in respiratory distress. And esophageal mucosa can result in odynophagia, bleeding, and stomach can cause pain, abdominal pain and bleeding, and rarely it can involve the duodenum. Usually it is the mouth, the lips, the mouth, the pharynx, and the esophagus, and then the stomach. The esophageal injury, the early signs and symptoms may not correlate with the severity of the extent of the injury. And the oropharyngeal burns have a low predictive value of the severity of the esophageal injury. So absence of oropharyngeal burns does not rule out esophageal burns. So it's very important, even though the oral pharyngeal buds are not there, unless the child is absolutely asymptomatic, we definitely do the endoscopy to make sure and to categorize the extent of the esophageal injury. What are the symptoms they would with? The symptoms include drooling, lip burns, oral burns, nausea, vomiting, irritability, dysphagia and odynophagia, and abdominal pain. They can also come with the respiratory distress and stridor, and they can come with severe respiratory distress. They can come with the acoustic injury. The severity of injury depends, as I told earlier. It depends on the concentration of the substance, amount of the substance, length of the time which the tissue has come in contact with the corrosive substance, the pH of the more alkaline or more acidic the substance is, more likely it is to cause injury. Solids versus powder form and liquid form, and liquids are more in the esophageal injury, more likely to happen. Once it is ingested, the child is trapped in a web. So there is nutritional compromise. The early compromise, they can cause ulceration, hemorrhage, perforation, which is going to cause nutritional compromise. And late complication, they are very likely to develop esophageal strictures or gastric outlet obstruction or poor stomach capacity. Once this happens, that also further compromises nutrition. And once there is esophageal stricture, you are going to deal with esophageal dilatation very often, multiple times in the life of the child. So if there is a esophageal stricture, that is more likely to cause aspiration of the contents. And once you dilate, also there is gastroesophageal reflux can happen, and esophageal stricture and esophageal injury can cause tracheoesophageal fistula and laryngeal stenosis if there is airway injury. And many of these children sometimes may land up in surgical intervention because of the recalcitrant nature of the stricture or other complications. And long term, they can also cause CA esophagus, which is definitely almost 1,000 times more common to happen in corrosive injury compared to the general population. So the first time when the patient presents, again, Dr. Jagadish and Dr. Rama had been talking, about the role of the pediatrician. This depends on the pediatrician, because it's extremely important. We have to airway, breathing, and circulation. So resuscitation is the most important thing, especially if the child has got hypotension or respiratory distress. Then you have to put an ICU. And respiratory distress, if it is there, they may require steroids. And if the child is hypotension, or they may require inotropes and fluid resuscitation. And respiratory distress, as I said, ENT has to be immediately involved, and the airway edema, they may require urgent endotracheal intubation or tracheostomy, and these patients may require airway injury, can be benefited with steroid treatment. Otherwise, not much role. Examine for features of perforation. Look for the crepitus in the neck or the chest, and look for the air under the diaphragm in the X-ray. Laryngoscopy when is indicated. If there is significant ENT injury or signs of perforation, a contrast-enhanced CT of the neck and chest and or abdomen is necessary, and the surgical intervention probably will be required. If there is perforation, definitely will be required. Now, whether there are neutralizing agents, acid can be neutralized by alkali with acid, and activated charcoal, milk. However, do not use any of this in corrosive ingestion. Do not use alkali for acid or acid for alkali or any of those things, and do not use activated charcoal. Do not use any food or milk, because they can all further obscure the visibility during the endoscopy and also increase the risk of complications. Do not do gastric lavage. Do not use antiemetics. There is a role for X-ray. Plain X-ray of the chest, you can look for signs of aspiration and also see signs of, excuse me, signs of pneumomediastinum may be seen. X-ray abdomen, erect, also maybe signs of perforation can be detected. And contrast studies, especially thin water-soluble contrast only can be used, and after stabilization. And very often, if you sense a perforation, you may do with the CT, contrast as CT, not what just per a meal or per a swallow. Record the esophageal and gastric involvement, which is very, very important. CT scan is very useful in these patients if there is severe injury. When do you refer for the endoscopy? The candidates with symptomatic ingestion, or if accidental or intentional ingestion, suicidal or purposeful, even if they are symptomatic, needs to have endoscopy done. So the endoscopy is necessary to detect the injury and to grade the intensity and the severity of the injury. That is going to prognosticate how severe the future is going to be for that particular patient. Suicidal patients may not tell the symptoms which they have. They may not tell about the dysphagia or adenophagia or any of those. They may not say that because they want to die. But so suicidal patients, irrespective of the symptoms, need to get endoscoped. It is true for acids and alkali. Preferably, the endoscopy is done within first 12 to 24 hours, but can be done even up to 48 hours. Preferably not later, because the esophageal, the injury that when it happens, the tissue is the most friable and most fragile after day 5. So it's do not put anything in through there at that particular time. So the endoscopy is usually done within 24 hours. If not possible, maybe at least before 48 hours, if at all possible. Principles of endoscopy, they need to have adequate sedation because you don't want the patient to struggle, which can increase the risk of perforation and complications. Flexible scope, not rigid scope, and as much as possible, thin side scope is used for corrosive ingestion. Minimal air insufflation because the risk of perforation. Direct visualization, do not blindly advance it. And do not advance if circumferential second-degree burns or third-degree burns are seen, you stop it there. But if careful, some people may try to even further because sometimes there may be more severe damage further down which may be detected by the scope, but most people will stop at grade 2B or 3, and circumferential burns, if it is seen, stop it there and take out the scope. If no lesions in the stomach, then complete this, look up to the first portion of the duodenum. Now, what are the contraindications for endoscopy in corrosive injury? Hemodynamic instability. Just like Dr. Jagadish was telling, if the child is stable, only do the scope. You cannot do it without it. So the child is stable, do it. If there's an unstable child, do not do it. And hemodynamic instability, suspicion for perforation, necrosis of the oral cavity, and compromised airway, you try not to do the endoscopy. Now, there's a classification most of us follow, called Zargar's classification, which is accepted for seeing the intensity and the severity and the damage the corrosive ingestion causes, especially the esophageal injury that is caused. And the grade 0 means no injury. Grade 1 is just edema and hyperemia. 2A, there is injury, friability and hemorrhage, and small erosions and blisters may be there. Small exudate may be there, whitish exudate may be there, and superficial ulcer. But 2B is 2A plus deep ulcers or circumferential ulcers. They are once it becomes 2B, that is severe injury. 3A is areas of small scattered necrosis and brownish black or gray discoloration because of the necrosis. 3B is extensive necrosis. That's a grade 4 later they added, which is perforation. This is the various stages of the, it says it to grade 1, 2A, 2B, there are different circumferential injuries and all, and the last one, which is circumferential, and the black scar that you can see in the injury. Different set of photos, again, from endoscopy. Now, I said earlier, the CT scan has been very useful and has been used nowadays. So, but endoscopy still is number one in identifying the extent of the injury in the esophagus, especially, because the more severe the injury, more likely the child is going to develop esophageal strictures. So, because of that, endoscopy is a very valid instrument and intervention. There is correlation you can do with the CT score. And so when there's a grade 1 injury, there's edema and hyperemia in the endoscopy. And in the endoscopy, in the CT scan, there is no definite swelling with esophageal wall. Wall is within normal limit. 2A, there's friability and hemorrhages and erosions, blisters, whitish membranes, and superficial ulcerations. And 2B, as I said earlier, 2A plus deep and circumferential ulceration. And in the CT scan, you will see edematous wall thickening, and the esophageal wall is more than 3 millimeter, and without peri-esophageal soft tissue infiltration. So there is no perforation that has happened. 3A, there is small scattered necrosis, and 3B is extensive necrosis. And again, the CT scan, edematous wall thickening and peri-esophageal soft tissue and infiltration, because of the deeper injury for the esophageal wall that is causing the peri-esophageal soft tissue infiltration, and the interface can be seen. Perforation, of course, can be seen better with the CT scan. You don't like to do it when there is a suspicion for perforation. Endoscopy is not done. So what do you do once it is, the score is determined? 0 means you can start the oral feeds and discharge the child. No follow-up is mandatory. However, grade 1 means oral feeds can be started, and discharge can be planned, and endoscopy follow-up may not be necessary for grade 1 either. However, grade 2A onwards, the follow-up is absolutely mandatory. The grade 2A oral feeding is can be done after antibiotics and PPI, but discharge once they make sure the child is not febrile and there is no respiratory distress and there is no further complications. And these patients will require a barium study done in 3 weeks to see is there any complications from the ingestion. 2B means is NPO, and in these patients, NG feeds can be planned. However, do not blindly pass NG tube. So NG tube is placed during the time of the endoscopy under vision, so that there is no risk of or less risk of perforation with the NG tube. So you do not like to do it blindly. Do not pass NG tube in corrosive ingestion patients. Grade 2B is the only the grade that is steroids has been tried. There they say there may be slightly decreased risk. One study showed, other studies have not shown any improvement or difference with the steroid group versus no steroid group. And these patients also will require follow-up study to find out is there any complications from the corrosive ingestion. 3A and 3B also NPO, and antibiotics and PPI is given, and barium study is also required for them. And but again, these NG tubes are placed under vision not blindly placed. Now, which antibiotic you use? Many times you use which has to cover for gram-positive, gram-negative, and possibly anaerobic cover, because oral flora has anaerobes also. So ceftriaxone is a good choice, or ampicillin with sulbactam is a good choice to use. So when there is mediastinitis or perforation or any of those things, you have supposed to definitely use the antibiotics. But otherwise, grade 1 and 2A, there is no need for antibiotics. And only in severe grades, grades of injury, you use 2B or 3, or when there's perforation, or if you have started giving any steroids, you must give antibiotics. And do not give any tablets or capsules. If any medications are given, give us syrup or suspension. How long? There is no consensus, but 3 to 4 weeks may be more appropriate, and do the follow-up barium study done, contrast study done, and to make sure there is no strictures. Then only plan to do unlimited, if there is no complications. Nutrition is extremely important. NPO before endoscopy, if there's drooling or suspicion of perforation. And grade 1A and 2A injury, liquid diet may be used after the endoscopy and confirmed there is no serious or severe injury, and liquid diet is given, and advanced liquid diet in a day or 2. Grade 2B on 3, NG feeds, but only with undervision. Oral feeds are allowed after the first 48 hours if the patient is able to swallow saliva. If there is no drooling and there is able to swallow saliva, then liquid diet can be tried after day 3 of life of the injury. If there is inability to swallow the saliva, and if the child is and NG-tube is not there, these patients may require total parenteral nutrition if oral feeds are delayed. And these patients can also would benefit if there's severe injury, a surgical jejunostomy, and if the NG-tube is not placed and oral cannot be achieved and TPN is not initiated. And that also can be used more useful in patients with the gastric outlet obstruction too, jejunostomy feeding. So placement, as I said earlier, grade 1 and 2A not required, 2B and 3 controversial, but if you use it, advantage is you can give some nutrition, but and also theoretically you may keep the lumen patent in animal studies have been shown that way. However, blind insertions are absolutely not advised because of the risk of the perforation. And once NG-tube is sitting there, of course, there is the increased risk of GERD and further damage from the from the NG-tube. So those patients giving a PPI would be appropriate. So steroids, as I said, only one study, but that is theoretically could help to inhibit the granulation tissue and decrease the risk of the fibroblastic tissue reaction and stricture formation, but it is not well proven, so it is not universally given. But when there is laryngeal symptoms, stridor, laryngeal edema, respiratory distress, those patients could benefit from steroid therapy for 2 or 3 days of steroid therapy. And even that one study done for the esophageal injury, only 2B, that was given very high dose of steroid, but for 3 days, but it is not sure how much it has benefited, but many of the other studies have not shown and did not replicate that particular benefit. So PPIs, when there's inflamed esophagus and stomach, and also lower sphincter is relaxed, and the PPI can be useful. High frequency of acid reflux into the esophagus causes further ulceration damage. So PPI is again beneficial for these patients. And adult series, they have given intravenous bolus injection followed by only in adults they have given for 3 days, but we don't know how much to give. And expert, so grade 2 and 3, the recommendation is to give for probably for 4 to 6 weeks, but not sure because there is no consensus for that. But if the NG-tube is placed, PPIs are given along with it. So stricture formation is one of the most common complications of the corrosive ingestion. And if there's a grade 2B, almost 30 to 70% can develop stricture. Grade 3A or above, more than 30% they can develop stricture. So there's a very high risk of stricture, the higher risk of injury into the esophagus. So if it has caused gastric injury, they can develop pyloric stenosis, gastric perforations, tracheoesophageal fistula formation. Actually, I think there is one patient that Dr. Geeta and I share that with a patient with a tracheoesophageal fistula formed a patient. Mediastinitis, peritonitis patients, pneumonia can develop, sepsis, malignancy, as I said, CA esophagus, almost 1,000 times they can develop CA esophagus in corrosive injury. And of course, they can develop death. So messages, nutrition plays a very important role in healing and recovery. So it's very important to attempt feeding, provided there is no severe injury to the esophagus. And if it is not tolerated in the saliva and drooling, and if there is drooling, start TPN. NG-tube under vision may be possible, and it can help with the nutrition. And start antibiotics and also PPI if it is indicated. And do not start steroids empirically. And only if there is endoscopy is done, one is willing to take that chance, you can try it, but otherwise steroids are not universally given. So endoscopy may not be necessary for a asymptomatic accidental ingestion patient. Asymptomatic and accidental ingestion patients, there is absolute no symptoms and and it's accidental, maybe 2-year-old or something. It maybe you can watch and see how it goes. But otherwise, if there is suicidal or deliberate, that patient has to get scope. And if it is accidental, if there is any symptoms, oral burns or pharyngeal burns, you have to do. Even absence of pharyngeal burns does not rule out esophageal burns. That is the reason I said those patients also, it will be better off to do the endoscopy and make sure there is no burn. So that way, if there is nothing there, they can rest assured they don't need to come back for follow-up. And if there is higher grade injury, they need to get barium study done. Endoscopy is necessary and useful in predicting the outcomes. Thank you. If you have any questions, I will definitely try to answer.
Thank you, sir, for the wonderful and very informative talk. About sir is worked in Amrita Institute as a pediatric gastroenterologist with a vast experience in India and United States. Any questions can be asked now.
We'll have a discussion on the session. The session is open for discussion if there are any queries.
Foreign body, chest X-ray and AP and lateral, and what about CT scan in foreign body? How is the CT scan?
Normally, yeah, am I audible?
Yes.
Yeah, normally radio opaque foreign bodies, mostly they are visible on the X-ray itself. But if you have any doubt and sometimes it may not be very clear, in that case, CT, and if there is any, for example, if there is an unexplained bleed or if there is severe esophageal injury after removal and you're suspecting an aortoenteric fistula like that, you can, an aortic injury, then you can take a CT. Sometimes, but you find that there is considerable injury underneath, and if you're even suspecting perforation, etc., removal, before that, assessing what the situation is, for that a CT thorax may be required. And otherwise, in evaluation, a CT may not be required. Would Banu sir have any views on?
Only other thing I add is, if there is a fishbone or something, you may do it because of sharp ends and something deep, the neck, because it's not seen in the X-ray well and everything. So CT may be for those kind of patients. But as Dr. Rama said, typical foreign bodies, radiopaque too, unless there is complications being or worried about it.
Okay, sir. Thank you very much. Thank you, Dr.
Thank you, Dr. Banu. Thank you, Dr. P.C. Hadda, sir. I invite Dr. Jebin Kamar to give the memento to Dr. P.C. Haridas. Would like to inform that the paper and poster presentation will be conducted in the same venue at 4:30 p.m. Next, we straight away move to the panel discussion, incidental findings.
Hello, am I audible, Dr. Rekha? Am I audible?
Yes.
Okay, thank you.
We'll introduce the panelist and the moderator. The moderator is Dr. Geeta and Madam, Senior Gastroenterologist from Aster Medcity, Cochin. Panelists are Dr. Jebin Kamar, Consultant Pediatric Gastroenterologist from Metra Hospital, Calicut. Dr. Ramya Arpai, Consultant Pediatric Gastroenterologist from Lisi Institute, Cochin. And Dr. Rega Hari, Consultant Associate Professor in Pediatric Gastroenterology, Amrita Institute, Cochin. We request all the panelists and the moderator to check the connection.
Good afternoon. Am I audible?
Yes, madam.
Yes,
madam.
Good afternoon.
Dr. Ramya?
Good afternoon, ma'am.
Audible. Rekha as...
Good afternoon. Good afternoon, madam.
Hello.
Hello. Hello. Can we start?
Yes, yes.
Okay. So this is the last session for the day, and I'm sure we're running out of time, so I'll try to make it as short as possible, but it's an important discussion topic for practicing pediatricians. These are conditions where we find something incident we are forced to deal with it. So we have an eminent panel of the pediatric gastroenterologists who will help me through this presentation today. So we'll start with the first case, a 10-year months of duration. Also has periumbilical pain, which is mild to moderately severe, associated with any of the alarm or red flag signs, fever, no weight. He has mild loss of quantified, and there's no other want when there is an abdominal pain for 3 to 4 months. Naturally, you have to do something, and pediatricians or even we would be forced to do an ultrasound. Sometimes the parent does ultrasound by themselves. And now the finding is mesenteric lymph nodes 15 into 7 millimeters, and now the patient has come to you regarding this, asking for clarity. So may I invite Dr. Jubin to discuss what is the significance of this node and how does this relate to the pain that the child has? Dr. Jubin?
So good evening. As pediatricians and practitioners, we have in most of the ultrasound findings, ultrasound reports will have a finding of a mesenteric lymph node symptom. So it is difficult to nowadays. It's very difficult to find an ultrasound report without an impression of mesenteric lymphadenitis. So what is the significance and which all lymph nodes has to be taken as significant? What are the common causes which we come across? So before going into that, I'll just give you a brief outline regarding what are these.
1 minute.
Okay.
Actually, we didn't call our chairperson. Just 1 minute. We have to call Balendra sir. Hello, Balendra sir. Yeah. Can you just start the session? 1 minute. Sorry, madam. Gida madam. 1 minute.
Can you hear?
Yeah.
Yes,
Here.
Yes.
Okay, you can start, sir.
No, it's already continue.
Okay,
Doctor,
actually, this one they didn't call.
no,
this.
no problem. Jubin, please continue.
Okay.
Bala can finish the session now.
So mesenteric lymph nodes actually drain the GID. What they drain is the drainage of the mesenteric arteries. That is usually mesenteric lymph nodes drain the GIT, that is starting from the duodenum to the colon. So any inflammation or any pathology anywhere in these areas can actually cause an enlargement of the mesenteric lymph nodes. So this is just what is its role? It acts as a firewall to prevent the live commensal bacteria from being identified by the systemic immune system, and it is normally present in children, but usually the size of a normal lymph node is less than 5 millimeter. And a normal appearing lymph node will be usually oval and hypoechoic or isoechoic on ultrasound. And in every child, there will be an increase in the size till 8 to 10 years of age and then regress. And if it is more than 20 years, usually it will not be a finding in most of the ultrasound more than 20 years.
It's a frequent interruptions.
I think Jubin's voice is not is breaking.
So is it okay now?
Video.
Is it okay now, sir? Geeta ma'am?
Prashant sir is okay now? Can we continue?
Good evening. Is it audible? Madam, is it audible now? Geeta ma'am? Prashant sir? It is not. They are not responding. Geeta ma'am?
Yeah.
Am I audible
Yes, I
now?
can.
Is it clear?
Yeah, now you're clear.
Okay.
Yeah, now you're clear. Thank you. So go ahead.
So, I was just telling about the mesenteric lymph nodes and it's draining the GIT. So normally it is present in all children and its normal size, if it is not due to any pathology, it will be less than 5 millimeter in the short axis. So what is the short axis means? Short axis means it is taken that if you take an ultrasound in the lymph node, the longest diameter of the ultrasound and the perpendicular, the axis which is perpendicular to the longest diameter of the ultrasound lymph node is taken as a short axis. And if the short axis diameter is usually less than 5 millimeter in the case of a normal lymph node, that is a normal mesenteric lymph node. And usually it increases in size till 8 to 10 years of age and then regress. Next slide, please. So, if it is a mesenteric lymph node finding, it could be a normal, non-significant mesenteric lymph node. It could be due to a primary mesenteric lymphadenitis. And if there are some other organic pathology, then it could be a secondary lymphadenitis. And these pathologies could be an infective, inflammatory, or a malignant cause. Now, this is a very old, very age-old radiological criteria for the radiologist to report it as a mesenteric lymphadenitis. That is, if there is a cluster of enlarged 3 or more hypoechoic lymph nodes with a minimum short axis of more than 5 millimeter, among at least one of them should be more than 8 millimeter. And these lymph nodes are usually located along the right lower quadrant or sometimes in the para-aortic region. And if there are no other identified cause of inflammation, then it could be a primary mesenteric lymphadenitis. A normal ultrasound, normal lymph node in an ultrasound, the shape will be oval. If it is a round lymph node, then beware, you are dealing with some other pathology and not a simple mesenteric lymphadenitis. And as I've already told you, the long axis, you can see that the marked axis is actually the short axis. The long axis will be normally more than the short axis. And the ratio of long axis and short axis is also important. That is, if the short axis increases in size, then the ratio becomes less. That is, a ratio of long axis to short axis less than 2 means it doesn't become normal. Lymph node is oval shaped. When the short axis increases in diameter, it becomes a round shape. A round shaped lymph node is usually, it is not a benign lymph node. It could be malignant or it could be due to some other causes.
Jubin?
Yes, ma'am. Not audible?
And now you're back.
Yes. Madam, next slide. Okay. So, usually enlarged mesenteric lymph nodes can be seen in 64% of the children, and as I've already told you, it peaks in the first decade, that is 8 to 10 years of age. And the most common ones which we see are the primary lymphadenitis, where there are no underlying identifiable cause. And most of the ultrasound sonologists report an associated finding of mild thickening of the terminal ileum wall and cecum in a minority of cases. This can actually be a finding in a primary mesenteric lymphadenitis, and a finding of a terminal ileum thickening, a mild thickening, doesn't always say that it is pathological, because in primary mesenteric lymphadenitis, it can actually present like this. So I'll just brief you what is happening in a mesenteric lymphadenitis or a primary mesenteric lymphadenitis is that the patient will be having a viral upper respiratory or a GI infection. So the virus or the bacteria, whatever, usually it is a virus, it invades the mucosa or the epithelium, it enters a bloodstream, it spreads to all the parts of the body, then it reaches the intestinal mucosa, it pierces the intestinal mucosa, reaches a Peyer's patches, from the Peyer's patches it goes into the lymphatics, and finally it locates in the mesenteric lymph nodes. And that is what happens in a primary mesenteric lymphadenitis. So these children will typically come to you with a history of a short, maybe a 2 to 3 months history. They'll be having an abdominal pain, a vague abdominal pain. There'll be it may be temporal to such a very insignificant viral infection. And sometimes these mothers will say that, okay, he was okay, and then maybe after a play or after sports, that the pain increases. So it is said that usually it causes this is a typical history when you get in a primary mesenteric lymphadenitis, which you can leave alone. You needn't treat it with an antibiotic or any other inflammatory agent. So coming into the different causes, It could be an acute cause or a chronic cause. Now, what I have said previously was about the primary mesenteric lymphadenitis, which doesn't require any specific treatment. So coming into a very large group of a secondary mesenteric lymphadenitis, it could be due to acute cause. A mesenteric lymphadenitis, the close differential diagnosis is appendicitis, because both of them presents with a right iliac fossa pain. When you examine the child will be having a mild right iliac fossa tenderness. In appendicitis, the tenderness will be very severe, and the child may not tolerate. But in mesenteric lymphadenitis, you can actually, even though there is tenderness, you can actually deeply palpate the abdomen. Now, in rebound tenderness will be present both in appendicitis and mesenteric lymphadenitis, because here in mesenteric lymphadenitis also the mesentery is inflamed. So a rebound tenderness will be present in both, but it will be more in an appendicitis. Now, other causes of secondary mesenteric lymphadenitis of infectious origin are, again, the most common ones we see are the enteric fever, the non-typhoid salmonellosis, then the infectious IMN. IMN actually can cause a mesenteric lymph node also, along with the cervical lymphadenopathy, and rarely the other parasitic infections. Now, coming to the chronic causes, the chronic causes are usually the inflammatory bowel diseases, then the systemic chronic inflammatory diseases like SLE, sarcoidosis, malignancies, tuberculosis, and HIV infection. So most of us, I think all the pediatric gastroenterologists do not usually diagnose. I know that maybe none of them might have diagnosed any of these chronic cases just by seeing a mesenteric lymph node size of any 15 into 8 millimeter or whatever the ultrasound or the sonologists say. So this, next slide, please, ma'am.
Yeah. So some of what Dr. Jubin had said was that mesenteric lymphadenitis, when they are secondary in nature, they usually are not just they're usually precipitated with some infection or inflammation. They have other features in addition to the lymph nodes. But the ones which we are dealing with here is the one which is totally asymptomatic. Child has not had any preceding illness in the recent past, has not got any other symptoms except for an ultrasound which shows us mesenteric lymph nodes and probably a vague abdominal pain. And those are the ones that can be labeled as primary mesenteric lymphadenitis, which need not be treated aggressively. But however, when the parent comes with this finding, how do we manage? How do we really approach this case? Because now the parent has associated the abdominal pain with the node, even though we may say it's benign, does not require treatment. We need to treat with something. So do we have to give them antibiotics?
Yeah, that I have already told you that is usually these cases of primary mesenteric lymphadenitis are mostly viral. But they will have, the patient will be really symptomatic. The child will be having severe pain, especially it will be an intermittent colicky pain in the right iliac fossa without fever. And as I have told you, it can mimic appendicitis. But mind you, you can do a hemogram, that is you can do a CBC, an ESR and CRP, and usually it might show a mild amount of leukocytosis with a slightly elevated CRP. If it is the chronic mesenteric lymphadenitis, they can actually show significant variation in the CBC, the ESR and the CRP. It will be seen in primary mesenteric lymphadenitis, but to a very low extent. Mando is not required, and no empirical treatment with ATT. I know most of them will not do that. Most of our pediatricians do not give an empiric ATT for just a mesenteric lymph nodes. So how to manage these children? The most important thing is rule out surgical causes. And mind you, this is a self-limiting cause of a pain, and it will usually subside within 2 to 4 weeks, and in a very rare situations, it might extend for maybe 3 months or so. Hydrate the child, reassure the parents, then you can give a paracetamol or NSAID, but better not to give a cyclopam or any other anti-spasmodic medications. Antibiotics are generally not required, and just reassure the parents, ask them to not to send the child for much of a play, taking good amount of fluids, rest and reassurance is all that is enough to manage a case of a primary mesenteric lymphadenitis.
So, Dr. Jubin, how do we know that it is primary or secondary? Sometimes this previous illness may be like a chronic illness. For example, if you say inflammatory bowel disease or tuberculosis, or sometimes even case of lymphoma, the early features may be very mild, no specific fevers. So how do we know that this patient needs to be evaluated further or not? Or is there any need for follow-up of these ultrasound findings? Because we've seen this patient only at one point. And that 1 point says the node is benign or probably not very serious. But do we have any evidence that this can progress to some illness later, or say 6 months down the line, the patient comes saying that there's some illness when we missed it? That is our fear as pediatricians or as doctors, that we miss something. So do we need to really evaluate this further?
See, in a case of a primary mesenteric lymphitis, as I've already told you, the natural history is actually, it just takes maybe 2 to 3 months to resolve. And a follow-up is required if the short axis diameter is more than 10 millimeter, without alarm features. It is actually, we should decide on management by taking on to the history of the child, the other findings, the examination findings, all the other blood reports, and only the ultrasound abdomen should be taken as a last inclusion in the when you are planning your management. So it is not an isolated mesenteric lymphadenopathy which has to be taken into consideration. You have to assess the various other associated findings and the maybe associated findings in the ultrasound abdomen also before embarking on a treatment. So what is abnormal? It is a characteristics of the lymph nodes, the number. If the lymph nodes are present just in the mesenteric or the para-aortic area, it could be due to a mesenteric lymphadenitis. But if you are seeing lymph nodes not only in the below the mesentery, that is in the drainage of the SMA, but it is usually, if it is seen in the peri-pancreatic region, peri-hilar region, or mediastinal lymph nodes, then you are not dealing with a simple case of a mesenteric lymphadenitis. The site, again, that is what I had said. The shape, if it is an oval to and if it is an hypoechoic or isoechoic in ultrasound, it could be a benign. But if it is a round shape, multiple round, then it could be something not a benign which we are dealing with. Echo texture, again, and a hyperechoic mean it is full of cells. So in ultrasound it will appear as hyperechoic. And then that could also be a case of a lymphoma. Caseation, as you all know, caseated, conglomerated, necrotic lymph node could be a finding of a tuberculosis. Now, not only the lymph nodes, but also the adjacent structures, that is the bubble loops. Bubble loops, as previously I had told you that in mesenteric lymphadenitis, there could be a mild thickening of a terminal ileum. It is said that previous literature has shown that, pediatric radiology literature has shown that a less than 5 millimeter thickening, the specific measurement could be only told in a CT, but a less than 5 millimeter thickening in an ultrasound or a CT is not that significant, and it could be part of just a simple inflammation due to a mesenteric lymphadenitis. Now, findings in other associated hyperechoic mesentery, omental nodes, a free fluid in peritoneum, in the peritoneal cavity, or encasement of vessels. Maybe you are not dealing with a simple case, you're dealing with a complicated, maybe a tuberculosis or a lymphoma. And presence of ascites, any amount of ascites, any amount of free fluid in the abdomen should be, you should, again, it is an indication to evaluate further. It could not be a simple case. And presence of other constitutional signs or symptoms like fever, weight loss, abdominal, chronic abdominal pain, and other edema, ascites, all these could be pointing towards some other chronic pathology which should not be missed while managing such a case.
So thank you, Dr. Jupin, because this is an important slide. This says, as sums up the whole approach to the mesenteric lymph nodes, where it says that if there's any change in the shape, size of, or the appearance of the nodes, or there is conglomerate nodes or multiple nodes, do not take it lightly. It is not mesenteric lymphadenopathy. The incidental finding of few nodes in the right iliac fossa, which are benign appearing as enumerated by Dr. Jubin, is the one which can be left alone. And what are the long-term complications for these patients? Do they actually persist, or do they get better? How is it?
If it is a primary mesenteric lymphadenitis, usually the long term, I told you, it will disappear within maybe a period of 2 to 3 months, and it is generally good.
So they generally do not need to have any follow-up, but they can be left alone. Most of the pains usually disappear by 2 to 3 months, as Dr. Jubin said. So the take-home message is primary lymphadenitis or mesenteric lymphadenopathy is a common finding, and it's an incidental finding which need not be given much credence. 2 things which you need to remember is look out for the actual report and read the reports, make sure you're not missing anything in the lymph node appearance or in the general constitutional symptoms. Second thing, you can have a follow-up of these nodes to see that they are decreasing in size, and thereby you will not miss any of these patients. So thank you, Dr. Jubin, for your inputs. Now we'll go on to the next case, a 4-year-old child with history of respiratory infection. Ultrasound was done because child had chronic pain during that time and the parents wanted it done. There was no real indication for the ultrasound except that the parents thought that an ultrasound should be done. But however, at the end of the ultrasound, it showed multiple gallstones measuring 3 to 4 millimeters.
Give a short brief on the etiology of the different cholelithiasis in children, the clinical features or the symptomatology of cholelithiasis, and the complications that you need to expect when you manage a child with cholelithiasis. So coming to the etiology, you can see that different from adults, we have a different set of etiology for cholelithiasis in children. For example, in infants, one of the most common causes that can predispose to cholelithiasis is sepsis. Now, prematurity, along with prolonged periods of NPO and total parenteral nutrition, can again predispose to cholelithiasis. One common genetic factor like PFIC3 can have cholelithiasis. Then genetic conditions like Gilbert syndrome, cystic fibrosis, then mutations associated with ABCB4, they can also present with cholelithiasis. Now, short bowel, we all know that the enterohepatic circulation takes place in the distal ileum. So when there is conditions which have caused terminal ileal resection or Crohn's disease that causes terminal ileal dysfunction, such children can also develop cholelithiasis. Then gallbladder stones are also seen in children post cardiac surgery and post heart transplant. Some of the common drugs that is associated with cholelithiasis are diuretics like furosemide, cephalosporins, especially ceftriaxone. Chronic octreotide therapy can also cause cholelithiasis. Then some of the most common immunosuppressants that we use, like cyclosporin and tacrolimus, they can also predispose to cholelithiasis. Now, coming to the older child, other than idiopathic factors, cholelithiasis can also occur secondary to hemolytic conditions. And you can see in adults, it's most commonly obesity. After menarche, the incidence of cholelithiasis can increase. Then pregnancy and oral contraceptives can also lead to formation of gallbladder stones. So there are three types of stones mainly: cholesterol stones, black pigment stones, and brown pigment stones. So cholesterol stones are typically radiolucent, and it is usually seen in association with obesity, high intake of dietary cholesterol, and you can see that it can be also seen in metabolic syndrome associated with insulin resistance. Cystic fibrosis and drugs like octreotide can also cause cholesterol stones. They are the most common and they're typically radiolucent. Now next comes black pigment stones. There is a small correction. This is 50 to 75%. So most of the black pigment stones are radio opaque. They originate in the gallbladder, and it is mainly due to hemolytic conditions. Black pigment stones means you have to rule out hemolytic diseases like sickle cell anemia and hereditary spherocytosis. Conditions like thalassemia can also cause black pigment stones. Wilson's disease can cause black pigment stones. Now, children with heart valves, what happens is that there will be mechanical shearing of the erythrocytes that leads to hemolysis and formation of black pigment stones. Now, the next is brown pigment stones, which is associated with infection. So, how is it different from the other two is that these brown pigment stones typically originate in the common bile duct and they are usually radiolucent. So they are associated with bacterial infections like E. coli, staphylococcal infections, Enterobacter, Salmonella. And you also have to rule out parasitic infections like the liver fluke and Ascariasis, roundworm infection. Next slide. So if I take a history of this child, I would like to know whether he has symptoms. If he has symptoms, is it pertaining to the stone per se, or is it non-specific, like maybe another abdominal pain? So typically, the symptoms of a gallstone are biliary colic. Biliary colic is characterized by right upper quadrant pain, and even though you use the term colic, it can be a constant pain also. And in adults, it is usually precipitated by a fatty meal. This correlation is not that commonly seen in children. They can also present with acute abdomen-like conditions like fever, tachycardia, hypotension, and jaundice. So when these conditions occur, you always have to rule out a cholecystitis, pancreatitis, cholangitis, or even sepsis. Also look for the Murphy sign, where there is tenderness of the right upper quadrant due to the inflamed gallbladder.
and that is very characteristic of cholecystitis. The Charcot's triad is for the postgraduate students. It is characterized by fever with right upper quadrant pain and jaundice, and is very characteristic of cholangitis. Next slide, ma'am. So, like unlike how in an older child you have abdominal pain, and infants you should always alert the mother to look for pale stools, irritability, any signs of abdominal pain, sepsis or cholestasis. So that is how infants will present when they have a cholelithiasis. Then when taking the history and examination, always look for obesity, family history of gallstones to rule out genetic factors, and also take a diet recall, because studies have found that increased fat intake with highly refined sugars like fructose and a low fiber diet predisposes to the development of gallstones. Next slide. So what all investigations I will do? I will do all the routine CBC. Hemoglobin low means it can be hemolytic anemia. Counts are high with neutrophilic predominance, can be an infection like cholecystitis or cholangitis. CRP high means again in favor of an infection. LFT with GGT, gamma glutamyl transferase, should be done to rule out any obstruction. PT-INR should always be done to rule out, to assess the level of hepatic dysfunction, if at all it is present there. Lipase and amylase is usually done when we suspect a pancreatitis, like when the child presents like an acute abdomen with fever, vomiting, and severe abdominal pain. Lipid profile is done to rule out hypercholesterolemia and hypertriglyceridemia. Now, celiac disease. So in celiac disease, what happens is there is some proximal enteropathy. So this cholecystokinin is less. So again, the contraction of the gallbladder is less. So there is biliary stasis predisposing to gallstones. And when you do the test, you do a TTG IgA always with a total IgA. An elevated TTG IgA in the setting of a normal IgA is in favor of a celiac disease. Rule out hemolysis by doing retic count and a peripheral smear. Sweat chloride can be done, or even genetic tests can be done to rule out cystic fibrosis. So regarding the genetic studies, these are some of the common mutations that we look for: ABCB4 or the MDR3 protein, CFTR, PFIC3, and Gilbert syndrome. Next slide. So the investigation of choice is USG abdomen. That slide has been not been included because USG we have already done. So in USG you assess the stones. You can also rule out cholecystitis. You look for the common bile duct, the common hepatic duct, intrahepatic biliary radicals, also the pancreas. Now, suppose you are not able to, like whether cholecystitis is present or not, it is equivocal, then you can do HIDA, but we routinely do not do HIDA in all cases of gallbladder stones, especially if the child is asymptomatic. So the uptake of the dye by the gallbladder will be absent. Since HIDA has a sensitivity of 97% and specificity of 94% in diagnosing an acute cholecystitis. Next slide. So CT, MRCP, EUS are routinely not done in a child coming with especially an asymptomatic gallstone. But yes, we do all these if we suspect a choledocholithiasis, or in USD if we find that the CBD is dilated, or you want to assess the pancreatic morphology. In all these cases, we go for advanced imaging techniques. EUS, yes, is helpful in diagnosing distal CBD stones. Next slide, ma'am.
Yeah, so before we go on to the next question, I just like to summarize what Dr. Rekha has said. In an incidentally identified gallstones with no other symptoms, you need not go to all these investigations. You can do the basic investigations. Like Dr. Rekha has said that most of these stones are not cholesterol stones, they're usually brown pigment stones, probably due to secondary to an infection that has happened earlier on, but sometimes they can be due to hemolysis. So your primary job at this point would be to identify if is there a hemolytic anemia underlying, and your investigations can be tailored to that. But like Dr. Rekha mentioned, if there are complications or previous history of complications, previous history of jaundice, then your investigation would have to take a more aggressive turn, and you may have to in detail find out what is the need for what is the cause for these stones. But in a general case, when you have a child who is totally asymptomatic with, like I said, an ultrasound showing an incidental gallstones, is there any need to tell these children that they have to avoid fatty diet?
Actually, as I told earlier, studies have shown that a high fat, high calorie refined sugars and low fiber diet predisposes to gallbladder stones. But the other way around, whether dietary restriction leads or helps in dissolution of stones, the studies are lacking in the pediatric age group. Regarding pediatric cholelithiasis, we don't have enough studies to validate that such dietary, like giving a high fiber diet or a low protein diet, low fat diet, or a low calorie diet would help in dissolution of the stones. But generally, when they come, if the parents ask for a instruction on their diet, we tell them to avoid all processed packaged food, all these packaged fruit juices. Then we ask them to include more of vegetables and fruits in their diet, and we definitely we tell them, okay, you can avoid all oily and fatty food. So this we avoid, we ask them, but definitely there are no guidelines to prove that this has a in dissolution of stones.
There's no evidence to prove that this may, to even cause or even improve the outcome in patients. And for children, it's very difficult to restrict them from diet for so long. But if there is a biliary colic or there is symptomatic gallstones, and that symptom is worsened by taking fatty diet, definitely would have to go for diet restrictions. So what are the long-term complications of these conditions, Dr. Rekha, in case we leave it alone?
So suppose we leave it alone, we have to keep in mind that we should be prepared for the complications and we should alert the parents that such and such things can happen. So suppose all these complications are usually due to the stone migrating downward, distally into the cystic duct or the CBD. So if it is in the gallbladder, means it will remain there, it is most likely to be asymptomatic. Suppose it migrates down to the cystic duct, it can cause a biliary colic, it can cause obstruction and lead to infection causing cholecystitis. Lower down, it can erode into this, wherever the stone gets lodged, it can elicit an inflammatory reaction, and thus it can erode onto the adjacent hepatic duct and it can lead to a hepatic fistula. So that is Mirzi syndrome, which is very, very, very rare. And I have searched the literature. It usually happens maybe around the mean year of 29 years after, that is the GB stone persists for 29 years, then only this can happen. That is the age years gap. Migrates lower down into the distal common cause cholangitis as well as pancreatitis due to obstruction. So these are the most common complications, but on a long term, in adulthood, it can very rarely lead to cholangiocarcinoma. So these are the complications that you usually expect in a
So in your slide, you have mentioned that asymptomatic, the stone can be asymptomatic in 75% of the patients. As you know, a large number of patients, they do come with ultrasound finding of these stones. So how do we decide in which patient to be sent for surgery? And if so, when? Or do you decide that all patients should go? Is there any criteria to help this?
Yes. So actually in pediatric, regarding pediatric cholelithiasis, there are not much studies which, or we don't have a definite consensus as to how to manage a pediatric cholelithiasis. But this came in Indian Pediatrics. I think this study came from STPGI Lucknow. And I found this useful. So here we can start from the lowermost point. So if you take an older child with a symptomatic gallstone or an older child with a gallstone due to a hemolytic disease, then itself you can refer the child for cholecystectomy to a pediatrician. So suppose the child is asymptomatic, you can keep the child under follow-up. But this is a bit risky because two things you have to keep in mind. One, when you follow up, studies have shown that an asymptomatic stone which is being kept under follow-up, the chances of developing a complication increases by 1 to 2% every year. And suppose the gallstones resolve also, there in 20 to 30% of children, they have been found to have recurrence of stones in adulthood. So all these, and then the complications should also be kept in mind when you opt to observe a child. So the patient should be kept under regular follow-up. And if you are giving this dissolution therapy like ursodeoxycholic acid also, you should keep in mind that UDCA should be continued for at least 3 months, even after dissolution of the stone. And even after that, you will have to keep them in the loop, maybe 1 year, 2 year, or 3 year follow-up. So that is regarding an older child. Now, suppose an infant comes to you with a gallstone and the infant baby is asymptomatic. Suppose a gallbladder stone is calcified, immediately refer to the pediatric surgeon for cholecystectomy. In non-calcified asymptomatic stones, you can wait up to 12 months. You can observe the follow-up, explain the complication and its symptoms, and keep them on regular follow-up for maybe 1 year. And still, if the stones are persisting or at any time it becomes symptomatic or complications develop, you can refer them for cholecystectomy. Suppose an infant is symptomatic, just wait for 1 or 2 weeks and just refer to the pediatric surgeon. So rather than removing the stone, more risky is keeping the child under of symptomatic. And how long?
Okay.
Yeah.
Yeah, continue, please.
So how long to keep the child under follow-up is a question, because they say the chance of recurrence in adulthood or maybe after 15 years, there have been studies that 20 to 30% of them have recurred. So we should be keeping them under follow-up.
But I think the evolving information on this, and with the availability of surgical expertise everywhere, I think many parents are also opting to do the follow-up staging. Also, even pediatric surgeons, at least in our setup, in our hospital, they do not prefer to do cholecystectomy for an asymptomatic stone, with the only caveat being because the risks of surgical or the complications of surgery itself is going to be higher than the risk of leaving it around. So like Dr. Rekha said, at least a 12-month observation is what they prefer. And if the 12-month the patient has had any particular symptom, like any pancreatitis or any cholangitis or colic, then it's easy to convince the parents of a surgery. The problem is you subject the patient to a surgery, and if there's any complication post-surgery, it becomes unacceptable because it's being done as a prophylactic case. So in children, younger children, like you've said, we'll usually follow them for 1 or 2 years. And if there is any complication, we would rather, it will be easy to convince them for surgery. About the incidence of malignancies and when it's whether it occurs or not, in so far studies in children have not identified this high risk of malignancies. So I think now there's a rethink on whether cholecystectomy should be done for all patients, and therefore some stones can actually be followed up for a year or two, maybe even I think they are extending this 12 months of up to 2 to 3 years, or till the next symptom occurs, and then we can decide about cholecystectomy. Upfront cholecystectomy for finding stones is now actually undergoing a sea change even among the pediatric surgeons, because they feel that the risk of doing surgery is actually higher than leaving it alone. So, but this is only for asymptomatic patients, and it's not for patients with hemolytic disease or symptomatic gallstones or any patient who has had any complication like pancreatitis. Those definitely have to go in for cholecystectomy. So thank you, Dr. Rekha, and I will go on to the next case. A 14-year-old boy weighing 110 kg went for a routine checkup because of his overweight. Parents wanted to check whether everything was all right with him. And as usual, they went for self-checkup, during which time they will do a lipid profile. And his cholesterol was found to be 276. They've done his sugar testing also, but that's HbA1c was normal. His BP was found to be on the borderline higher side, and thyroid function test was normal. They also got an ultrasound done, which showed grade 2 fatty liver. Now he's been referred to the pediatric gastroenterologist. So Dr. Ramya, what would your general approach be?
Good evening, ma'am. This is a common scenario that we're facing these days, because obesity is definitely on the higher side. As we all see, obesity is becoming an epidemic these days. I think after the COVID times, children are having a very less physical activity and more of junk food eating habits. And with the upsurge of obesity, the upsurge of fatty liver has also increased. Earlier, it used to be in the developed countries. Now we are seeing it in the developing countries like us. So with that, as a fatty liver is increasing here, we'll just run through how we would approach a child with fatty liver, not the case what we discuss in general. This is any child who's obese or overweight, that is based on the BMI, more than 9 years. We would first look for the ALT because it's affecting the liver. And if the ALT is more than 2, based on the sex-specific upper limit we are taking for boys as 26 and girls as 22, not on the lab base for each hospital. If the child does not have any symptoms, we would observe the child for lifestyle modifications for 3 to 6 months. And we would ask the child to repeat the ALTs. If there is improvement, we would continue the lifestyle modifications. If the ALT is not improving, and if the child is having any clinical symptoms, or in the initial stage itself, if the child is having an ALT which is elevated more than twice the upper limit, we would need to evaluate the child for other causes of liver diseases. And this is a point we would have to refer the child to a pediatric gastroenterologist. So all fatty livers, we have to monitor them. We cannot just leave the child saying that it's just a fatty liver, it will go off. So it has to be monitored. We have to look for other causes of fatty liver which will be coming to downwards. So that is a normal approach. And in the child which we have mentioned earlier, this is a child who's having hypertension. It's on the, anyway, we have not got the exact height. So he has got hypertension, at least by the look of it. His cholesterols are on the higher side. Though his HbA1c is 5.5, it is definitely borderline. So he definitely needs to be evaluated by the pediatric endocrinologist. So that would be the general approach in managing a child with obesity and a great in a fatty liver child.
So the point here is all children who are obese, about 20 to 30% can have fatty liver, but don't take it very lightly. There could be other causes also. So when patients, when they have become overweight, or children when they become overweight, parents are not upset or worried. But the moment an ultrasound shows a fatty liver, they're really worried and they come to the doctor asking for help. So what is this implication of fatty liver in this age group, that is in a child? How serious is it? And just like how they talk about in adults, because now it's the propaganda is such that if you have fatty liver, you're to go for cirrhosis, and liver transplantation is the next stage. So is that the same case in children? Because that's what parents are asking. And will it lead to cirrhosis of liver? And when is the time for us to look for an endocrinologist?
The child in question here is a 14-year-old child and he's weighing 110 kilos. So at what point did the parents think that it's an issue? So that is where the main issue is. The parents, the concept of obesity in children itself is not there. And the concept of only when the issue of a fatty liver or when a health issue occurs, that's when they start getting bothered. So we need to educate them as to the issues of fatty liver is. So fatty liver, otherwise now we call it as non-alcoholic fatty liver disease. It's actually lobular inflammation and hepatocellular injury. The next stage would be NAFLD or NASH with fibrosis. And finally, it is NASH with cirrhosis.
So this is one of the occurrence of fatty liver, and the ultimate involvement of cirrhosis is actually quite long. It can take 10 years. But if it's left untreated or unaddressed, without any lifestyle changes, the progression after the stage 2 or stage 3 can be quite rapid. So we don't know, because we're finding fatty liver in younger and younger children. So we don't know how long it will take for them to become fibrosis. Like Ramya mentioned, there is a significant amount of these patients. So the progression to cirrhosis will not be much delayed. And as you can hear, even 35-year-old adults are finding themselves with cirrhosis. So this could be why that is happening. So that needs to be taken with into consideration. And the next thing is, when in children, in a child with fatty liver, will you suspect a metabolic disorder? Because as you know, many of the metabolic conditions also present as fatty livers. Just because child is obese, we cannot automatically assume that it's due to NAFLD. When will you suspect that there is a metabolic condition?
So fatty liver, we could have differential diagnosis. So one is metabolic causes, there could be some medications, dietary causes, and infections. When we talk about genetic or metabolic causes, and most common is a fatty liver, that is non-alcoholic fatty liver disease. Other could be fatty acid oxidation mitochondrial disorders, citrin deficiencies, Wilson disease, uncontrolled diabetes mellitus in them, lipodystrophies, lysosomal acid lipase deficiency, familial causes, and A-beta lipoproteinemia. Medications, especially corticosteroids, methotrexate, antipsychotics, and antidepressant, especially in adolescent age group. Dietary, especially kwashiorkor, alcohol abuse, especially we should be considering them in these adolescent age groups. Another thing is infections like hepatitis C. But the concern is, when will we suspect a metabolic disorders, especially if a child, especially a younger child, less than 3-year-old or a 5-year-old child who's not that obese, and he comes with an ultrasound finding a fatty liver, we need to think of whether this child is having a metabolic cause. If the child is having abnormal growth, if he's very thin built, or there is short stature, if there are some syndromic appearances in this child, or if the ALT and AST is elevated much more than expected, those are the conditions we should think about. If there is a family history, if the parents have had some history of fatty liver, or there is some history of liver disease in the family, some death in the family because of liver disorders, these are the considerations. So these are the elements when we would think that this child is having a fatty liver, which is not probably because of obesity, and other conditions will have to be evaluated as well.
Thank you, Dr. Rame, for that. Child who's obese, first thing we'll think of is a fatty liver disease, but a child who's lean and has a fatty liver, think of metabolic conditions. And like Dr. Rame said, the younger the child, be aware that there could be metabolic conditions which could mimic as fatty liver. But for this child, this 14-year-old obese, overweight child, what would you suggest as the treatment?
Main thing we need to address is there is no short-term or short treatment for fatty liver. We have certain goals. Basically, it's the regression of we have to stop the progression of NAFLD from steatosis, inflammation, fibrosis, resolution of NASH, and decrease the excess adiposity. So if, the main treatment is lifestyle modification. It is a main treatment. In adults, there are some drugs, but in pediatric age group, we do not have any drugs. And last option is pediatric surgery. Lifestyle modification, it has to be multitude of things. It's not just diet. It has to be diet along with physical exercises as well. When we talk about diet, we cannot tell them that, okay, go on a diet. We have to sit with them and explain to them what they have to take, take a detailed diet history of the child, understand what the child is taking on a regular basis, describe to them what they have to take, especially on the avoidance of sugar sweetened beverages, on a well-balanced diet, and importance of exercises. We cannot just tell them run for 2 minutes, or at least 1 hour of physical exercise has to be taken and had to be age appropriate for the child, and reduce the screen time.
So this is the most difficult part of the treatment thing, that you don't have any specific medication to give or any magic medication to give, but lifestyle changes has known, along with exercise, has known to actually produce wonderful results in these children. If they lose about 10% of their body weight, their fatty liver can actually be reversed. So that needs to be emphasized, even though it's a very tough way of treatment, because the compliance can be very poor. So it's very difficult for a pediatrician or even for us to sit down and tell that change your lifestyle and do improvement this. But what are the practical tips? How do you manage in your office practice?
The most important, I think, is to build a rapport with them. Most of them are adolescent age group. So unless they are convinced, the parents as well as the child are convinced that yes, it is an issue that needs to be addressed, they are not going to follow whatever you tell them. So I think building a rapport with them, explaining to them that it is a problem and it can progress to cirrhosis and even liver transplant in the future if this is going to continue. So that is the most important thing. And once they are convinced, talking to them about the lifestyle changes, yes. And once they are on the go and they are ready to go ahead with the treatment, we need to progress their we need to progress their disease and the treatment at least annually. And if the child is obese and overweight, we need to see if the more obese the child is, we need to have more frequent follow-ups in the office so that we can manage their weight better. And if the child is an adolescent age group, we need to tell them that they have to restrain from taking alcohol, restrain from taking smoking, because they're growing up. Another thing that we can do is vaccinate them against hepatitis A and B. And another thing, most important, is there could be a lot of name calling and body shaming. So there could be a lot of psychological aspects to these children as well as the parents. So maybe we could address them. And if it is beyond our scope, refer them to a psychologist, a child psychologist, where they might be more comfortable with.
So it's a team effort. Both the child, the family, the doctor, and the psychologist or the dietitian will have to actually work together to help this family. So what is the advice that you give to the child and the family in general?
Basically, stressing on lifestyle changes. Basically, we sit with them and talk to them about the child. So basically, the child asks you, what can I have? What can I not have? There might be certain things that they really like. So telling them what are the alternate options. So they might ask you, how can I make this? So maybe telling them that they could go ahead with an air fryer. So, making practical options for them, and what exercise they like, whether they like dancing or whether they like karate. Then they ask you whether they can go to the gym, adolescent boys. So talking to them it is basically personalizing each child's journey and keeping them under follow-up and motivating them. That is what I would advise each family and child.
So thank you, Dr. Ramya, for that inputs regarding to face today. So with this, we come to the end of this discussion. If there are any questions from the crowd, I think the panelists will be happy to take them.
Any questions? Okay, Dr. Bala, National EB member, who's chairing.
Thank you.
To conclude.
Yeah, thank you, Dr. Naushid and Dr. Prashant, for inviting me to chair this session. As a general practitioner, I would say that pediatric gastroenterology is one topic which the general practitioners should be very much aware, because the patients, they will go to pediatric cardiologist, pediatric neurologist, or pediatric pulmonologist without our permission. They will go. They know that, but the cases in pediatric gastroenterology depends on the general practitioner, and the general practitioner should be very much aware about these three common topics. I was very much happy that I could attend all the three this topic, like mesenteric lymphadenitis, the gallstones, and the obese child. These three are the very common conditions we come across in our day-to-day practice, and we general practitioners should be aware when to refer to a pediatric gastroenterologist. And today, ma'am, Gita ma'am, and all the three experts, Dr. Remya, Dr. Rega, and Dr. Jivin, has given a very enlightening talk on what are the causes, when to investigate, when to refer, and what advice we can give to the patients. Thank you, ma'am, and all three experts. Over to Dr.
Thank you,
Prasad.
Bala. Thank you, everyone, for your active, valuable insights and discussions, and an academic delight today. Thank you, everyone. Meeting is adjourned for post, and we are having a poster and paper presentation after this. Thank you, everyone.
Thank you, everyone.
Thank you, Geeta madam. Thank you. Thank you.
Dr. Prashant, it was a wonderful conference.
Thank you, sir. Thank you very much, sir. Thank you for your active participation. Yes, we are all here for them. We have.
Thank you, sir. Thank you for coming. Thank you, all faculties, for coming and enjoying the hybrid of Vadagara. Thank you, madam. Thank you
with all of you.
Yeah, thank you, Geeta madam. Thank you, Rami madam. Hari, Rega Hari madam. All. And we have to want to start the paper and poster presentation. There's another link. I think judges are Geeta madam, and we will wind up this session and we'll start another link. If anyone want that link, just Geeta madam, please send to them. Other faculties also, no problem. Okay, thank you. I will send in a group also that paper and poster presentation. Okay, thank you all.
Thank you.
Thank you.
Thanks a lot.
Hello, കേക്കാവോ? പ്രശാന്ത് sir? Okay, പ്രശാന്ത് sir, കേക്കാവോ? Hello. എല്ലാവർക്കും കേക്കാവോ? അങ്ങോട്ട് പറഞ്ഞ കേക്കാവോ? Okay. ഹലോ, പ്രശാന്ത് സാർ കയറിയല്ലേ? ആ, പ്രശാന്ത് സാർ കയറി. പ്രശാന്ത് സാർ മ്യൂട്ട് ഓഡിയോ വെച്ചിട്ടല്ലേ കയറിയത് തോന്നുന്നുണ്ട്. ഓഡിയോ കേൾക്കുന്നില്ല പ്രശാന്ത് സാറിൻ്റെ. ഗീത മേഡം ഉണ്ടോ? ഓക്കെ. ഹലോ, ഗീത മേഡം.
ഹലോ, ഞാനുണ്ട്.
ഓക്കെ, ഗീത മേഡം ഉണ്ട്. പിന്നെ വേറെ ആരെങ്കിലും ഉണ്ടോ? പ്രശാന്ത് കെ സർ ഉണ്ടോ? മാഡം, ആതിര മാഡത്തിന് എമർജൻസി ആയിട്ട് ആതിര മാഡം ഇല്ല തോന്നുന്നുണ്ട്. ജഡ്ജസായിട്ട് ഗീത മാഡം ആണുള്ളത്.
ഡോക്ടർ രേഖ ഉണ്ട് കേട്ടോ.
രേഖ മാഡം ഉണ്ട്. രേഖഹരി മാഡം ഉണ്ട് അല്ലേ? ഓക്കെ. അപ്പോൾ നമുക്ക് തുടങ്ങല്ലേ എന്നാല്? എല്ലാവരും കയറിയോ? ഞാനൊന്ന് പേര് വായിക്കാം. ജസ്റ്റ് ആരൊക്കെ ഉള്ളതെന്നുള്ളതിൻ്റെ ഒരു പേര് വാങ്ങിക്കാം. അൽഖ രാജൻ. ഓക്കെ. അനുജ ബിജു. അനുജ, ഡോക്ടർ അനുജ. ഡോക്ടർ ആയിഷ. ഡോക്ടർ ഗായത്രി. ഓക്കെ. ഡോക്ടർ പ്രേംജിത്ത് ടി പി. ഡോക്ടർ രോഹൻ രാജ് ഉണ്ടോ? ഓക്കെ. ഷിബിൻ അലക്സാണ്ടർ. എല്ലാവരും അൺമ്യൂട്ട് ചെയ്തിട്ടൊന്ന് പറയണേ. ഷിബിൻ അലക്സാണ്ടർ. പേപ്പർ 2 പേരാണ്, ഡോക്ടർ ആയിഷ ആൻഡ് ഡോക്ടർ മനു. ഉണ്ടോ? അക്സെപ്റ്റ് ചെയ്യണേ. ഡോക്ടർ മനു, ഡോക്ടർ ആയിഷ ഉണ്ടല്ലോ അല്ലേ? ഓക്കെ. പ്രശാന്ത് സാറേ, നമുക്ക് സ്റ്റാർട്ട് ചെയ്യല്ലേ?
Yes, we can start.
Okay. First we can start the paper presentation. Madam, you can start, no problem. You can carry on this. I will call Dr. Aisha to present the paper.
ആയിഷ ആണോ അൽഹാണോ?
ആയിഷ, ഡോക്ടർ ആയിഷ എന്നാണ് എനിക്ക് പ്രശാന്ത് സാർ അയച്ചു തന്നത്.
Okay.
Okay.
All the presenters may switch on their video.
Okay. ഡോക്ടർ ആയിഷ ഇല്ലേ? ഡോക്ടർ ആയിഷ. ആയിഷ നേരത്തെ ഉണ്ടായിരുന്നല്ലോ.
പേപ്പർ അല്ലേ, പോസ്റ്റർ അല്ലല്ലോ?
പേപ്പർ.
Okay.
Aisha is presenting both, I think.
Okay, fine.
ഓക്കെ. എല്ലാവരും നല്ല നെറ്റുള്ള സ്ഥലത്ത് ഇരിക്കണേ, അല്ലെങ്കിൽ കേൾക്കുമ്പോൾ കട്ടായി വരും. ഓക്കെ. അപ്പോൾ ഫസ്റ്റ് വി ക്യാൻ.
Others may please mute also.
Okay.
Also not present.
Yes. And we can start the paper presentation. Dr. Manu Matthew, you can start. You can share the slide. Manu Matthew ഇതിലില്ലേ?
ഉണ്ട്.
Okay. Okay. Share the slides.
Manu, you have to share your slide.
Okay.
Are you seeing a button on the
screen share എന്ന് കാണുന്നില്ലേ?
There is a screen share.
ആ സ്ക്രീൻ ഷെയർ ഞെക്കുമ്പോൾ ഷെയർ ചെയ്യാൻ പറ്റും. എന്നിട്ട് പ്രസന്റേഷൻ ഓൺ ആക്കിയാൽ മതി.
ഷെയർ നിൽക്കുമ്പോൾ വരുന്നില്ല.
No. Keep your PowerPoint open.
Keep your PowerPoint presentation open. Minimize it.
Then
and
you
click on the share. You will find your desktop. And then you will find many small screens on that. അത് നിങ്ങളുടെ PowerPoint presentation click ചെയ്താൽ വരും. ചെയ്യാൻ പറ്റില്ലെങ്കിൽ if you can video call, we can help you.
ചെയ്യാൻ പറ്റുന്നില്ല.
Could you just video call one of your friends or Dr. Prashant or one of the organizers? Let us show your screen. They'll help you do it. ഈ സ്ക്രീനിൽ താഴെ ഒരു ഷെയർ കാണുന്നുണ്ടോ? ഒരു ഗ്രീൻ ബട്ടൺ ആയിട്ടൊരു ഷെയർ കാണുന്നുണ്ടോ? അത് ക്ലിക്ക് ചെയ്യുമ്പോൾ എന്താ വരുന്നത്? യു ആർ മ്യൂട്ടഡ്. ഇത് ക്ലിക്ക് ചെയ്യുമ്പോൾ എന്താ കാണുന്നത്? Okay, so then you're not being allowed.
ഒരു മിനിറ്റ് സാറേ.
I think
ഒരു മിനിറ്റ് സാർ, ശരിയാക്കാം, അവിടെ ശരിയാക്കാം.
Nitesh.
സാർ ഒന്ന് ട്രൈ ചെയ്ത് നോക്കൂ.
Constipation is a frequently encountered problem in a pediatric group. There is a very little Indian data on the clinical profile of childhood functional constipation, diagnosed as per Indian criteria proposed by the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition. So the objective of this study is to study the demographic, psychosocial and clinical profile of functional constipation in children. And the method was, it is a cross-sectional study, was performed in tertiary care hospitals to assess demographic and clinical profile of functional constipation among children 2 to 12 years using Heptagon diagnostic criteria. All patients were subjected to detailed clinical history, thorough physical examination, and basic evaluation to rule out organic etiology. So these were the results. There were almost 82 children enrolled in the study with mean age 6.72 plus or minus 2.8 standard deviation. Majority were male, almost 60% and 40.2% were female. And among the subject participants, we found out we have stool retention and painful bowel movements. And 81% of the subjects have defecation frequency less than 2 times per week. And almost 78% of the subjects have fecal impaction. And large diameter stool that obstruct the toilet account for 35.4%. These were the various symptoms that is noticed in the subject. The mean duration of the symptoms that lasted for 33 months with a deviation of 18 months. Abdominal pain that accounts for 32.9%. Among the subject participants, 29.3% is taking adequate amount of dietary fibers, whereas 62% is having inadequate physical activity. And among them is 61% there is a premature toilet training. Toilet training started before the age of 1 year. And 24.39% have temper tantrum. And 7% have family issue. And almost 51.2% of the subject participants have absenteeism in the school, which is directly attributed to constipation, abdominal pain, and fecal incontinence. 78% having fecal impaction, and the 73% of the subjects had received different laxatives other than polyethylene glycol for variable duration. So there is almost a diagnostic delay of almost 33 months that points to the lack of awareness among the practicing pediatrician to diagnose the functional constipation in a timely manner. The majority of the children that were studied were aged above 5 years. Children below the 2 years of age are not considered because the number of organic causes in this age group is high. So conclusion, functional constipation is a major cause for abdominal pain in children and it is often overlooked. It is not attributing pain to constipation may delay the diagnosis which have poorer prognosis. A substantial proportion with functional constipation has fecal impaction upon diagnosis, which has management implications.
Thank you, Dr. Manu. It's a nice study. I just wanted to know your age group is 2 to 12 years of age. And you said a significant amount of the children had years of age. So since majority of the children were aged 5 years and above, and the duration of symptoms only 33 months, how do you attribute that toilet training for 70% of them was, or 60 to 70% was below, was there in many of these children, but onset of constipation is after 5 years of age?
Premature training of premature toilet training will affect the one of the factor that is affecting functional constipation. Premature training less than 2 years of age is usually associated with functional constipation. Among the subject participants that is having the found to have this functional constipation, we have found out that a large proportion is having a premature toilet training that's less than 1%.
So since there are many of them are school going, one thing that you can also consider in your future analysis is whether school going time has an impact on constipation, because many of these children, when they start school, they're okay during the holidays. But the moment they start school, that routine can get varied. So therefore, that can be there. What about you said that about 29% of children had low fiber in their diet, or only 29% had good fiber in their diet. Am I wrong?
Only 29% is having adequate amount of fibers included in the diet. The majority were not having such diet.
What would you say is adequate fiber in your diet?
5 gram per day is the recommended dietary recommendation.
All right, thank you. Thank you, Dr. Manu. Next presenter.
Next presenter, Dr. Aisha for paper presentation. Share on the exit. Okay, Aisha, you can share now.
Okay, sir. Dr. Manu was also paper?
Manu was also paper.
Paper.
Manu and people are in paper. Okay.
Yeah.
You can start.
Good evening, all. Today, I'm going to present my paper on the topic Unraveling Genetics in Cholestasis, a case series. Cholestasis is characterized by impaired bile flow resulting from various etiologies, including genetic disorders. Identifying these genetic causes is crucial for diagnosis management as well as genetic counseling. In our study, we explored the various genetic etiologies of cholestasis in a cohort of patients, emphasizing the clinical diversity and implications. So coming to the methods, we did a retrospective chart review at a gastroenterology clinic of a tertiary healthcare center in Kerala. Results were we had 20 patients with genetic causes, among which 11 patients were having PFIC, and 5 patients with Alagili syndrome, 2 patients with Dubin-Johnson syndrome, 1 patient with Niemann-Pick C. Coming to the breakup of PFIC, we had 1 patient with ATP8B1 mutation with PFIC1, and 1 patient with ABCB11 gene mutation, that is PFIC2, with PFIC3, that is ABCB4 gene mutation, and 2 patients with PFIC4, that is tight junction protein 2 mutation, and 1 patient each of PFIC7 and PFIC12, that is corresponding to USP53 and VPS33B genes mutation, which were very rare. And we had both JAG1 as well as Notch2 mutation in Alagili syndrome. A study found that 60% were females and 40% were males. And we had positive family history in 15% of cases, that was in PFIC2 and Dubin-Johnson syndrome. And mortality was found in 20% cases, 1 each of PFIC2, PFIC3, Niemann-Pick C, and Alagili syndrome. Coming to the clinical case discussion. So this is a first patient, infant, who presented with jaundice and intermittently pale colored stools, and he was born to consanguineous parents, and he also had history of pancreatitis, and genetic study proved ATP8B1 mutation corresponding to PFIC1, which can have extrahepatic manifestations like recurrent pancreatitis and hearing loss. So this is our next patient who presented in the early infancy itself with the neonatal cholestasis. These patients came very early because they were already aware of the condition because the previous sibling was affected with a similar presentation. And we counseled them. We did a genetic study and it was corresponding to PFIC2. And liver transplantation was advised, but due to financial constraints, they couldn't go ahead. And this is the condition at 1 year of age. The child had massive hepatosplenomegaly with ascites and finally succumbed to death at 1 year of age. So an important feature about this case was during genetic study, there was an STR analysis was done and there was a suspicion and they did a karyotypy and they found to have a triple X, 3X chromosome in the karyotypy. So it is a combination of PFIC2 with triple X syndrome, and PFIC2 has got the worst prognosis. And this is the Next patient, she's a 15-year-old girl with cholestasis since infancy, have undergone laparotomy, and she continued to have, now she's 15 years old, and she continues to have severe pruritus and massive hepatosplenomegaly. And she also had extensive psoriasis with psoriatic arthropathy, and she was diagnosed with PFIC 4. She also had hypogonadism and intellectual disability. So this is our next patient. Actually, he's a young male. He's 22 years. He was in the follow-up as a case of cholestasis during infancy, later lost for follow-up, and he presented at 22 years of age with mild jaundice and with intractable pruritus, even with suicidal ideation out of this pruritus. And his genetic study found to have, and liver transplantation, it may be necessary for some. And Alagali syndrome, it can be mistaken for biliary atresia due to this high GGT, and also in some cases they can be atretic gallbladder and also associated congenital heart disease. So my recommendation is further research is needed to explore the underlying mechanisms of these genetic mutation and to develop targeted therapies. Thank you.
Thank you, Dr. Aisha. So that was a good collection of cholestatic patients. May I ask, what was the treatment given to the PFIC patients? You said one patient died, but what about the rest of the patients? How are you managing them for the present?
We were managing with vitamin supplements, that is fat-soluble vitamin supplements were given. For intractable pruritus, there are newer options that we have tried antihistamines, and one patient was with rifampicin.
Okay, and how many of these patients did you do a bile acid?
Transplantation was done in one patient.
Which was done in one patient?
A liver transplantation in one patient.
So was there any bile acid levels done in these patients?
This was not done in this patient.
And any child subjected to biliary diversion surgeries?
We have advised biliary diversion surgery with kids with intense pruritus, but they haven't undergone.
Okay, maybe not doing in your setup. Thank you, Dr. Aisha.
Thank you, ma'am.
Thank you, Aisha. Next, we can go to poster presentation. First, I will invite Dr. Alkan Rajan to present. Dr. Alkan Rajan.
Yes, sir.
Rajan.
Yes, sir.
Please share the presentation.
Shall I start, sir?
Yeah, you can start.
Good evening, everyone. Respected faculties, I'll be presenting a case report of food protein-induced enterocolitis syndrome. So this is about a case of an 8-week-old male infant who was referred to us with a history of chronic diarrhea, loose watery stools without blood, and failure to gain weight. The birth weight weighing 3.3 gram and weight at presentation is 3.4 gram. On reviewing his history, this baby was presented on postnatal day 54 with history of vomiting and diarrhea, leading to hypovolemic shock and profound metabolic acidosis. He was subsequently found to have severe methemoglobinemia, acidosis, and shock, and this was improved with fluid resuscitation and antibiotics. An extensive workup, including evaluations for infectious and metabolic etiologies, was unremarkable. However, a detailed dietary history revealed a change in diet, that is breastfed and cow's milk-based formula from postnatal day 8, which was changed to soy-based formula subsequently, supporting a diagnosis of food protein-induced enterocolitis syndrome. The infant was started on extensively hydrolyzed formula and discharged home with follow-up appointments. However, he did not show symptomatic improvement or gain weight. Hence, he was started on amino acid-based formula from 9 weeks of age. At the time of his follow-up, roughly 8 weeks after the discharge, he was continuing to do well on amino acid-based formula, and height has improved to 5.4 grams. So this was the nutritional status, initially breastfed and formula fed, And suspecting lactose intolerance, first we gave lactose-free formula or soy milk, and later changed to the feed was kanji water, but suspecting carbohydrate intolerance, later extensively hydrolyzed formula was fed, and no improvement, and later amino acid based formula was started. This towards the right side is the weight gain you can see in the growth chart. So food protein induced enterocolitis is a rare or severe form of non-IG mediated food allergy that can present in infancy with predominant gastrointestinal signs and profound dehydration. It has two varieties, acute and chronic. In acute, the acute and delayed repetitive vomiting is the hallmark, and diarrhea in some patients. And the most important concern is about the dehydration. In chronic FPIES, the diagnosis is considered if there is intermittent but progressive vomiting and diarrhea in an infant, particularly infants on regular cow's milk or soy formula. The poor weight gain and possibly failure to thrive, particularly in very young infants, is seen. If severe symptoms can lead to dehydration and even metabolic acidosis. The conclusion is that it is important to consider the possibility of FIES in an infant with vomiting and diarrhea in the setting of recent dietary change leading to profound dehydration, metabolic acidosis, and methemoglobinemia.
Thank you, Dr. Alka. So you were mentioning from day 8, child was on a particular formula. What formula was that?
Yes, madam. Since day 8, the patient was admitted with ADD, so he was started on a soy-based formula.
No. In your fourth bullet point, from postnatal day 8, child was on a breast fed and cow milk based formula. Is that what you're saying?
Yes.
So when was the change to soy based formula done?
First it was just the formula fed. Later it was changed to soy based formula.
And subsequently, how many days later the child presented to you? Because the child is now 8 weeks. Or from that point of time, child has been having diarrhea, is it?
Yes. Initially presented with diarrhea and was treated on OPD basis, but since diarrhea was not subsiding, he was admitted and evaluated.
Okay. So this is a good case for pediatricians to understand that there is a condition wherein you can get allergy to multiple foods, including rice. So what is the long-term plan for this child? How long are we going to keep him on amino acid formula?
Madam, the importance is that we should there should be avoidance of whatever the trigger.
Sorry, I didn't get you. Avoidance of?
For lifelong, they should not be whatever the trigger in case this in this case it was the soy based formula and the carbohydrate, so it shouldn't be for lifelong.
Okay, so not lifelong. You can reintroduce it after the child is a year or 2 years of age, because it's even though it's said by IG mediated, after some time the gut matures and they can handle it, because it's difficult to say that lifelong they cannot take rice at all. Even soya is possible, but for a South Indian to say that you cannot take any rice based dishes, it's unusual. So usually FPIES is typically found in infant age group. It's usually not seen in older children, but they grow out of it. But it cannot be introduced for the next 6 months or till the child is 1 year of age. All right, thank you, Dr. Alka.
Thank you.
Next, I would like to invite Dr. Anuja Biju. Dr. Anuja Biju, you can share your slides. Anujanda, another next person, Dr. Aisha, you can present the poster.
Okay. Good evening. My poster is on the topic, A Teen's Journey from Pigmentation to Polyps, a spotlight on Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome, it is a rare autosomal dominant genetic disorder which is characterized by gastrointestinal hamartomatous polyps, mucocutaneous pigmentation, and increased risk of malignancy.
tissue glutaminase levels to look at the compliance to gluten-free diet. Can monitor the
All right, thank you.
child every 6 months levels to come back to.
Okay, thank you, Anuja. Next, I invite Dr. Rohan Raj to present the poster. Rohan Raj. Rohan Raj.
You stop sharing, Anuja.
Anuja,
Stop sharing the slide.
Anuja, stop sharing slide. Okay. Rohan Raj,
Rohan,
you can share. Rohan Raj. And unmute your Zoom. Rohan Raj.
Yes, sir.
Yes. You can share the
think,
slide.
Yes, sir.
Unmute yourself, please, and please share your slides.
The network seems to be
You can close your video also. Just put your audio.
വീഡിയോ ക്ലോസ് ചെയ്യുക. എല്ലാവരും നെറ്റ്വർക്ക് ഒക്കെ
close
നല്ല സ്ഥലത്ത് വേണം നിൽക്കാൻ ഇങ്ങനെ പ്രസന്റേഷൻ ചെയ്യുമ്പോൾ. Share your slide.
Are you able to share, Dr. Rohan? You can keep your audio on.
രോഹൻ രാജ് കേൾക്കുന്നുണ്ടോ?
Rohan, is it audible? Or Premjit is ready now? Premjit?
Sir, I can try.
You have set everything ready?
Yeah.
Then you try.
1 minute, ma'am. Just.
Rohan has.
Rohan is sharing now. You can present, I think. Rohan, you can start.
Good evening, all. I'll be presenting a case report on neonatal presentation of Dubin-Johnson syndrome. Introduction. Dubin-Johnson syndrome is a rare autosomal recessive genetic disease caused by mutation in the ABCC2 gene that codes for bilirubin transporter MRP2, multi-drug resistant protein 2. So bilirubin binds with albumin and is carried into the hepatocyte using a carrier protein. Inside hepatocyte, the bilirubin gets conjugated and then is excreted in the biliary tract through the MRP2 receptors. So here in Dubin-Johnson syndrome, MRP2 receptor is affected, so it is an excretory defect. So there will be increase in conjugated hyperbilirubin. So Dubin-Johnson syndrome is characterized by recurrent episodes of jaundice and conjugated hyperbilirubinemia. Most of these studies on Dubin-Johnson syndrome includes children and adults. However, neonatal onset Dubin-Johnson syndrome was rarely reported in only few case reports and small case series. Here I present a case of a 1-month-old infant with neonatal onset congenital hyperbilirubinemia who was diagnosed with Dubin-Johnson syndrome. Case presentation. A 31-day-old male child, second child of non-consanguineous marriage, with developmentally normal, immunized for age, with history of neonatal jaundice requiring phototherapy for 4 days, presented with persistent yellowish discoloration of eyes since early neonatal period, and it was associated with high-colored urine and ambiguous stool. On examination, child was icteric with no pallor. There was soft hepatomegaly, 2 cm below right costal margin, soft margin, and no splenomegaly. Investigation showed increased serum bilirubin with conjugated hyperbilirubinemia, normal GGT, normal OTPT and ALP level. There was elevated bile acids. Fasting ultrasound was done, which was normal. And genetic testing showed ABCC2 live disease. So discussion, clinical presentation of Dubin Dubin-Johnson syndrome as a neonatal cholestasis is rare. However, our studies show that the Dubin-Johnson syndrome is of neonatal cholestasis. So this case report illustrates GGT neonatal cholestasis. Thank you.
Thank you, Dr. Rohan. My question is, what would you advise this patient for the future? I mean, how will you prognosticate? The child has had a jaundice. So what will you tell the parent about the chances of recurrence of the jaundice or the implications of this jaundice?
Sorry, ma'am?
What advice will you give to the parents regarding this jaundice? Is
Sorry,
it going
ma'am, I
to
couldn't hear you.
recur in the future?
Hello?
Or can you hear?
Yeah, yeah, I can hear you, ma'am. Ma'am, there can be recurrent episodes of jaundice with infection, or if a female child, if she is taking OCP pills, there can be a chance of recurrence of jaundice at present. So, and there is no.
Yeah, but then you have to ask them to avoid hepatotoxic drugs in future that can aggravate the morbidity. All right. Thank you. Thank you, Dr. Rohan.
Okay. Next, I would like to invite Dr. Premjit TP.
Yes, ma'am.
Stop sharing, Rohan.
Stop sharing, Rohan. And Premjit, you can share your slide. And after, before starting the presentation, you can off your video because all are you're sitting is poor net connection area. Okay? Premjit, you can start. You can share.
Rohan, you can stop sharing.
Okay.
You can start sharing.
Yes.
Good.
Okay, good.
Good evening, madam. I'll be presenting a topic.
Slideshow format.
It's okay, we can.
Slideshow. Premjit, that rose bar, you can see one slideshow button. You can just press it.
I think he's pressed it already.
Okay, you can present.
Okay, you try presenting.
That's okay, present, it's okay.
I will be presenting a post-round liver transplantation for type 1 hyperoxaluria. Introduction. Primary hyperoxaluria type 1 is an autosomal recessive disease.
Slide is not changing. Slide change.
Caused by the functional defect in alanine glyoxylate aminotransferase that result in overproduction of oxalate. Primary oxaluria type 1 is characterized by hepatic overproduction of oxalate, which is often leading to kidney failure. Kidney liver transplantation is recommended. Either combined kidney liver transplantation or sequentially performed kidney liver transplantation is done. Child showed a homozygous mutation AGST gene, which is pathologically cleansing the diagnosis of primary hyperoxaluria type 1. She had a stable kidney disease with a creatinine of 0.4 and glomerular filtration rate of 79. In view of multiple urological interventions at a very young age and considering the potential for progression to chronic kidney disease and end-stage renal disease, she was underwent preemptive liver transplantation. It is a X-ray showing left is diagonal calculus, and it is the genetic report of the child. It is showing AGST gene mutation. Discussion. Liver transplantation is recommended in primary oxaluria type 1, either combined or sequentially performed. The merit of SLKT and in the place of an isolated kidney transplant, the selected patient is unsettled.
Preemptive liver transplantation were not widely performed, but case series reported very high patient survival rate up to 100% after 10 years of follow-up. Coming to conclusion, this case report illustrates the role of preemptive liver transplantation as another transplant strategy in primary hyperoxaluria type 1. Thank you, ma'am.
Dr. Premjit, what is preemptive liver transplantation?
Preemptive transplantation means we are for like this case, a young child with normal kidney function, that this child didn't have that much oxalate deposition in kidney. We can transplant a liver, and which will avoid the further oxalate deposition in kidney.
So when will you decide to do combined?
Combined is the child already had some oxalate deposition and worsening of EGFR. We usually go for combined kidney transplantation.
Okay, good. So even before the kidney becomes damaged, if you're doing transplantation, it's called preemptive. That is, you're transplanting a normal liver. But because the hyperoxaluria occurs due to enzyme deficiency in the liver, you are transplanting the liver to prevent further damage to the kidney. All right. Thank you.
Yes, ma'am.
Can we go to the next case?
Yes, thank you, Dr. Premjit. Next, we can go to, okay, Dr. Shibin Alexander. You can share the slides. Shibin. You can share the slide. Okay.
Good morning, dear faculties and my dear friends. So I'm going to present a rare cause of cholestatic liver disease. Hello.
Okay.
Am I audible, sir?
Yeah, now you are audible and you are, okay, you can start.
Sure, possible.
But slideshow also.
Or else just
yes. Okay, you can start.
Okay. Good evening. Post-cortex and splenomegaly, it's about 13.1 centimeter. During evaluation for fever and abdominal pain weeks earlier, there was no history of jaundice or upper GI bleed. There is no history of CLD. On examination, the patient had no pallor or icterus. The weight of the child was 19.9 kg. The height was 117.5 centimeters, approximately the 50th percentile. On perabdominal examination, liver was just palpable, 2 centimeters under the right costal margin. Splenomegaly was present. On evaluation, HB was 13.1. Total leukocyte count was 5,610. There was thrombocytopenia. Platelet was 95,000. ESR was 22. Peripheral smear thrombocytopenia. Total bilirubin, direct bilirubin was 1.6 and 0.5. Total protein albumin was 6.8 and 3.2. OTPT was 127.93. ALP was elevated 579. GGT was elevated 374. PTNR1 and IgG showed 20. And shear wave elastography was done for this child. It was coming to 7.88 kilopascal, which corresponds to F1 metabolic score. And autoimmune panel was also done, which came to be positive in 1:100 dilution. Done a liver biopsy for this child. It showed chronic biliary pathology with increased fibrosis, and no changes of autoimmune hepatitis were there. Genetic testing done for this child showed homozygous pathogenic mutation in the PIT gene, pinching the diagnosis of progressive familial intrahepatic cholestasis type 8. This was confirmed with parental segregation analysis. His bile acids were estimated, and this was also found to be elevated. This was confirmed with parental segregation analysis. He's on ursodeoxycholic acid and fat-soluble vitamin supplements, and he's on follow-up of 24 months without features of end-stage liver disease. And here, this is the genetic study, next generation sequencing came positive for PIT mutation. This autosomal recessive condition, pathogenic variant. Discussion. This is the first reported case of PIT mutation in Kerala. Early onset recurrent cholestasis, pruritus, option for liver transplantation.
So the ultimate treatment will still be liver transplantation.
Liver transplantation. We can support the patient with ursodeoxycholic acid polyeretics, antihistamines like supportive management, and final treatment option is liver transplantation.
All right, thank you.
Thank you, Dr. Shibin, and thank you, our judges, respected Dr. Geeta Madam and Dr. Rega Harris Madam. And I would like to conclude. I would like to invite Dr. Prashant sir to conclude the poster and paper presentation. Handing over to.
All the presenters can leave now. All the presenters may kindly log out.